morning. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. We are starting the third day of the World Congress, 14th World Congress of WAPR. Actually, we had two lengthy days yesterday, and today also we'll have another lengthy day, but not that lengthy as yesterday and the day before yesterday. The idea behind this World Congress is that we are having so many perspectives to cover. It's also a worldwide participation. So we have 42 countries sharing in this Congress, and more than 200 speakers sharing in this, with more than 135 titles for scientific sessions. Till yesterday, the number of people who are registered online are 4,700, and people who are registered physically are 700. It's a great issue to have similar World Congress, and this is the first one in the Middle East to be hosted. So we have to be proud of this. I'm proud of you who are courageous enough to come and attend physically, because I think there are lots of people who are addicted to the screen, so they are so near to the venue, but they still follow up through virtual platform. They are a few kilometers away, and they are sitting in front of the screen instead of coming. While there are lots of people who are coming from various countries, and also from other Emirates. We have many great friends and colleagues coming from Al Ain, from Dubai, from Ras Al Khaimah, from even GCC, and from Dubai, of course. So we are really proud of your participation, and your interaction to the last moment is the fuel for the success of any Congress. So I'm proud of all of you, dear friends, and I'm really thankful for all of you who actively participated with us. Now it's the time for the first keynote. It's live, and we have two speakers. It's about mental health reform in Belgium and a public health perspective. First speaker, ladies first, Sarah Morsing. Expert mental health reform, PhD. She is Federal Public Health Service, Food Chain Safety and Environment, and Mental Health. She has a Master of Clinical Psychology and Master of Theory and Research in Psychology. The other speaker is Professor Bernard Jacob. He is the Federal Coordinator of the Belgian Mental Health Care Reforms, and is active in the field of mental health and social welfare for more than 30 years. He's the project manager and national coordinator of the mental health care and psychiatry reform for adults and the new mental health policy for children and adolescents. He ensures the coordination of the global elaboration plan in connection with the various levels of decision and organization, and the competencies of the regions, communities, and National Insurance Institute of Disease and Disability. He has also an important experience in the management and monitoring of European issues. So please share with me, welcoming both speakers, and they are sharing with us live.
Hi, everybody. Thank you to invite us to present the mental health reform in Belgium. I'm Bernard Jacob. I'm a federal coordinator from the mental health reform in Belgium since 12 years. And I would like direct to introduce my colleague, Sarah Morsing. She's clinical psychologist, PhD. She's really an expert of the mental health reform in Belgium, and she will present the most important topic from our reform in half an hour. And after, if there are questions, of course, we can have this discussion together. So please, Sarah, you have the floor.
Thank you, Bernard. Good morning, everyone. It's really morning here in Belgium. It's 6 o'clock. So, well, thank you for everyone joining live or online. And let's get started. I will give a short presentation on the mental health reform in Belgium from a public health perspective. So before I begin, I have to take a step back and tell you a little bit about the origins of the mental health reform in Belgium. So it already started more than 10 years ago, and it was and is a cultural revolution and evolution of mental health in Belgium, where we really try to apply a mental health in all policy, meaning that all domains or all policies are really joined together to work around mental health. And the large idea of the Belgian mental health reform is to transform part of the residential offer, because in Belgium there was, before this date, a heavily reliance on institutional care in mental health. So the idea was to transform part of this offer to a community-based offer. So let's say a balanced MH model based on institutions partly, but also for a larger part, community. And a very important other aspect is the participation of users and family representatives. If you'd like to know more about this earlier part of the mental health reform, I'd advise you to go to our website, C107.E. Unfortunately, I don't have time to really go into details about this. I just want to say that one of the very important vehicles of our reform are the networks, and those cover, those regionally cover the whole of Belgium, and they are networks of collaborations between structures and resources of that region that co-organize, co-structure mental health care in their region with the same principles that I just explained. And their greater goal is to align the needs of this region with the existing offer. But what will be my main focus of today's plenary session is this next step that we are currently in the middle of. And that is that during COVID, there was a silver lining. We got the attention of policymakers and also a budget for a coordinated approach to strengthen the psychological care offer. Because, well, it was seen, of course, that because of COVID, mental health was particularly attacked for the whole population, and in particular for certain targeted groups that were most affected. And so this budget, this new step, is really a next step in the reform in mental health care to further develop the offer with the same principles, really focused on primary care, on this whole population approach. So this will be the main focus of my presentation today. So what I'm going to try to do really shortly, let's see if I succeed, is take some key concepts of public mental health and also the quintuple aim, and introduce to you some of the ways that we try to translate this in Belgium. So this is also part, I guess, of a changing culture where mental health is no longer seen as something that is exclusively for people with very severe or chronic problems that should be treated in institutions. But mental health and mental health care accordingly is much broader than that, as also WHO mentions in their definition. It's a state of well-being. So that implicates that also people who are at risk or have mild to moderate ill health or problems are also part and should be focalized in mental health care. So this is really, I think, the start of this cultural revolution, thinking about a whole population that we should focus on. So the public mental health approach, I'm really, to keep it short, I'm going to focus on this graph by Turnikov and Tanzala, who have kind of these key points of the public health approach. And I'm going to just take some of the most important ones and see how we did this next step in the Belgian mental health report. First of all, it's the whole population approach that's really key. And for that, we use the WHO optimal mix of services. The key is really, if you start from a whole population approach, that you do this demand driven, so based on the needs and not based on what is already there and the offer of institutions that's already there. And then for this, you can see, I'm sure you already saw it before, this triangle that represents the needs, the percentage or the frequency of needs of people. And you see that most of them, most of the people, well, they either don't have a need, they don't experience mental health issues, which is great, but a large part of the population does experience mild to moderate ill health or mental health problems. A relatively smaller part has more severe problems, and a very tiny part in comparison experience chronic and severe mental ill health or psychiatric disorders. And so WHO says that based on the frequency of needs that I just explained, you should also organize your care. So there should be a relatively larger part of care that's dedicated to people with mild to moderate symptoms in comparison to those with severe or chronic problems, although also this group is of course important and needs adequate care. So this is really the idea of, on an organizational level, having stepped care, so different kind of care according to the needs and intensity of this care, to achieve on an individual level matched care, to make sure that each individual has appropriate care. And if we translate this to Belgium, we of course see the same prevalences of mental ill health and mental disorders as the WHO triangle. So I'm sorry, I represented here the WHO triangle as a translation to Belgium, and you see that's still in Dutch, but I think it's still useful to show that we have the same, of course, repartition, and that we should also have the same model to organize our mental health care. So as I already told you, Belgium was, before the mental health research, mainly the institutional-based offer. So what we wanted to do, and gradually, of course, in the mental health reform, we started to change that. But with this newest step, we're really focusing on the basis of the pyramid, so the light to moderate psychological problems, ill health, and so accordingly organize care that is low intensity, that is short, that is general, not too specialized, and that's focused in primary care. And with that, we want to meet the needs of 80% of the whole population, focused on prevention, early intervention, and detection. And very short, I'm going to touch upon the concepts of undermet and overmet needs, meaning that if you don't have this basis, which in Belgium is not really as strong as it should be, then a whole lot of people with mild to moderate symptoms, they cannot find adequate care because it's not there. So they will either wait until their problems become more severe, or they will find help that's not adequate and that's too specialized, too intensive for them. That's so overmet needs. So this undermet and overmet needs is not only clinically, but also in cost effectiveness on the whole system, not a very good situation. So we're trying really to focus on this mild to moderate group. Another key concept is of mental health, the mental health approach, is that we see individuals in their context, and we try to do that by focusing on most vulnerable target group that were most affected by COVID. And another way we try to look at individuals in their context is by outreaching into their community. So really where they are, we're going to try to establish an offer there. So based on their needs of a certain target group in a specific region, because that, of course, it differs from region to region, and make sure that we find those people and organize care where they are, so that the threshold is really low in for them to find care. Another important concept is the population-based intervention. So we're not only trying to focus on mild to moderate problems and vulnerable groups, but we're trying to do organize our care that's focused on prevention and promotion via population-based intervention, so group treatments. This is not only cost-effective, it's as effective also as individual intervention, and it has added clinical value where you can learn from each other, where there is this support around you. And within this, and this is something we always try to do in the whole mental health reform, we try to value the expertise and participations of users and family representatives, not only in organization of this new step, so they're really at the table and thinking with us, but also on the clinical level, and that's something we call task shifting, so that we're next to other professionals such as clinical psychologists. We really value the expertise of users and families, so to co-create and collaborate in group interventions as well. Another concept is the importance to look at service components in a whole system of mental health. And first, we translated this to local multidisciplinary collaboration. That is really a key in this new step. Why? Because needs are multifactorial, so we cannot answer, even when it's a mild to moderate need, we cannot answer that with just a mental health offer. For example, these people often have physical problems, sleeping problems, stress problems that they can feel in their body. So we really need this multidisciplinary offer, not to offer a big team for every patient that's there, but so that the team works together and can create for each individual separately the best team, the best way of referring, and the best sharing of expertise. Also, population management is very important on the local level for us, and that's why I told you about the networks at the beginning, but we also go to a level that's even lower than that, to really align the needs of vulnerable groups in a certain region to develop an offer for them. So we really give a lot of responsibility to networks and other local structures. And again, we try to always do this in outreaching towards the community. So here's just a brief figure that kind of represents the WHO triangle, where you go from people that have mild problems to those with severe, and then you see the offer. So a whole lot of people, they don't need professional help, but they have enough with self-care and informal support. But when that's not enough, there should be an offer that's outreaching towards these people, but from primary care to start with. For example, a pharmacist, a GP, a psychologist, a primary care psychologist, a physiotherapist, a street worker, and so on. If that's not enough, then there should be an upgrade in intensity of care towards specialized caregivers, so as psychiatrists, specialized psychologists, care, crisis teams, and so on. And then for this very small part of the population, intensive care is needed for a part of their life. And so this just to show you how important multidisciplinary and integrated care is for us. In each level, you have, of course, people working together in teams. You have neighborhood teams in primary care and local multidisciplinary specialized teams in specialized care. And it's very important that all of them are connected. on the different levels, micro, meso, and macro level as well. And I've highlighted some of the people that you see in red just to show you that for one particular clinical patient, it's not necessary that everyone is there and everyone works together, but you have to have these teams to be very dynamically able to refer, to collaborate when needed. So this is really the heart of our new step in the mental health reform. And also the care, the psychological care that we're introducing and reimbursing or financing now with this new budget is really explicitly in this whole system of collaboration, where we introduce the primary psychological care function. So that's a low intensity or short period of time intervention that's aimed at prevention, promotion, early detection, reinforcing of capacities of the patient and family, assessment and orientation. And so they're embedded in these neighborhood teams. And then you have the specialized psychological care function that has moderate intensity, that's more specialized in the audience that they have, in the approach and the expertise, and it's really aimed at treatment, whereas the other is more intervention or orientation based. So these are two functions that we're trying to reimburse with, of course, clinical psychologists and orthopedagogues, but also other important professionals such as GPs and patient and family representatives. And those two functions, we will offer them not in sort of mixed methods, depending on what the patient wants, face-to-face, online, individual or in group, with a preference for group, of course, and also outreaching into the community where the preference lies, or if needed, also in the private practice. So a short word on the quintuple aim, that's based on not only a focus on population health perspective, also on a quality of care, the patient experience, in cost effectiveness, but also making sure that the care team has a good well-being and is taken care of, and lastly, equity and inclusion. And we try to do this by focusing to starting from the population mental health perspective, to focus on these people with mild and moderate problems in ill health, to accomplish a quality of care, because for us, qualitative care is integrated care in multidisciplinary teams, to focus on prevention and promotion and group sessions, which is most cost effective, to focus on vulnerable groups, to have equity and inclusion, or ensure equity and inclusion, and also multidisciplinary teams, they make sure that the well-being of a care team is better because responsibilities are shared, to have this task shifting also, and that professionals support each other in their expertise, and to offer correct reimbursement conditions. So this was very briefly what I'm trying to say. I'm just going to formulate a conclusion. So all of the public mental health, we translated this into the newest step in the Belgian mental health reform on a very practical way. So on the right, you can see again the principles that we already discussed. And the idea is that these feed into the local implementation that we're trying to accomplish. So really allowing a responsibility to the networks and other local structures to, in a certain regional area, going to target vulnerable groups within their context. And if you have these vulnerable groups, you can decide what care is appropriate, of course, while thinking about early intervention and prevention. You can see where you have to organize this kind of care. It has to be in the community where these people are often found. It has to be with certain multidisciplinary partners. And also the provider has to have a certain profile to be able to meet the needs of the vulnerable target group. So just to make this clear, I have one example. So maybe you want to find out or formulate an answer to needs in an urban area. And you can see, okay, the needs there are, for example, youth at risk for drug abuse. We also offer the networks information about precarity in their region, so which groups they might want to focus on. But on the other hand, they also have this knowledge themselves to see where the needs are and where there is not yet an answer for people with mild to moderate problems. So for example, youth at risk for drug abuse, if you target these people, then you know what kind of care you need at risk. So this is prevention and promotion. Where do you do this? Well, youth centers, for example. Which partners do you need? Not only partners of addiction to really escalate very quickly intensive care if necessary, but also leisure activities. Where do you find this youth typically, and really intervene with this non-mental health professionals as well? And also, what kind of profile of the provider would you need? Also someone who has this kind of expertise, but also someone who can act as a professional mediator. And that's a little bit about the task shifting I explained, that can support non-mental health actors or professionals in helping meet the needs of this, in this example, youth at risk. So really, public mental health for us is a way to have a deductional process in population management. And here I've very fastly named some of the opportunities where we are really basing our policy on scientific research and theories. We are focusing on an offer that is demand-driven in a prevention and early intervention, where local multidisciplinary integration is key, and we try to focus on vulnerable groups and outreaching to really meet them. Because research also shows it's not only the fact that people have to pay and that you can install reimbursement that will make them come into care more quickly. That's what we really want to do with promotion and prevention, right? Make sure that people come more quickly into care so that they can be taken care of before their problems escalate. So reimbursement is one thing to do that. Another thing is outreaching, so make sure you have a low threshold. And then I come to the second challenge first, is that research shows that those two are not the only reasons why people wait to search for care. It's also their attitude, thinking that they can do things alone, that they don't need care. And this even goes farther than stigma. It's really their own idea. And so that's a challenge. We're not really focusing on the mental health literacy for now. We have a big challenge in seeing how do we want to integrate these local neighborhood teams, knowing that these are most of the time independent professionals. It's very easy to have integration in a service in a hospital, where you have multidisciplinary teams. It's a lot harder for independent professionals in these neighborhood teams. How do we do that? So also for people listening, I'm really open for suggestions right now, or maybe via email if you have expertise in this. Also, the group interventions with patients and family experts. I mean, we have some experience in that for severe mental health problems in hospitals, for example. How do you do this with mild to moderate problems and make sure that we have a good use of the expertise of patients and families? And also monitoring of quality indicators, I think, is really key in the public mental health process. So this was really shortly my presentation or my keynote. Thank you a lot for listening. And I really hope to, since I cannot see you, to at least hear from you here during the presentation or by email after this. So thank you very much.
Thank you very much, Dr. Sarah. It's really very important topic regarding the challenges that we are facing, especially after the COVID time, and also regarding that needs in the community for our patients to reach them. This reform to have more outreach programs is very important. And to have cooperation and collaboration with the primary health care is another good chance. We here in Emirates, we are working also in some sort of a reform And I think me and Dr. Sharif and some other colleagues were discussing this plans in what is called the CRG, which is the clinical review group. So we have almost some similar way of thinking about the same way you're talking about, is having more like a hub where we can coordinate together and divide the cases according to the severity and who's to be followed up in the community, who's to be followed up in the primary health care, who are to be followed up in institutions. The institutionalization is one of the most important things that we all over the world are working for. So reducing the number of admissions to hospitals, reaching your patients in the community, reducing the difficulties that the patients are facing, using the technologies to help you to interact with your patients. Having multidisciplinary team intervention is very important. So what you highlighted is really very important, and it's very interesting to have some sort of similar ideas. I think this is a plan for most of the people who are aiming for better lifestyle and better outcome for their patients. So the floor is open for questions. Please, Dr. Mazen. Actually, we have a very tight time, so we'll have only one question, if you excuse me, because we have another talk in 9:30 here, which is 6:30 in your time.
Good morning, Dr. Sarah. Thank you so much for this comprehensive lecture. It's very nice to hear that the users and the family representative are involved in the strategies. My question is how we can engage these users and family representative in these strategies. This is the first question because of the mental health literacy and the severity of their illness and these things, and if you are targeting a specific group. And the second question, I think this reform since 2009, and it's reviewed in 2021, so it's almost more than 10 years or 11 years. How much these is the stakeholders, the users, and the family representatives that are involving or engaging in the decision of this strategy. Thank you so much.
I will. Okay. Since the beginning, 2009, we include user and family representative in all the different discussion for our reform. We begin with this idea that because we are working for user and family, we had to include and to listen to the voice from user and family. And so we decide to have a group of user and family representative to give us the recommendation during all the process, and we continue now, because now they are really included in the reality, and they receive also, they are also reimbursed, as Sarah says, in the binôme session for psychology, primary care psychology. So since this time, since the beginning, we have every 2 years, if you want, we listen to the recommendation. It's very well organized. It's really a book of recommendation to the authorities to be sure that they can understand what we are doing. We translate it. We begin to listen recommendations. They came in different groups to decide with us, and it's really a long process. And I think that it's the same for all the different levels when you organize a reform. You organize all the system. For me, I'm from the beginning in this reform as a national coordinator. I think it's really a movement together with authority, institution, professional, user and family, and of course for the last step now the collectivity. So it's a movement all together. So it's very important to have these users and family representative in our movement. It's a key point for us since the beginning.
Thank you very much, Professor Bernard and Dr. Sarah. It was a pleasure seeing you today, and we are sorry we started a bit late. That's why we didn't have more room for questions, but we're proud to see you, and thank you for sharing your experience in Belgium. And hopefully next time we'll see you face-to-face in Abu Dhabi. We'll have the pleasure to have you. Thank you very much, and see you. Have a good day.
See you.
Thank you. Bye.
Thank you. Thank you. Bye.
Thank you. Now we're moving to our next topic, which is presented by Professor Walid Sarhan. Actually, Professor Walid Sarhan is one of the most recognized psychiatrists in the Arab world. Personally, I learn a lot from him. He's a great mentor and a great asset to any organization that he works for. He's a senior consultant psychiatrist working in Amman, Jordan. He's the chief editor of the Arab Journal of Psychiatry, a fellow of the Royal College of Psychiatrists, international distinguished fellow of the American Psychiatric Association, and the honorary president of World Psychiatric Association. Also, he had so many sections in the World Psychiatric Association and in WHO collaboration centers. So it's an honor to see our Professor Dr. Walid and interact with him at the end of the presentation. Thank you very much.
Good morning, ladies and gentlemen. First of all, I would like to thank the organizers for giving me the chance to talk to you. I will be talking today on cariprazine as a novel antipsychotic that has been released in the last few years in different parts of the world, and it is a unique molecule. This symposium is sponsored by Hikma Pharmaceutical. As you all know, well aware that symptoms of schizophrenia are categorized into positive symptoms that include hallucination, delusion, thought disorder, negative symptoms, allogia, abolition, anhedonia, and cognitive symptoms, memory impairment, concentration difficulties. And you can see always the suffering of patients and families from these symptoms. The negative symptoms of schizophrenia are those that refer to loss, diminution of normal functioning, and such as expressiveness and motivation. And they are in these categories: affect is blunted, allogia, anhedonia, asociality, abolition, amotivation, and apathy, which makes our patient neglecting themselves, isolated, not functioning at all. And the cognitive symptoms include poor executive functioning, trouble focusing, and problems with working memory. The epidemiology of negative symptoms, clinically speaking, we all see it to various extents in our patient. And in studies, you can see studies that varies from 5 to 60% prevalence. And I don't believe that any psychiatrist would say that negative symptoms are not important regardless of the figures or the study you are looking at. So the cognitive symptoms are related to, but separate from negative symptom, and determine the functional impairment and characteristic of the patient with the disorder. That's why the negative and positive symptom together, if they improve, it means recovery and then improved quality of life. As you're well aware that we treat schizophrenia traditionally by blocking D2 in the mesolimbic pathway. Positive symptoms are controlled in the ventral striatum, and the EPS developed included, which is the side effect commonly seen. And the burden of negative symptom often persist despite psychosocial and antipsychotic treatment, recognized by FDA and EMA as features of schizophrenia that are not adequately treated by available antipsychotic therapies, the major contributor to low functioning levels and debilitation in most patients with schizophrenia. This burden has substantial impact on day-to-day functioning of patients in work, studying, independent living, being socially active, performing activities of daily living, maintaining personal relationships. The treatment with blocking D3. According to Stahl hypothesis, by blocking D3 receptors, the brainstem, in the brainstem, an improvement in the negative and cognitive symptoms can be seen. And this is quite important note, because this is really the first time we are working on D3. This is cariprazine molecule and the high affinity as partial agonist D3, partial agonist D2, and antagonist 5-HT2B, and a partial agonist on 5-HT1A. The moderate affinity being antagonist on 5-HT2A, H1, 5-HT2C, and adrenergic alpha-1. The low affinity or no affinity on D1, D4 antagonism, adrenergic alpha-2 antagonism, and muscarinic antagonism. And these are all side effects, as you know. We can classify now the typical antipsychotic, the old generation, with the atypical group that we are all familiar with. And this could be said to be the third generation of partial D2 partial agonist, aripiprazole, brexpiprazole, and cariprazine. And when you look at the profile, you can see here that cariprazine is the highest one that has affinity, very high affinity for D3 in comparison to all others. And this is what makes cariprazine unique in this group of drugs. And according to Stahl, cariprazine has unique potent binding for D3 receptors and other unique receptor actions. The low affinity for current antipsychotic for D3 receptor relative to the very high affinity of dopamine itself for D3 receptor means that in the living brain, the D3 receptor is not blocked by any antipsychotic other than cariprazine because of the presence of dopamine. That is because of cariprazine is unique among antipsychotic in having higher potency for the D3 receptor than dopamine itself. The net effect of cariprazine administration is D3 receptor blockade. So you take the comparison between the third generation cariprazine, aripiprazole, and brexpiprazole, and you can see here, and comparing it to risperidone and olanzapine, there is nothing similar to cariprazine in the ratio of the D3 receptor relative to the D2 receptors. The important question is Reagila, which is the trade name for cariprazine, is Reagila receptor profile different from those of other antipsychotics? Yes, Reagila receptor profile differs from all other antipsychotics as it is the only one with a higher affinity to D3 receptor than dopamine itself. This feature is based on its high affinity and in vivo selectivity to D3 receptors. Is there a correlation between the mechanism of action of Reagila and its efficacy on positive and negative symptoms? Yes, Reagila partial agonist effect on D2 and D3 and other receptors seems responsible for the effect seen on positive and negative symptoms. So saying that is a good drug for negative symptom does not mean that it doesn't work on positive symptom. What about the efficacy? There has been so many studies about efficacy comparing here Reagila with aripiprazole and showing that improvement versus placebo at endpoint was 61% for cariprazine 6 and 41% for cariprazine 3. And you can see here that this is cariprazine 3 and this is cariprazine 6. Also, the effect on hostility associated with schizophrenia, by working on negative symptoms, you may get the feeling that this has nothing to do with hostility. No, it works on hostility. From week 1 through week 6, cariprazine significantly decreased the mean PANSS hostility items compared to placebo. And as you can see here, when the hostility is over 2, over 3, and over 4, in all of these, you can see that cariprazine is very superior, clinically significant over placebo. Why to consider cariprazine in the treatment of acute symptom? Or shall we keep it for chronic negative symptom? No, we can use it easily for acute symptoms. It has proven efficacy. You will avoid switching and polypharmacy. It's very safe, has a very long half-life in comparison to others. In many studies, and this is one of them, long-term cariprazine treatment for previous prevention of relapse in patients with schizophrenia in randomized double placebo-controlled trials has been shown in many studies to be effective on long-term treatment. Another advantage of cariprazine is the long half-life. Promoting ensuring medication adherence in patients with schizophrenia is a challenge, and we all face it daily. Adherence can be hindered by complex dosing regimen, adverse effects, positive or negative symptoms, including cognitive impairment or lack of therapeutic alliance. And this is an important point to know, that cariprazine is metabolized by cytochrome B453-2A into 2 long-lasting active metabolites. Based on the half-life of cariprazine is 2 to 4 days. One of its metabolites, di-dysmethyl cariprazine, has a half-life of 1 to 3 weeks. So that gives you the security that patients who are missing doses or skipping or hiding it will not relapse, but also that when you stop it, the side effects will not be resolved immediately. In this important study that was published in The Lancet 2017, it was compared to risperidone monotherapy for treatment of predominant negative symptoms in patients with schizophrenia. It was a randomized double-blind controlled trial, and it was multinational randomized double-blind active controlled parallel group study, included many countries, as you can see, and there was 4-week leading to phase and 26 weeks treatment and 2 weeks follow-up. 2 arms, 460 patients. Doses were 3 to 6 milligram risperidone and 3 to 6 milligram cariprazine. Primary endpoint was PANSS factor score for negative schizophrenia, and secondary endpoint PSP. Additional endpoints, several scales have been used in such large studies as usual. Since 1999, second generation are the first line of treatment. From available second generation, 4 have better efficacy than the rest on negative symptoms. Clozapine, which is not a first line treatment, amisulpride dosing, it has a dosing problem, sedation, and prolactinemia. Olanzapine has metabolic syndrome and not superior in head-to-head trial with azanapine. Risperidone, similar side effects profile, similar dosage, strong antipsychotic that is used by many. So it has been chosen, as you can see here, to compare with. 2 weeks was 4 weeks was the preparation, and then the patients were divided on cariprazine 4.5 and 4 milligram with a range of 3 to 6 and 3 to 6. And the negative symptom study results in symptom control of PANS FSNS. Its statistically significant effects were observed in favor of cariprazine over risperidone. On these two scales, negative symptoms improvement from week 14 onward. As you know, you don't expect a negative symptom to respond in a few days. And this is a chronic, long-lasting group of symptoms. Also, in the responders rate, the responders rate of 20%, this is the difference between the two, and at the responders rate 30%. So there was a statistically significant more patients responded to treatment in the cariprazine group than in risperidone group. This was true for 22 and 30% responder rates. Negative symptom study results in functioning PSP. Overall, there was a statistically significant effects were observed in favor of cariprazine over risperidone on PSP patient functioning from week 10 onward. Results in functioning PSP subscales, there was clear evidence of the efficacy in socially useful activities, personal and social relationship, self-care, disturbing and aggressive behavior. So statistically significant were observed in favor of cariprazine over risperidone on PSP subdomains reflecting activities of daily living. Negative symptom study result in functioning CGI severity. Statistically significant effect were observed in favor of cariprazine over risperidone on CGI severity. Patients with cariprazine were considered less ill from week 3 onwards. Also on CGI improvement, statistically significant effect were observed in favor of cariprazine over risperidone on CGI improvement. Patients with cariprazine improved more. The pseudo-specific parameters that could be a confounding factor in negative symptom. First one is positive symptom. And here it has been shown clearly there was no difference observed between cariprazine and risperidone on the PANS factor score for positive symptom. The result on negative symptoms are not due to positive symptoms improvement. And this is the second parameter, depression. There was no difference observed between cariprazine and risperidone on CDSS, and the result on negative symptoms are not due to depressive symptoms improvement. Negative symptom study on EPS, this is the comparison between the two. No difference was observed between cariprazine and risperidone on movement scale. The result on negative symptoms were not due to EPS improvement. So, in summary of this study, the cariprazine was the only antipsychotic able to show superior efficacy compared to other antipsychotics with negative schizophrenia symptoms. It is considered first-line treatment for negative symptoms of schizophrenia. we can summarize this efficacy saying that cariprazine efficacy in acute exacerbation of positive and negative symptoms of schizophrenia was confirmed. The proven cariprazine long-term efficacy in schizophrenia and statistically significant efficacy compared to placebo in patients who are showing predominantly negative symptoms of schizophrenia. Regarding safety, these are several studies. 7 studies included more than 2,000 patients, and this is the outcome of these studies, that the most frequent adverse effects are akathisia, insomnia, and headache. Clinically speaking, headache rarely observed. Insomnia is taken in consideration. The drug is not sedating, and if the patient has insomnia, usually it has to be addressed. But akathisia, yes, it's 14.6%. And when we look at akathisia, patients with akathisia showing 14.6 comparison to placebo, and akathisia events 334, the mild, the moderate are the majority. So most cases were mild to moderate incidence density, more than 95%. Symptoms were managed with anti-EPS treatment or down titration. Discontinuation, it seems here that discontinuation rate due to akathisia was similar, 6.3% for cariprazine and 4.4% for placebo. The median time of akathisia resolution after drug discontinuation was 26.5 days for cariprazine, while in placebo, it didn't resolve. And this 27 days is very important, that we need to continue managing akathisia for 3 to 4 weeks after discontinuation. The metabolic parameters are quite interesting in this medication, that there is definitely shift from normal to high level of cholesterol and triglyceride that occurs less frequent in cariprazine group, and the incidence of glucose levels shift from normal to high was slightly higher in cariprazine group. Hyperlipidemia occurred in 1% of patients, and hyperglycemia and diabetes occurred in less than 1% of patients. And here is the short-term and long-term study, and it shows clearly that unfavorable shift in cholesterol and triglyceride level were less frequent with cariprazine, both in short and long-term, when compared to placebo. The incidence of glucose level shifts was higher with cariprazine, stayed, however, stable over time. Also, the incidence of hyperlipidemia, hyperglycemia, and diabetes were low during both short-term and long-term carbamazine treatment. Weight change, the potentially significant weight gain, which is more than 7% increase, it happened in 9.2% cariprazine or in versus 3.9% in placebo. Weight changes observed early in treatment and maintained stable over time. Actually, in clinical practice now, I would say that I haven't seen any significant metabolic problem or any significant important side effects except akathisia. Prolactin and sexual dysfunction. Prolactin decrease was observed with cariprazine treatment to normal range. Hyperprolactinemia was not seen with cariprazine. The QTc and a change in short-term And as you can see here, in comparison to risperidone and aripiprazole, it is very much less, and that is potentially clinically significant. QT prolongation was low in cariprazine group, and similar to placebo. And even QT-CF, QT interval, and corrected for heart rate using Friedreichia formula. Insomnia and sedation, it is mentioned, as you all know, in studies you look for it, but in daily practice, yes, the medication doesn't help to patient to sleep, and if the patient is in acute state, he should be given something for sleep. But the sedation and somnolence is negligible. Cognitive impairment was reported in 0.5 for cariprazine versus 0.3% for placebo in schizophrenia studies. Based cognitive data, Marder disorganized thought factors score and Meltzer cognitive factor score suggest a pro-cognitive effect of cariprazine, significantly greater improvement in cognition than placebo or risperidone-treated patient. What about the dosing? It comes in dose capsules 1.5, 3, and 4.5 and 6 milligram. The starting dose is 1.5 milligram, and the range is 1.5 to 6 milligram. The lowest effective dose is 1.5 milligram, and it can be used in maintenance in elderly patients with comorbidity, patients who are taking enzyme inhibitors. Defined daily dose in most patients ranges from 3 to 6 milligram. And the target dose is 4.5 milligram, and the highest approved dose is 6 milligram. Rarely 9 and 12 milligram could be used in some patients who are known to tolerate high doses of antipsychotic. The titration could be daily increased by 1.5 milligram or every other day, and it could be weekly as a slow titration, especially in chronic, more or less stable patient. Time until the effect appear, significant effect were seen after 1 week for these doses 3, 4.5, and 6, and after 2 weeks for 1.5 milligram. The down titration also depend on what previous antipsychotic the patient was on, and the titration could be slow or fast. It could be slow as in 1 week, and fast in 1 week, or slow 3 to 4 weeks. And here, how it works, that you down the dose slowly, and the overlap is 2 to 4 weeks, and this is the quicker one in 1 week. Usually, this is much easy and simple and safer. And if the full dose overlap strategy is often recommended when switching between antipsychotic, that you introduce the new antipsychotic and reach the full dose and then start dropping the old one, and that range between 1 to 4 weeks. By that, we can say we reach the conclusion that cariprazine is the only approved medication for negative symptoms of schizophrenia. And in addition to this, cariprazine does not cause hyperprolactinemia, causes less sexual dysfunction, and causes weight gain that is comparable to placebo. It is metabolically neutral. Hyperlipidemia, hyperglycemia, and diabetes were comparable to placebo. Cariprazine does not worsen cognition, frequencies, of cognition-related adverse events were similar to placebo and uncommon. Evidence suggests that cariprazine improves cognition. Cariprazine does not cause serious or severe QT prolongation. It causes less sedation, and that is similar to placebo. By that, I would say adding cariprazine to my armamentarium in the fight against schizophrenia has been a very positive experience, and the feedback from patients is very, very, very good. One of the patients told me, you know, doctor, I was okay before, but now I feel I am back to life and my brain is working. He was a physician and he was actually suffering cognitively and socially, but with Reagila, he's now doing very, very well. I hope you will have a similar enjoyable experience with Reagila. And thank you very much for your listening. And thank for the organizers for giving me the chance to talk to you in this great conference. Thank you, everybody. Thank you.
Thank you. Thank you very much, Professor Walid, always giving a very comprehensive presentation and new insights for a new hope for our patients. Definitely having a new antipsychotic is a new hope, always a new hope for our patients and our practices, especially if it is having some different qualities and better profile. Your presentation highlights so many topics, and I think there are many questions need to be answered. I'll leave the floor for the audience, and then maybe I'll ask my questions. So, okay, Dr. Badr.
Thank you for excellent presentation. And I would like just to ask, cariprazine and similar other atypical, which indicated also for bipolar disorder. Is there any role of this cariprazine with this excellent profile of mechanism to be indicated in bipolar disorder, or other people with not only negative symptom, but with resistant to other model of treatment? Thank you.
Yes, thank you for the question. Cariprazine is indicated for schizophrenia in general. Being effective on negative symptoms doesn't mean that it's not acting on positive symptoms. It has been approved by FDA for bipolar depression, and it is very effective and very well tolerated. But in the Middle East, it hasn't yet been approved for bipolar. That's why I didn't really mention it. But very soon it will be approved and available for bipolar.
So my question is regarding the best patient profile to be given cariprazine. What is it? Your experience.
It's. I would say the patient. To start with, at least to build some experience, start with chronic patients who've been under your care for a long time, that they have improved, but they have negative symptoms, and introduce cariprazine slowly until you get to 4.5 to 6 milligram. And in that case, you start building the experience. But later on, You can even start this with acute patient, even if they are agitated and so on. Maybe you will give them something like quetiapine. I would personally start carprozine in such patient and until the episode is subsiding, and I would want to withdraw quetiapine and continue carprozine. So it's, and this is usually will be somebody who with a chronic schizophrenia in relapse coming to hospital, and you know for sure that he has never been well controlled regarding his cognitive and negative symptoms. So it's probably at the beginning I was giving it in that sense, but now I am giving it to acute outpatient with different kinds of psychosis who present with like delusional disorder but has been long around, and I can easily introduce it slowly 1.5 to 3 to 4.5 milligram. So after all, it's another antipsychotic. You will use it as antipsychotic, probably because it's a little bit more expensive. You want to reserve it for the patient who is in need for that. If it's less expensive, I would probably give it to more patients, actually.
Thank you very much, Professor Walid. Last question that I'll ask, because we are very short of time, is can we use cariprazine in elderly?
Yes, definitely. And you will start with the 1.5 milligram. You may go up to 3 milligram, and some elderly patients I have are doing well on 1.5 to 3 milligram without reaching the 4.5 or 6 milligram.
Thank you very much for the very comprehensive answers and a very elaborative presentation. And it's our honor to have Professor Walid Sarhan with us. He's an icon of psychiatry in the Arab world and in the region. So it's our pleasure and honor, and have a very good day, Professor Walid, and see you soon in Abu Dhabi, inshallah.
Inshallah. Thank you very much. It was my pleasure.
Thank you. Now, because we are very short of time, I'm going to present the coming symposium. It's headed by Professor Matthew Varghese. He's a dear colleague and friend, and he's the treasurer of the World Association for Psychosocial Rehabilitation. And not only that, he's a senior professor of psychiatry. He's retired from National Institute of Mental Health and Neurosciences in India after working for 35 years with them. Current affiliation is adjunct professor at St. John's Medical College, Bangalore, India. He had been a faculty at the Department of Mental Health till July 2021. He currently is an adjunct professor, and his research area of interest are in geriatric psychiatry, mainly dementias, epidemiology and community psychiatry, family interventions and rehabilitation. Also, he's having over 150 publications in journals, monographs, and books on various cross-cultural aspects of mental health in developing countries. He has had assignment with the National Human Rights Commission and Ministry of Health for review of for mental health facilities, care, implementation, and monitoring of the National Mental Health Program in India. Dr. Varghese is a member of the Medical and Scientific Advisory Panel of the Alzheimer's Disease International and a board member of the World Association for Psychosocial Rehabilitation. He is on the executive board of the other professional organization in geriatric psychiatry and psychiatric rehabilitation. So please share me welcoming Professor Matthew Varghese.
good morning, everybody in Abu Dhabi and in other parts of the world. It might be evening, or it might be forward towards the night. First of all, I want to thank the organizers, especially Dr. Medat and others of the WAPR 2021 conference in Abu Dhabi for accepting this symposium. This symposium will essentially be on psychological aspects of COVID-19 and doing psychotherapy in the pandemic. All of us were hoping to be there in Abu Dhabi, but unfortunately, because of the new strain, the Omicron, we had to cancel our trip. And it's very nice that we can attend this conference in a hybrid mode. And I understand that there are almost 5,000 delegates who have attended in hybrid mode in the last 2 days. And I'm very pleased to start this session and chair and introduce the speakers. The order of the speakers is going to be, first is going to be Tara Chako, then Vrinda Amritraj, and then finally myself. I will introduce both Tara and Vrinda first. Tara Chako is a psychiatric social worker by training. She trained at the Tata Institute of Social Sciences in Mumbai, and then later on did her MPhil at NIMHANS in Bangalore. And for over 30 years, she has been working at this organization called Zeitgeist, which is a center for personal and organizational well-being. She is a business partner with Brinda, who also I will introduce now. Dr. Brinda Amritraj is she's a clinical psychologist, and she trained at NIMHANS in Bangalore, where she did her MPhil and her PhD. And both Brinda and Tara actually work at this organization called Zeitgeist, which they will talk about in a few minutes. And they basically deal with clients, companies, and other organizations. And Tara is going to first talk about emotional well-being in the COVID-19 pandemic. And Brinda will talk later on after that about how to handle grief. Over to you, Tara.
Thank you very much, Matthew, and good morning, good afternoon, and good evening to all of you who are here today. Thank you very much to Dr. Medat and all the organizers of the WAPR for having invited us to do this symposium. And it is a great honor to be able to do this and be in your midst at this time. The pandemic has made it hard for us to be there like we had originally planned to. And there is no other clear example of the way that you have so tremendously worked hard to shift things around with the new COVID variant coming in, various challenges that have come in, which all of us have been going through over the last more than almost 2 years now. And this pandemic has really turned our lives upside down in various ways, and the unprecedented extent of change that has been expected of all of us so fast and so rapidly and in such uncertain ways. From the emotional impact from initially being shocked and being able to be uncertain and tremendous amount of fear in the first wave, to moving to tremendous sense of loss and distress about and anger about the way the pandemic was handled, carelessness, to now a sense of fatigue and fear of how long more is this going to. The emotional well-being of people is something that has to be addressed. And thanks to the pandemic, the focus on mental health and well-being is being recognized much more than it did before this. In the next few minutes, I will talk about the psychosocial impact of the pandemic on employees in the workplace, some of the strategies that we have used and worked with employees to help them to cope with and enhance their emotional well-being. To begin with, I'm going to draw on an acronym that is used in the business world when it was way back, started in 1987, but describes or reflects on how due to this rapid technological, industrial, financial market condition, how it replaced that sense, old world sense of certainty, stability, and familiarity with now a sense of constant flux. And now more than ever more with the pandemic, this has become much more appropriate. VUCA actually is an acronym which stands for volatility, uncertainty, complexity, and ambiguity. And just the nature and dynamics of change due to the COVID, we have seen every day unprecedented and dramatic changes that have happened. The lack of predictability is what we're seeing in the uncertainty. No one can really predict with what confidence the pandemic will be over, what are the new variants that are going to happen, the efficacy of vaccines, even this unpredictability in terms of even the way we had to conduct this conference and change things overnight. The third is the complexity is in terms of the multiplicity of forces, the confounding issues that we're having to do. There is sometimes no clear cause and effect thing that we can actually see. So this has impacted all businesses, healthcare, economy, our mental health in very, very complex ways. And of course, the ambiguity, because there is really no clarity. There are no best practices which organizations and people can see can be done to be able to face the challenges. And research on VUCA, the impact environment, has clearly talked about how over the years, even from the very early times when we're talking about it, has a clear impact on destabilizing people, disrupting the organization, their motivation, career moves, the decision-making process can be paralyzed, and this can take a toll within the organization on individuals and the organization, which can be overwhelming. And what has been unique with the COVID-19 pandemic, the kind of changes that we are seeing is that overnight, people had to move into full-time work from home with prolonged introduction, which also led to merging of work and personal roles, the lack of social connectedness, and especially when people talking about not being able to connect with their team members, having to work remotely, the work stress, they talk about anxiety, frustration. Somehow, even though the work from home reduced the amount of commute, they found themselves working longer hours. The kind of work that has come on is here huge. Career growth, do I move? Will I get a promotions? Will I get my increments? Collaboration became a big challenge because though we have moved to being in a connected, so with all our technology, there is still this feeling of lack of understanding. People are just not able to take time for themselves. And because of this merging of work and personal life, there are a lot of conflicts with friends and family. Now, all of us are in this rough sea together, but we are not necessarily all traveling in the same boat. So therefore, what we have seen is the impact of the pandemic on employees. Out of the American Journal of Psychiatry, 7 out of 10 employees indicated that the COVID-19 is the most stressful time of their entire career. Insomnia, depression, and anxiety are also very noticeable. Survey by the Total Brain, which did a global workforce since February 2020, talked about stress increasing 28%, anxiety and depressed move more than 50%. And that having an impact on the difficulty to focus and difficulty in planning. So no other time is it so important for people to look at strategies to manage these difficult emotions. Because the WHO has emphasized being able to recognize our emotions, to learn to manage them and regulate them in a way definitely has a huge impact on our physical, mental, and social well-being. In fact, people who are good at being able to notice their emotions and feelings, are able to manage and adjust their behaviors, are much more likely to adjust their behaviors, more likely to do well in their life, have more healthier relationships, and manage their situations better. Now, what I'm going to talk about clearly is in each of these, what are some things that we really need to keep in mind? As Viktor Frankl rightly said, that an abnormal reaction to an abnormal situation is normal behavior. So the feelings of fear, just to begin with, that it's to be able to reassure each one of us that it is okay to feel this way as we are all dealing with an abnormal situation. So it begins with the awareness of feelings. in being able to recognize that all emotions have a function, though it makes some of them make us feel uncomfortable, some of us term them as bad feelings or negative feelings, but every emotion has a function. Whether it is anger that protects and helps us to prevent any intrusion into our boundaries, or fear that prepares us for anything that can go on, the tendency is to be able to deny our emotions or try to suppress it in the hope that it will go away. But what we also encourage strongly is for individuals to acknowledge and to name the feeling. As we say, you name the feeling, you can tame the feeling. And therefore, it is very important to be able to recognize that the understanding of or managing of emotions begin with recognizing and naming what is the feeling I'm experiencing. And to just call that out makes the huge difference into the way we are going to be able to manage those feelings. Awareness of feelings also, what we recommend is for people to monitor their moods and be proactive, to be able to recognize that, okay, that this morning I woke up and I felt happy because I had sent off some mail and I got some congratulatory mails. It made me feel good. On a scale of 1 to 10, that is going to something that is feeling 1 or 2. I have made second after about 11 o'clock, I recognize that one of my team members has not completed the task that he was supposed to do. It irritates me, but on a scale of 1 to 10, I'm at 6. On probably the evening, there was a presentation that had to be made, and the CEO and the senior directors were there. Somebody called out something which I had overlooked, and it made me tremendously angry. To be able to recognize what the intensity of emotions is the first step towards being able to manage them. So therefore, what are those hot buttons or triggers that set off emotions that are difficult to manage? What are the things that make me anxious? What are the things that make me angry? Being aware of that makes it easier to manage those. The second aspect is about regulation. And it can definitely, all of us have the ability to regulate a difficult emotion. Ask somebody who has just been yelling at one of his team members for a task that has not been done, and his phone rings, and he looks at the number and he sees that it is a senior director in the company. How he can just switch off that feeling of anger towards the team member and actually behave very nicely to the CEO or the director who is talking. Definitely, it is possible to regulate the way we respond to our emotions. And some of the things that we can do that help us to manage is, after recognizing the emotion, is to look ahead and think of the worst possibilities and see, are they really true? Because those are things that can our minds throw up as a looking for reassurance about what can be done just in case that they do happen. So being able to also look at not allowing oneself to worry through the day, but providing times during the day that you would sit and be able to look at the emotion, understand where it is coming from, look at how realistic it is, and then reassure or be able to say that it is okay to feel so. To be able to refocus, to ask around. One of the things that we have seen that really works in our workshops is that when people start speaking, everybody else starts feeling better. They say, oh yes, even I'm going through that. Oh great, okay, is that something that you have done? Or being able to learn from others about what they have done. That can help in being able to manage difficult emotions. Reproportion of guilt or blame, neither blaming ourselves or blaming the other person, but being able to see what really is the cause, what is the issue, looking at it from a third person and saying, what possibly have contributed to this? What can I do to address this, rather than saying he or she is at fault or I am at fault? One thing that many people we have said, talked about, found this useful is to be able to just take time out, not react as soon as the emotion comes, but take some time to let the emotion die down and then respond. For example, you have a mail from somebody, from a peer who suddenly let you down, said they cannot do what they should be. To be able to say, okay, let me not respond immediately, or let me respond, put it to the draft, think about something, look at what I can do that will help, and come back and re-look at it. You will find that you would want to rewrite what you have, which was probably very aggressive and out of line. To be able to practice gratitude and compassion takes away from what all is going wrong, what all is out of control, to being grateful for what you're actually having, to be compassionate to ourselves and empathetic towards other people, so that it reduces the amount of anger and resentment we have to people to recognize they also are struggling just as much as we are. In regulating emotions, sometimes the intensity is very strong and it's very hard to do some of this that we talked about. But definitely things like self-soothing, breathing, focusing on your breathing, talking to yourself that this too shall pass. This is only a matter of time. Going for a walk, some vigorous work, activity, wash the dishes, beat the rug, dust out of the rug, all that can help to be able to move and get that intensity down to a point where you can actually start looking at what is triggered off the feeling. Mindfulness by consciously focusing on the present, because we are either focused on the future, what's going to happen, or on the past, oh my God, this went wrong, how could he do this? But focusing without judging the task, just seeing them, thoughts, and allowing them to focus on day-to-day tasks, drinking that hot cup of coffee, what it feels when it touches your tongue, the feeling, the taste, the smell, the aroma, all those can be wonderful ways of being able to manage. Yet, it's also important for all of us and people to recognize when it is necessary to ask for help, to know that it is okay to ask for help when we are either overwhelmed, when whatever we are trying, we've done we've tried to meditate, we've tried breathing, we've tried looking gratitude, still not helping. It's impacting our sleep, our appetite, our day-to-day functioning, and it's impacting our relationships. People also need awareness of where and how to get help. And the work that we do with organizations, it's important for them to know how they can reach out, or what kinds of things they can reach out, and most importantly, to know that whatever they say to our psychologist or counseling team is completely confidential. So therefore, when we look at mindfully dealing, it's about turning towards our emotions with emotions, being able to identify the label, to accept that our emotions are there, not try to push it away, look at the impermanence, inquire and investigate to how true is it, what triggered, what can I do about it, and being able to let go to control your own emotions. Thank you very much.
For your warm introduction. At the outset, let me wish all the participants there at Abu Dhabi a very fine good afternoon and good morning to those not here. Good morning, good evening to all of us who are on the video. At the outset, I would like to thank Dr. Medit and the organizing committee for having had us to talk in this symposium. We've had the opportunity of enjoying Dr. Medit and the team's hospitality during our last visit to Abu Dhabi. And we are really sad that we are not able to be there during this time. And we are aware of the amount of trouble Dr. Medit and others took to make this symposium a grand success. But unfortunately, the Omicron came in right at the point and everything had to be moved. And like Tara said, really appreciate the change that the team had to put in at this point in time. So today I would like to spend a little time on talking about the management of grief and what has been my experience during the pandemic. We are all aware of the fact that COVID-19 today is one of the leading causes of death worldwide. As mental health professionals, we have all been involved in helping people deal with the loss of their loved one and with grief in particular. Especially during the second wave, we had a lot of people who succumbed to COVID-19 and its complications. To mitigate the devastating impact of the illness, and several restrictions were widely implemented. Such policies and practices, along with the COVID-19 spread, complicated issues of grieving and has dramatically altered the way people grieve with the loss of their loved ones. We live our lives through these important relationships that we have with people. Our relationships really define us, and who we are is intimately entwined with a sense of self, our self-concept in fact, and thus becomes a living part in us. It is no doubt terribly painful to lose someone we love, because it is like losing an important part. For this reason, grief is not something that happens out there in the world. Instead, it happens inside each one of us. The work of grief is thus a personal work of healing and regrowing the sense of self. As we know, each person's grief is unique, and the experiences that we have seen vary from person to person. As we all know, Holmes Rahe ranked death as of a loved one, in fact, as the most stressful event. However, during the coronavirus, the grief has turned into a new concept itself, and the challenge that the survivors and mental health professionals went through is really remarkable and something that was really difficult at times. Millions of people have not experienced the regular grief cycle that we usually go through. On the other hand, the expectation was that one would rapidly adjust to the situation, move on, and recover themselves from the loss. Many of themselves were also recovering from the COVID-19 itself.
Brinda, I think your slides are not moving forward.
No,
Just try to move your slides forward.
So what are the issues that we are seeing among the bereaved people? People were not able to travel because of the lockdown in some cases. And as you're aware, in a world that had become so dynamic, we had children staying in US, UK with their families in India, or children in different parts of India. All of these was happening. I cannot but recall one of the ladies who called during this time saying that her father had to go to UK on a 6-month deputation. And unfortunately there, he developed COVID and he died while he was there. This lady was going through immense grief. She could not imagine what her father had really gone through in a strange country. She kept saying that the last few words was that I can't breathe, I can't breathe, I don't know what to do. This kept ringing in her. She could not go because of the lockdown, flights were not available. All of these created a tremendous loss and grief in her, being miles away. It says that her father was a very people person, and what he really would always, even a small illness, he wanted the entire family around him. His wife had to be sitting and holding his hand all the time. She says, I can't believe that he was alone when he died. So this was what we were seeing out here. People were dying alone in the ICU, isolated from their families. There was a negative perception of death. For the grieving, the news, something from the media made it no easier. The constant barrage of information, lack of oxygen, beds not available, there was suffering in the ICU. We are all used to caring for people. And at such a time that we could not be there with our loved ones as they breathed their last was a very painful experience. I recollect an MD student whose mother was admitted in the same ward as he was posted on COVID duty. His mother was very healthy, except that she did not have any premorbid condition. But suddenly one night she took into being very serious. This boy was having night duty every other day, but that particular day was when he did not go for duty because he was on off duty. So when he heard that his mother was sinking, he ran into to go and be with her, but he was not had protocols to be followed. His friends kept giving him information, but she succumbed to the illness. This boy is going through so much of grief, so much of difficulty. Doctors were so busy that there was lack of communication. Death from other causes were also there, and that was numbering nearly 50 million as reported in research data. They were also happening. Amidst that physical distancing and COVID-19 related challenges, families were hesitant to take them up and be associated with guilt when there was exacerbation of the illness. So they could not even reach out for help when there was heart issues, cardiac issues, renal problems. They could not go for the regular follow-ups, and the other illnesses started deteriorating, and they lost people because of this. Worse still was that all family members were tested positive in many cases, and they could not be there for others grieving in the family. There were multiple things happening. Some were in the ICU, some were quarantined at home, some were having other illnesses, premorbid, so they had to be isolated. All of this made the bandwidth very low for people to be available. Therefore, there was a lot of guilt and a feeling that they were not there with the people to say goodbye when they finally lost them. Grieving was further became worse by the cascading life stressors such as financial loss, loss of a job, loss of independence, loss of relationships. As a result, there were so many things to mourn for. And what are you crying for? This people saying, what are you crying when there is a loss of job, when we are losing our own people? What are you giving priority for? So there was a lot of guilt associated. And hence, we saw two kinds of aspects of it. The lack of closure, a lot of the future was unknown, right? There was search for answers. Why me? Why is this happening to me? Feelings became complicated and difficult to handle. People were going on feeling stuck, and there was a guilt, grief. For what loss were we grieving really? There was disenfranchised guilt as well, because people were not able to mourn publicly because of the restrictions of COVID-19. There was blame, anger, guilt, sadness. People were emotionally distanced due to stigma. You know that a very close uncle of yours passed away, but you're unable to go there because of the social distance. And therefore, traditional practices were cut off. So it's interesting that the stages of grief that Kubler-Ross spoke about in her transformative book on death and dying as early as 1969 We saw it so markedly happening during the COVID-19. The denial state was a marked phenomena because many people suddenly got very serious and died suddenly. So the whole process of being with the person, the process of spending the last few hours with the disease, the last journey, we could not be there with the person. As a result of that, denial stage kept persisting with clients, and they were saying, I cannot believe it that he's not there. He was so fine when I saw him last. How is that he is no longer there? Anger, there was anger. The survivors' anger was a predominant emotion. Anger against the doctors, against the government, against the policies, rant and rave about what is happening, blame others. COVID behavior was responsible for the person getting ill. So there was a lot of anger against people who were not following COVID appropriate behaviors. We saw bargaining as well. Please, God, just give my husband one last chance. I'll be the best wife to him. Depression, no doubt, the severe sense of emptiness that clients feel when the person they love is gone from their lives. See no point of living, loss of hope. They talk about the purpose of life itself being lost. What is my life without him? Why should I live? There is no meaning in I'm going to further on. Acceptance is rather slow, and people are still grappling with the status of grief. So what is it that we can really look at? How can we help people cope with grief? These are some of the practices that are not new, perhaps well said in literature, but I would just share with you some of the experiences that we've had. In terms of acknowledging feelings, as Tara rightly said, many times it's just naming the feeling. Because what happens is that there are a lot of relatives and friends of survivors who say, you should not be crying, you should be strong, it is not okay to be angry. You are there, you are the only one for your mother or your father. You are the person who has to be strong. Don't cry, right? So when they come for therapy, it is important that we normalize the emotions. See, it's okay to feel that way. David Kessler, the world's most foremost expert on grief, has said that we need to encourage people to name the feeling, right? Only when we start naming the feeling do they actually are able to manage those feelings, because feelings then reach on to the thoughts. So they are able to tap the thoughts once the feelings are named. It's important that very often as therapists, our need to talk becomes very strong. So listening and helping the person with open-ended questions definitely helps. And of course, there is a lot, just not the grieving process, but there is a lot of life changes that come with it as well. So there's a lot of fear. How am I going to cope with all? I've never handled finances in my life. How am I going to cope? So instead of immediately giving advice, maybe we'll just help the person to talk about their fears, to talk about their anxieties, to talk about their concerns. The other aspect of focusing on therapy to normalize the feelings also encourages the person to feel. It is okay to feel. So therefore, there is some amount of, in the therapy session, there is a permission given that it is okay to feel. Just acknowledging that we are going through tough times really helps to heal as well. The second aspect, of course, is the community's support. And our funerals are a common place for many cultures and death and burial rites. It gives the loved ones a chance to say goodbye, support friends and family in their time of grief. But with this outbreak, such gatherings had been banned. So as I mentioned earlier, there was a lot of denial that we were seeing in the absence of ceremonies or burials or any of these aspects going on, right? So it was important to see how is it that they can get some support from well-wishers, even if it means virtually. Seeking support of people who matter, which is why in India we had a lot of bereavement groups set up as well, so that people could share their feelings and feel a oneness together. It was also very useful when there were stories, pictures shared of the bereaved across the world, when people start sending in their recollections, their memories of the person. It builds in a certain amount of tranquility. It also helps the person to build a narrative, a story that was abruptly cut off with suddenly the death coming in. It helps the person build a story around what really happened. The second aspect of it is, of course, practicing simple rituals. I remember of a person, an only son, who lost his father to COVID-19 at the height of the pandemic during the second wave. So as a result, the person was not able to perform any of the rituals. Much after, he kept saying, my father wanted to be sent off in a very grand manner, and this is the only wish that he had, and I could not fulfill it. He kept saying that repeatedly, and he could not after that speak. But a year later, very recently, when he performed 1 year rituals, he felt a lot at peace. Many times off recent, there are virtual medias where many of these rituals are done, but people are invited to join virtually. Therefore, we can encourage to coordinate with the family a date and time when these rituals can be practiced. The last, of course, is that during these tough times, what we have noticed is that people do not take care of themselves. They neglect them. Healing is really taking care of ourselves. And there is a certain amount of ambiguity that how can I take care of myself when there's so much of grief, when I don't have how can I enjoy a meal? How can I enjoy something that I have always enjoyed with the person, right? So working through those thoughts and helping the person to really take care of themselves, their mind, many people have turned into spiritual ways of healing, which is also very helpful. So pain of the loss really comes with over time, but is something that never goes away. As Kubler-Ross has said, acceptance does not mean that we say it's okay that my father is no more, but acceptance is really accepting the reality that my father is no more physically present, but I need to move on in life. Christians, for example, may take a lot of solace with the fact that one day they will meet with their loved ones in heaven. So also every religion, every community has a meaning in death. And that is something that is good to explore, which gives a sense of acceptance. Acceptance is when really the person is able to look after himself, listen to others, take interest in life, and adapt to changes without the person. During this period, I have found this extremely challenging, especially when they are older people and they have lost their grown-up children, or they are, or it is a wife dependent on a husband, or a husband who had his wife for everything all these 50, 60 years of his life. So in such cases, helping them to transform grief into a more peaceful and hopeful experience is really a challenge. As Kubler-Ross in his 6th book Sense has said, accepting loss is essential, but what comes after to live on is really a challenge. So therefore, as therapists, one thing that we need to really watch out for is that some personality types where there is difficulty in coping, where there are some of the risk factors, people can get into complicated grief, and that is something that we need to closely watch out for. Thank you very much.
Thank you very much, Tara and Brinda, for talking about how to deal with emotions and how to cope with issues in the pandemic. And thanks to Brinda to talk about what happens when we grieve. We have to handle the passing away of somebody. But I'm going to talk in the next few minutes about how to do this therapy. Because as all of us know, therapy has also gone online. And I'm going to draw on my experiences of the last 30 years or so, practicing and training in individual and family and couples therapy to talk about how we can do therapy online. So suddenly, though telepsychotherapy was available earlier on, we had lots of, lots of apps and other things to do therapy. But suddenly, there was an unexpected transition where we all suddenly pushed out because of pandemic restrictions into having to do telepsychotherapy as a must. The media that is used could be anything. A lot of people do therapy with a telephone, just a voice call, especially if it's individual therapy. A lot of people use mobile phones or smartphones. For follow-ups, a lot of people use communication by email. And there are a lot of apps, people have made do-it-yourself therapies with bots, apps, and even there is also avatar therapies. But one of the therapies that is, which has been researched a lot as opposed to telephone therapy is video conferencing psychotherapy. And I think video conferencing psychotherapy is something that has come almost close to doing in-person psychotherapy. Now, the needs of the patient or the client, you must remember, are actually the same in the sense that either you're trying to help somebody who's got a self-dysfunction, they have a personality problem or a depression or grief, or you're trying to help somebody who has an interpersonal dysfunction. So they have a difficulty talking to their spouse, or they have difficulty talking to their parents or their children, and so on. So essentially the needs are essentially basically broadly two. And if you transition, if you have seen somebody in in-person therapy and you want to transition to, as many of us have had in the last 2 years, to video conference therapy, you need to really make a new contact with them about what needs to happen. Now, there are lots of socio-demographic variables which makes online therapy or video conferencing therapy difficult. Now, I think a big chunk of that is the economic background of the client. Of course, the economic background of the client was important in terms of any kinds of therapy, because the poorer people, the marginalized people, the people who really need it the most are not able to go even for any kind of therapy. So there's already a divide, but the digital divide has become more so because it's not just the economically backward, but it's also people who are not able to use media and gadgets. For example, the elderly, for example, children, or even older people, adults who are not able to manage many of these video conferencing platforms. As I mentioned, the availability of a phone, tablet, computer is something that is very difficult. So, especially with work from home, most homes might have just one computer or a tablet, but if everybody has to be online, so to find a space, a private space, an available room without noise, where there's good light, where there's no other interference, is something that is a challenge. Many times therapists talk about how the children or some other person in the family, or maybe even sometimes pets, walk into the frame when we are doing therapy. So to get space, to get gadget, and to have no interference is something that is very challenging. And as I mentioned, particular challenge with elders and with children. Now, adapting to different modalities and settings depends on different aspects of therapy that you're doing. For example, if you're doing individual therapy, it might be a little bit easier than if you're doing, say, couple therapy. So when you're doing couple therapy, if you use one gadget, they will both just about come into the frame, and you might be able to see them, see their faces and do therapy. But if they get a little far away, then the noise, the audio becomes a problem. If you have to do family therapy, obviously you can't have just one device. Different family members, maybe the children from one device, the parents from one device, you have to log in from different devices. And so if you have a Zoom platform or a Google platform, you will have different windows where the whole family comes up on the screen. It's even more difficult doing group therapy. In one or two situations when I had to do family groups, it was actually family members logging in from different parts of the country, and they were all there were about 12 or 15 people on the Zoom screen. And this is something that I think all of us are used to, because we've been having Zoom parties and interactions with our families all over the world. So this is also something that is possible, and it's something that can be done. I already mentioned that the age of the client is important, because if you have to handle children, many times they are not able to, they are not able to know that they're supposed to be looking at the screen and talking to the screen. Similarly with elders, elders have a difficulty with vision and hearing. So when you try to talk to them on the computer, many times they cannot hear, and somebody has to repeat what you said, and many times they cannot see what's going on properly. So there are challenges depending on the age of the client. It also depends on the setting. For example, I remember in our hospital, suddenly when we went into lockdown and we had to do everything online, the administration had to suddenly install high-speed internet in every room, in every consulting room, the outpatient. And we had to make provisions and we had to take slots where people could do either consultations or therapies. The same thing operates if you're in an organization or you have counseling center at the workplace or in the school. Again, handling, earlier on there might have been just one counselor or a few counselors doing the therapy or doing the work. But suddenly, when everybody is doing this, you'll have to organize spaces and gadgets depending on what clinic you're in, whether in private practice or a community clinic. And also, if you are in a rehab center or a long-term home, or maybe even in prison. So these are places which don't really have the required paraphernalia to do this therapy. As I mentioned, if there are more participants, for example, if you have a family or a group, then the communication fluency is hindered. The group dynamics are difficult to interpret. and there is a higher degree of, you need to have a higher degree of attentional flexibility, because the therapist has to be really mindful of all these people who are in your frame. Now there are advantages, a lot of people have been talking about the advantages of doing online or video conference therapy. Of course, there is this geographical barrier which you have to surmount, or which it can be the plus or minus. In some sense, you have the person right in your room, just on the screen at touching distance. So in some ways there is a barrier, in some ways there is no barrier. Now, treatment-seeking stigma is supposed to become less, because clients can just sit in their houses and access therapy anywhere in the world. So you don't have the stigma of going and meeting somebody or going to the hospital. Some people say there is greater disclosure because the client is sitting in his own space. There might be more openness and maybe sometimes even disinhibition due to a sense of being safe in your own home, and also a neutral power balance. Usually when you go for therapy, in some ways the therapist is in a one-up position as opposed to the client. And of course, flexibility in scheduling sessions. You can schedule sessions whenever you want. You don't have to travel. In a place like Bangalore, you spend about an hour traveling about 10 or 15 kilometers. So it is easy to have this video conferencing therapy accessible, possibly affordable for many people, and also you need to adapt. There are also challenges or disadvantages in doing video conferencing therapy, and that is that the non-verbal communication might be affected. For example, when you look at the screen, you might have a difficulty looking at the person or the image of yourself. You need to modulate the tone of your voice, your body posture, and many times for clients, you cannot see their hands or legs. So if they're fidgeting, if their legs are tapping continuously, or they're wringing their hands, you're not able to see all that. Many times you're only able to see their head and their shoulders. And if it doesn't work out very well, many times you have dropouts if there is no therapeutic alliance that you can establish over the video conferencing platform. Some tasks in therapy may not be possible. For example, you may not be able to do role plays. You may not be able to do exposure in vivo as you might do in phobia or in OCD. But some people have surmounted this by actually bringing into the video conferencing platform, bringing in, say, a stranger into the session, or some strange object to which the person is having phobia or OCD. So that has been possible. You might not be able to do some of the emotion-focused therapies or strategic therapies where sculpting and empty chair techniques are involved. But some people in the video conferencing platform have also tried to use the telechair work. So you have an empty chair. We have an empty chair with a screen, and then you kind of do all the empty chair work there. The challenging situations are actually when you have somebody who is suicidal. So you have somebody on the screen who is saying that I want to kill myself, or he's threatening, or he's actually trying to do something, and you could be just sitting and watching somebody doing something to himself. Same thing can happen if somebody is psychotic and has an acute excitement. You might see them actually, getting into a fight or beating up somebody in their homes. You might have difficulties doing a lot of things where you need to monitor when it comes to eating disorders, and same operates for bipolar disorders and people who have social anxiety. A lot of people who have social anxiety may not actually want to be on camera. So you might have difficulty actually getting them to, take part in these sessions. Now it's important to establish a therapeutic alliance, and studies show that therapeutic alliance is actually quite easily established and maybe as good as in-person therapy. Now, in in-person therapy, there is a physically shared space, and all people say that it's a different sensory experience which aids in the therapeutic alliance. But I wonder whether that is just a feeling that we have. It's a feeling that, unless you're in the same room with the person, it is, you can't really get to them. But research has shown that it's probably not required. In video conferencing therapy, both the therapist and the client have a feedback from the camera. In some ways, this might be better for therapeutic lens, because actually the therapist can actually also see how he or she is behaving. And as I mentioned, video conferencing therapy might be difficult in people who have narcissistic tendencies or people with social anxiety, and in some ways, the fact that they are facing the camera might actually hinder therapy because some of them may not be able to do it. Some of them might, dress up a lot for the camera. And the other thing, one of the major things that can interfere with therapeutic alliance is technical difficulties. For example, an unstable connection, frozen screen, delayed audio, poor lighting, or even extraneous sounds. Now, it's important to remember us, the person of the therapist. Remember that the pandemic has affected us also as therapists. We also have gone through routine disruptions. We also have gone through fear, anxiety, grief. We are also doing work from home. We also have children and other people in the family. We have the same symptoms and situations as our patients. And maybe that is, the personal experiences might be something that might help us to empathize better. We also had less work. We also had less therapy. We also had less income and stress. So it's important to adopt a very self-reflective attitude. So it's good to think about what's happening. And all the things that Linda and Tara said about being self-aware, following self-care practices is extremely important. And one of the things that people have found out in research is that your attitude to video conference therapy or your prior experience with video conference therapy is a good indicator that you might actually do well in therapy with your clients in a video conferencing therapy session. And generally, the research has shown that there is fairly a high degree of satisfaction with video conferencing therapy that clients and therapists have noticed. A few words on supervision and training. When I was at NIMANS this year, and we had to do family therapy training, we suddenly had to switch to, we couldn't even meet except after the lockdown. And when we met, we all met in masks and we kept our distance and so on. But most of the therapy was on the phone or in video conference. It might have been in a group or a peer session, or it might be an individual supervision. And on the telephone or the video conference, it's sometimes difficult because you might have to spend, anything from 30 to 60 minutes doing this. Already, there was videos and other training material available. So we just had to tell our library to increase the video material, training material, and so there were videos from the APA, YouTube, psychotherapy.net, and so on, which trainees could watch. But it's very important to actually train the student in doing video conference therapy or phone therapy. So you must actually get them to do it and to experience what happens. And it's also good to tell the students to train them in the guidelines and the ethical issues. For example, who should log on, who should send the link, what is it that you can do, what is it that you cannot do, what are the practices in terms of the way you dress up, the way you present yourself. There are so many things that you have to teach students because it's a totally new experience. And so you need to actually get students and trainees to focus on what is called as deliberate practice. You practice doing therapy very deliberately and learn general principles of what can help with change in therapy. Not so much focusing on a manualized therapy, but you're actually focusing on what is it that I can do to achieve therapeutic competence, rather than just following a manual. Now, there are a lot of ethical considerations, and these are a little different compared to in-person therapy. The one is the issue of privacy, and the issue of privacy depends on whether you have a secure platform, whether your data is stored and follows maybe regulations like, for example, in the US, the HIPAA regulations. Privacy is also important for the client and the therapist, so privacy and safety of the client and the therapist. So what is it that you're going to do on screen? What is it that the client is going to do on the screen? For example, if the client starts behaving violently or the client starts, suddenly undressing, these might be things that, you need to do, you need to be mindful of. Informed consent is important. And there was a time when all over the world people insisted that you first saw the clients in therapy for one session, did assessments and so on. But you know that during the lockdown, you just couldn't see it. You couldn't follow this victim of having to do a first session in person. So many times it became first session online. And so how do you take informed consent? and many times you're not recording the sessions. Sometimes some clients ask me whether I could record the session that I did, even in psychiatric consultation. So I said no. So I said, why did you want to record? And they said, no, we just wanted to show the session to my son who lives in America, or my daughter who lives in Germany. So I said, no, I rather meet them online and explain to them exactly what I need to say, because you could actually misinterpret or interpret differently what I said or what I meant to say. So privacy is very important, and deciding with the client what is it that you're going to do and what is it that you're not going to do. Most of the time, we do not record, and we ask the clients not to record. Of course, in all this, competency of the therapist is very important. And what about payments? Commercial contracts. How will you pay? How will they pay you? Do you do PayPal? Do you do Google Pay? How much do you pay? How do you ask them? All these things are different challenges that you face. Now, what predicts if online therapy is working well? Lack of experience with telepsychotherapy is something that causes a lot of interruptions in therapy. Similarly, a theoretical orientation, very surprisingly, though CBT is easy to do online, one study showed that people whose theoretical orientation was CBT had a lot of interruptions in therapy. And patients' lack of privacy is something that is at home, something that has been noted as causing interruptions in therapy. But the predictors of good therapist satisfaction was previous experience with telepsychotherapy, belief about compatibility of telepsychotherapy with their theoretical orientation. For example, if you thought that if we did Rogerian work, or if we did emotional focus work, if we did dynamic work, and you thought that telepsychotherapy was compatible with that. And many times, most people found in research that video conferencing rather than telephone was much better as a good predictor of satisfaction. So in conclusion, you need to disseminate training programs for therapists on telepsychotherapy. You need to support patients to pragmatically access a private space at home. You need to encourage practitioners to use video conference rather than phone therapy to deliver remote therapy. You need to increase the acceptance of telepsychotherapy among clinicians and also the general public and clients. And it's very important to follow tele guidelines and ethical provisions that have been brought out. For example, India, very, very soon into the pandemic, the first wave, we came out with the national guidelines for teletherapy and telemedicine. Teletherapy is efficacious, it is acceptable, and believe it or not, teletherapy is here to stay. And I think this is the way forward in some ways, and teletherapy is really here to stay. Thank you very much, all of you, for a patient listening, and we'll be happy to take any questions at this point of time.
morning, good afternoon, good day. Now we have another symposium with an eminent speaker, and actually Dr. Shahid Qureshi is the Deputy Secretary General of WAPR. He is graduated from Kinda Medical College, Karachi in 1985, and he's working as associate specialist in worked as a specialist, associate specialist in transcultural psychiatry in Coventry Healthcare Trust, and since 2001, he's a consultant in Lancashire and South Cumbria NHS Foundation Trust. Also, more recently, he is working as the consultant psychiatrist in rehabilitation and low secure services in Benin Care NHS Foundation Trust. His clinical and teaching interests are in resistant affective disorders, anxiety and stress-related disorders, psychosis and suicidal risks, psychopharmacology, and also his expertise are intensive in CBT, ECT, interview skills, and managing, leading, organizing skills, ADHD, and ASD, and personality disorders. Actually, Dr. Shahid is really very active in learning and in CME activities in Manchester. Myself, I attended so many of his well-organized conferences, and it's our pleasure to see him with us today. So please share me and welcoming Professor Shahid, or Dr. Shahid, because he refuses that I name him as a professor. Thank you, Dr. Omar. Dr. Shahid, please come.
Thank you, Madad, for your very kind introduction. You are going to listen slightly different theme now than what you have been hearing in the last 2 days. When this conference organization began, I was asked by Madad if I can talk about career opportunities. The same work I have done previously in Pakistan, but I'm really glad that I'm talking through this platform. I know that lots of people from many other countries are listening and attending this conference. My disclosures are that I have not any personal agenda for this presentation. I have not been paid to make today's presentation, although it is, you can see that I have received some educational grants. Right, why I'm going to talk to you about this, what is important about me, because I work in the NHS as a psychiatrist. I'm a trainer, clinical and educational supervisor, and I'm interested in medical education. And more importantly, I'm interested in seeking opportunities from learning from other colleagues and providing information to other colleagues, likewise to seek opportunities elsewhere to gain further experience that they can take back to their respective countries. I mean, NHS is a huge organization, and these opportunities are perhaps more available since the United Kingdom has gone through Brexit. We no longer are part of Europe. Although geographically we are Europe, but we are not part of the European Union. I mean, I'm going to discuss today briefly about the United Kingdom, what it can offer, which I'm sure most of you would already know, NHS, National Health Service, and its organizational system, and how does medical workforce work. And in order to work as a doctor in the United Kingdom, you have to be registered with the General Medical Council, and how you go about it. As this is a psychosocial rehabilitation conference, so it is assumed that most of us would be related to mental health. As I am a doctor, so I'm going to mainly concentrate this talk about how psychiatrists work in the NHS and in the United Kingdom. Although this talk is not going to be providing any different information to other doctors who may wish to come and work in the NHS in different specialities. United Kingdom, as you can see geographically, it is divided in 4 countries, which is England, Wales, Scotland, and Northern Ireland. I mean, it comprises big cities like London, Manchester, Scotland. At the same time, it has a lovely landscape and countryside. People who want to come and work in the United Kingdom perhaps need to be aware of the weather. Sometimes in winters, weather can be a bit difficult for people coming from warmer countries. Traditionally, United Kingdom and NHS is relied on overseas doctors, mainly from India, Pakistan, Bangladesh, Sri Lanka, Arab countries, Nigeria, and other African countries. NHS is a very huge organization, 5th largest employer in the world. It has a huge budget, as you can see, 160 billion, and it works on the universal principles, and these principles are equitable, provide quality of care, and important thing to note is that care that you receive in the NHS is free at the point of delivery and is centrally funded. When I say provided free at the point of entry, it doesn't mean that people are going to pay for their medical care. Although it is true that some people can go and get private health care. How to get into the UK, get registered and help you to practice medicine there? There are many routes, and one is that obviously if you are a local UK graduate, have a medical degree from one of the UK's medical schools, you go through natural training, which has changed in the last 10 years, and the terms that we used are slightly different than maybe used in other part of the world. We have 2 years foundation year program, which previously called as house officer, and I think in many countries still these terms are used. And after foundation year, people go and join the core training. Core training enables them to pass the relevant exams. With respect to psychiatry, people have to pass MRC Psych examination before they secure a specialist training. And once they complete the specialist training, they can go and secure the concerned post. Of course, there are, as I said earlier, that NHS has relied on overseas doctors, so international medical graduates are not unknown quantity to the UK healthcare system. How international medical graduates can get into the system? I mean, there are 2 ways. Either they get PLAB or get exemption from the PLAB. PLAB is 2-part exam in which there is a written component as well as clinical component, and it also has other component which is linguistic. People have to pass ability to communicate in English language. And then people again go through the same process of going through foundation year training, core training and specialist training and becoming a consultant. But those who do not achieve all these stages, there's another route that has recently become available since 2005, and that is called Article 14 or CSER. CSER stands for Certificate of Eligibility to Specialist Registration. Now, service framework is based on service posts and trust doctors and training posts. And training posts further leads to specialty posts, as I said earlier. And some people go and secure locum consultant post because they have not gone through a proper training, and then they can go through CSER. When you're working in the NHS, there are national contracts. There are universal national acceptable contracts. And training, if people who are in training is a part of the contract. And during training, people go for the courses, expenses are paid. And your practice is also covered by indemnity. And people who work in the NHS, they also enjoy the pension schemes. I mean, there are different contracts, training contracts, middle tier contracts. I mean, the trust grade doctors are consultant contracts. I mean, you can see the pay scales are mentioned here from 25,000 to 114,000. 114,000 is the maximum salary of a consultant as we speak today. Although, many consultants do earn more than 114,000 because of different work that they do, or extra PAs, or if they've got merit awards. Well, salary ranges, as I mentioned, from 76 to 114. That is for the senior doctors. And whilst we're working as a senior doctor, people get study leave. Like, I have come here to attend this conference, so I have been granted a leave, although I have not been given, because I didn't seek any budget, but there's a pot of around 1,000 pounds a year. So 3,000 pounds in 3 years, people can go and get used towards their study leave. And people can get 10 calendar days in a year as a study leave. I've already mentioned that people who work in the NHS, they become part of an NHS scheme. And roughly we get about 6 weeks annual leave, and 10 days I have mentioned as a study leave. Some people do go and get lease car schemes, and people who are coming from overseas, they can get relocation package as well. It is negotiable, but and definitely minimum people are going to get is about 8,000 pounds. I've already mentioned grades. There are training grades, middle tier, and consultant. I mean, all of them require a GMC registration. Without GMC registration, you cannot work. There's another thing as a psychiatrist that you have to be able to be Section 12 approved. What it means that when people who requires to be treated under Mental Health Act, in order to admit those people, doctors have to be Section 12 approved, which is authorized by Secretary of State. Usually, it is expected for doctors working as a middle tier because they will be working in community. And there's an AC approval. AC approval, usually ACs are consultants. AC stands for approved clinician, which means that they are not only admit and treat people, but they can discharge people as well. And besides discharging them, they can subject some patients to other mental health acts, such as community treatment order. A specialist registration is required only for the consultants. GMC registration, I did mention that one route is if you have locally graduated in United Kingdom. Second, I've already mentioned is PLAB. But there are other routes. Some people can get exemption from PLAB. Who will get exemption? I will be talking in a minute. And then there are sponsorship schemes, and there's a college sponsorship as well, MTIs. And everybody who wants to come and work in United Kingdom from overseas must be proficient in English language. So there are English language exams, one of which is IELTS. I'm sure you are familiar. And I know that there are others these days available and which are recognized and approved by the General Medical Council. PLAB, I've already touched upon, this two-part exam. Exemption from the PLAB. Who can get exemption? As of this year, in January 2021, people can get exemption from PLAB if they have previously passed licensing examinations for different countries, such as USMLE, Step 1, Step 2, and AMC, MCQ examination and clinical examination are MCCQE, Part 1 and 2 in English, are acceptable postgraduate qualification. Acceptable postgraduate qualifications are because nowadays I'm sure most of you would be aware that many of the Royal College's examinations, you don't have to come and take examinations, even PLAB these days, Part 1, you don't have to come to England or United Kingdom to come and take the exam. You can take exams from different centers, and I know that Abu Dhabi or United Arab Emirates is one of the centers. Likewise, there are other Royal Colleges examinations that can be taken outside United Kingdom. So if people have passed, MRC Psych, MRCP, MRCS, or MRCGP, they can get exemption if they have not previously worked in the United Kingdom. If they have passed these examinations solely based on their training overseas and have passed these examinations outside United Kingdom, but examinations of one of the Royal Colleges of United Kingdom. However, there are conditions to this. These examinations must have been passed before a certain date. For USMLE on or before 13th of March 2020, AMC on or before 5th of March, MCCQE on or before 27th of October. And other condition is that that you must have passed these examinations within 4 attempts. And if you have set these examinations more than 4 times before passing, you will not be eligible. And it's important to note that after passing these examinations, if you have set PLAB examination and failed, then it will be difficult because you must then pass PLAB. So either don't take PLAB and make sure that you have passed these examinations before coming and working in UK. Or if you are taking PLAB, then make sure that you have passed it. Otherwise, it will be no. Now, sponsorship, MTI, if you go on to Royal College of Psychiatrists website, it's a medical training initiative for overseas qualified doctors who have some experience, minimum of 2 years in their specialty. I'm talking about psychiatry, so we're talking about psychiatric experience in their own country. And in some instances, if they have got postgraduate experience and postgraduate qualifications from their respective countries, then they can, some instances, get a direct sponsorship from employers, although it is very rare and it depends on needs basis. And then these doctors are supported to go through CSER. CSER, as I've also mentioned, it is a certificate of eligibility to specialist registration. This came into being in 2005. It was a PMETB, Postgraduate Medical Education Training Board. Now all the responsibilities have gone to General Medical Council, GMC. People have to maintain a portfolio. In portfolio, they have to produce evidence that in 5 years' time, they have gained the required competencies which would otherwise be expected by doctors who have gone through a natural training process in United Kingdom by core training and specialist training. And then there are other things that they have to show, such as they have learned from complaints, they have learned from serious incidences, they have done some research, and they have learned from case-based discussions, and main thing is reflection. And besides these, they have got a 360-degree feedback from their colleagues and patients. And I'm sure if you are interested about CSER, if you go on to General Medical Council website, you'll find more information. Now, private practice, if people who are interested in private practice, I mean, it is not impossible at all, although private practice is limited. And there are organizations, private organizations, who can employ doctors who are registered with the General Medical Council. And they look at your credentials. They also provide training and development. They also pay the expenses like an NHS does for further CMEs and CPDs. They also provide you indemnity, and they also make you part of their pension. But pension schemes in private sector are different than NHS. And also in private sector, you can work as a locum or a permanent employee, and their main employers in private sectors that I know are Priory, Bupa, Signet. And if you go on these organizations' website, you will find if they have got roles available. Now, people who come from overseas, it's very important for them to know what it is like to practice in UK and what is expected of them. You need to understand the services. Everything goes through primary care. Everyone is registered with their general practitioner. And general practitioners will see and assess their patients, and then they will refer them to secondary services. And secondary services will decide whether to refer them to tertiary services. I mean, you can see that family doctors earning, in some cases, can be more than what Prime Minister's salary in the United Kingdom. Now, mental health services, how mental health services are organized. I mean, there are, as I said, that entry to the system is through primary care. And primary care, patient will come into mental health services either through assessment teams or crisis resolution home treatment teams. Assessment teams will make assessments to decide whether that person needs inpatient service or a community service. Or if they need an inpatient service, they will decide whether they need to go in hospital or they can be managed acutely in their homes by crisis resolution home treatment teams. And at that same time, at the point of entry, if it is a psychotic episode, patient has experienced psychosis for the first time, then they will be referred to early intervention services. I mean, this is a conference on psychosocial rehabilitation, so I must not forget to mention that all these services do provide psychosocial interventions. And these are provided by multidisciplinary teams. These include doctors, nurses, psychologists, social workers, occupational therapists, and support workers as well. And we very much closely work in collaboration with the families and carers, because everyone in UK is not living with families. Some people live with carers. And if they are not acutely unwell, they are not requiring inpatient or crisis resolution home treatment team, then they will go to the community mental health teams. One thing I forgot to mention is that at the GP point, people who have a common mental health problems, they do not need to be referred directly to the mental health services. They can refer them to IAPT. IAPT means it's an entry to the accessing psychological therapies. And then when people get recovered from hospital, they will be referred back to initially to home treatment or crisis resolution home treatment team, from there to community mental health team, and then back into community to their GPs. And of course, we're talking about mental health. Some of the patients will stay with community mental health teams longer than expected, and in many cases, some may require rehabilitation on an ongoing basis, so they may be referred to specialist services, which are called tertiary services. Now, what we need is, in order to practice mental health, we have to be registered. We follow the BNF prescribing guidelines. There are other guidelines in the United Kingdom, so NICE, the National Institute of Clinical Excellence, they are CQC. They are Commission of Center of Quality Commission. They have also guidelines, and they monitor the services, and there are college guidelines as well. I've also mentioned Section 12, means that there is a Mental Health Act law in the country, so people are treated where required under Mental Health Act. But Mental Capacity Act is important. It also came into 2007, where we have to ensure when we're treating patients, they have a full capacity. It is assumed that everyone has a capacity unless you prove it otherwise. People have to be treated within Human Rights Act and Data Protection Act. Yesterday, I was listening to one of the speakers who were talking about electronic records. And electronic records, it's very important that the things that you enter into that and make sure that it does not breach the confidentiality. And there is also Children's Act present, means that these patients we treat, if they are under, living with patients, with the children under a certain age, then there are safeguarding issues for patients as well as for the children. So there are laws available in the country to practice within those boundaries. Now, Brexit, I think these slides are slightly older. I mean, it happened a few years ago. I mean, we have gone through that. We have left the EU now. And now, even if you are an EU graduate, it does not naturally exempt you from the PLAB. You have to pass the PLAB examination, even if you are a European citizen and have passed examination after a certain date. Right, we talk about pension, we talked about salaries, and these salaries are subjected to taxes. So you need to be aware that the taxes that you might pay. Other thing, in order to practice medicine in United Kingdom, you have to be revalidated every 5 years. In order to get revalidated every 5 years, you have to be appraised every year. So one 5-year cycle is completed and you have got acceptable appraisal portfolio, then your RO, means responsible officer, which usually is a medical director, will refer you to General Medical Council for revalidation, means that you're continuing your license. What it requires is to maintain a portfolio. And portfolio, what it needs is that you're maintaining your knowledge and skills. Means that you are attending CPD conferences like these, and you are learning from it. And you prove that you're learning from it not only by attending and showing a certificate of attendance, but you must have reflected on learning. You have a 360-degree feedback from your patients, from your colleagues, and colleagues does not only include doctors, it includes all your colleagues who you work with. It may be a porter or a sweeper in your hospital, your secretary, your manager, your nurse colleague, your occupational therapist, your social worker, psychologist colleagues. You must do case-based discussions, and you must adhere to audit and quality. This other thing also is called probity and health. You must maintain a good health. Does not mean that you don't, people after a certain age do suffer from certain conditions, particularly like you can see I'm an Asian guy, hypertension and diabetes are not uncommon in our age. But what health means that your health should not affect your ability to practice. And probity is that you are honest. You make clear declarations, like at the beginning of these talks, you have noted that speakers now make declaration that what kind of benefits they have got from where. I work in Manchester, but I live in Lancashire. So I just given you, this slide that each county has their own localities of practice. When I said I live in Lancashire, and although I did work in Lancashire until October 2020, it's only in October 2020 when I moved from Lancashire to Manchester and Rochdale and Pennine Care. These both are in Northwest. Northwest has 3 big areas to cover, which is Manchester, Lancashire, and Liverpool, which is called Mersey Care. Now, surrounding areas, there's a Manchester, there's a London, about 2 hours. I'm just giving you, it's an idea. It doesn't mean that you have to come and work in the Northwest. It means that everywhere you go and choose, transportation is very convenient. You can commute easily. I live in a countryside, about 17 miles from Manchester, so I can get there in 20 minutes. Now, obviously, this was a workshop, and I had expected that we will have discussions, and I think I'm close to the time, but I'm happy to take any questions that you have. But before you have any questions, I would urge you to take note of these websites. There's a Royal College of Psychiatrists website. There's a www.jobs.nhs.uk. Through that, you can find the jobs, what the jobs are available in the United Kingdom. There's one website that I must have put in, is a GMC. I'm sure you'll find it. It is www.gmc-uk.org. And when you have found a job through Jobs NHS UK, then you find email contact with a medical recruitment of that particular hospital. You can call human resource, you can contact medical director to have a telephone conversation about what they can offer and what your expectation is. And make sure that you read the job description. And when you look for the jobs, you will find that those organizations are also available on Twitter and Facebook. So you can find a lot more information about them. Thank you very much. If you have any questions to ask for colleagues present in this hall or colleagues who are listening online. I guess no questions. In that case, I would like to thank you all for your patience and listening to me. Thank you very much.
to have the plenary as a keynote from the President-elect of WAPR. It's an honor to have Dr. Gabriel Rocca here in Abu Dhabi, and he came all the way from Italy, and we are honored to have him. Dr. Gabriel Rocca is a psychiatrist and psychotherapist. After having actively participated in the Italian psychiatric reform, which realized a mental health system without psychiatric hospitals, he directed the Corpore Institute in Lambiat, Milan for 9 years, from 2006 to 2014. And in this context, he carried out social inclusion projects for individuals with autism spectrum disorders. In 1988, he began his psychoanalytical training, and since 1996, he has been a professor at the Postgraduate School of Psychotherapy in Padova and Milan. Since 2020, he is health director of the Solaris Social Enterprise. The fields of interest are constituted by residential care, history of psychiatry, and rehabilitative models in psychiatric care community-based. He's, of course, as I mentioned, the president-elect of WAPR, and shortly, maybe after a couple of months, he will be the president of WAPR. So please join me welcoming Dr. Gabriel Rocca. Please.
I can. Good morning to everyone. Thanks, Medad, for introducing me. And thanks to the technician, because they supported in a critical situation. Many thanks. Yes. Distinguished delegates. The Congress is proceeding to the closing session. And we can say that the Congress, it has been a significant opportunity for discussion and debate despite the pandemic crisis. And I would like to start my presentation talking about the impact of the pandemic crisis on mental health systems. Well, a WHO survey realized in 2020 shows that in all countries, mental health psychosocial support is recognized as an integral component of their national COVID-19 response plan, without a specific budget, but they were recognized. Mental health services continued to operate. In fact, in no country, their complete closure has been reported, but in only 7% of responding countries were all services fully open, only 7%. In the remaining, there were disruption of essential services and interventions. The services most affected were community-based outpatient services. More specifically, suicide prevention programs, home or community outreach services and interventions for caregivers were completely disrupted in more than 20% of countries. The percentage of disruption was different in different areas, higher in low and in lower middle income countries, and lower in high income countries. It's clear that outpatient services and community-based services were more impacted compared with inpatient facilities. with full or partial closure in more than 40%, and home care and daycare services reaching levels of full or partial closure in 60–70% of countries. Furthermore, according to WHO, half of COVID-19 deaths in Europe have occurred in elderly care facilities, which have become the places of greatest spread of the pandemic. Frequently, these facilities hosted hundreds of beds where people were admitted because no longer self-sufficient. They are large institutions which host hundreds of beds, institutions full of sufferances, strict rules, and patients who have lost a significant part of their own personal history. These structures turn out to be dangerous and pathogenic, just like the psychiatric hospitals. And as for the psychiatric patients, we need to deeply question the tendency to institutionalization of elderly as the usual response to various kinds of disability. Also, dramatic experience as the COVID-19 clearly show that health services community-based are needed to ensure the health of the population, because an health organization founded on hospital and large residential structures will always be more expensive, less efficient, and unable to respect human rights. And this is even more true in this field of mental health, where a model of care centered on the disease and not on a person, with his history and his social relationships, will never be able to respond to the needs of health that come from users. During the first phase of pandemic, the Italian branch of WAPR realized the survey to know the staff point of view on what was happening. We presented the result in a specific symposium. Regarding the specific condition of patients, a significant percentage of those who answered to the questionnaire believed that people living alone seemed to be those who suffered the most from the reduction of activities, irrespective of the severity of psychotic symptoms. To identify and take care vulnerable groups, we must consider family factors and, above all, social determinants, which in terms of prognosis and therapeutic indications tell us much more than the diagnosis. The economic situation and healthcare are now worsened in many countries due to the pandemic that has increased inequalities, impoverished social and health services, made people's lives more uncertain. But it's really difficult, or rather impossible, to provide comprehensive, integrated and responsive mental health and social care services in community-based settings if 70–80% of national mental health budgets are used for psychiatric hospital and long-stay inpatient facilities. The direction to proceed is that of deinstitutionalization. If the mission of our association, the WAPR, is to improve the lives of users by promoting psychosocial rehabilitation, we must strongly affirm that our first goal, which can no longer be postponed, is the closure of mental hospitals. Mental hospitals are not only antitherapeutic in themselves, but very negatively affect every other care activity in the community as well. In psychiatric hospital and other long-stay inpatient facilities, people are not treated, and frequently they suffer human rights violations because they are deprived of social contacts and health treatments, and they are subjected to restraint and other forms of violence. The processes of deinstitutionalization put an end to these violations and allow the affirmation of those rights stated by the Convention on the Rights of Persons with Disabilities. I'm referring to right to accessible and affordable mental and physical health care, right to live independently in the community as other citizens, right to work and opportunities to work, right to determine their future and make their own life choices, right to recognize the equal before the law as other, and the right of full protection of the law, right to be included in the community, right to respect for private life. The crucial aspect is the will and the ability to go beyond the confusion between social protection and recognition of fundamental rights. The Convention advocates a reversal of perspective. Disabled people who are usually subjected to protection and care must become rights holders. Disability questions everyday life, spaces and time. It forces us to imagine a different way of living it by finding new skills and new abilities. The Convention offers the possibility of modifying social and legal relations and pushes the institutions to intervene to neutralize the lottery of nature, which creates inequalities. To overcome these inequalities, it's necessary to ensure social inclusion and participation, as well as access to high-level social and health services. But we cannot forget that the first right is that of access to the exercise of all rights, with full respect of inherent dignity of the disabled person. As claimed by the WHO, Quality Rights Toolkit, some of the worst human rights violations and discrimination experienced by people with mental disorder is in healthcare settings. We know that coercion is widely practiced in inpatient facilities. Globally, the rate of use of coercive measures in the literature varies from 0.4 to 66%. Great variability and very high rates. The UNOMA multi-center project was conducted in 12 European countries. The result you can see, 38% of patients compulsory admitted had coercive measures. And the variation is from 21 to 59%. There are very severe physical harms to death during restraint procedure, and also severe psychological consequences. Post-traumatic stress disorder, fear, humiliation, degradation, shame, sadness, loss of trust in staff, and experience felt like an aggression and abuse. Clinical practice should follow the principle of evidence-based medicine. Instead, is there no evidence of the usefulness of coercive measures? At the opposite, they are very dangerous. It follows a dramatic clinical paradox. Despite the lack of evidence, coercive measures are commonly used in adult psychiatric clinical practice. The reduction of coercion and compulsory admissions is a mandatory commitment for all of us, for our association, in all countries. To achieve these results, we must operate on various levels. First of all, it's necessary a legislative framework inspired by full respect of human rights and also a network of community-based recovery-oriented mental health services. At the operational level, a recent review provides clear indications. The review emphasized the efficacy of staff training to reduce use of restraint, and the evidence on the efficacy of shared decision-making and on integrated care interventions to reduce compulsory admissions. By contrast, I would like to highlight that community treatment orders and adherence therapy had no effect on involuntary admission rates. And stable training activity is also crucial because coercive measures tend to repeat themselves and therefore require specific attention over time. These evidences are in accordance with the user point of view regarding the use of the coercion. About this, users ask improvements in two key areas: the way mental health professionals relate to users, and the alternative forms of treatment and the variety of service options. Users are very clear and give us specific indications. During the COVID-19 pandemic, all of us have lived a condition similar to the one experienced by people with a mental health problem every day. We have lost the opportunity to choose, to discuss the treatment plan with the doctor and the other professionals, to say what we want or don't want. And even now, we are using vaccines without knowing how long they will be effective and with what possible side effects. We had lost the power to decide and determine our future, and we have suffered for this uncertainty, for this lack of power. Users have been frequently in situations when their needs are not adequately met and when they are scarcely involved in the decision that concern them. Their lives are completely in the hands of the professionals. Users are asking for opportunities to choose, influence and control their own care plans and lives. This is an important part of the empowerment process, which can allow positive outcomes and can act as a protective factor against levels of disease risk, other risk. Yes, another issue. The protagonism of users can affect also the research methods, because they explain that the double blind is in contrast with the possibility to participate to decide their treatment plans. And then they are asking an health ethics perspective that is opposite to the randomized assignment. So, researchers, people with mental illness, and caregivers should rethink our medical trial designs. In a wider perspective, service users' involvement goes beyond the strictly clinical dimension. It aims to create the conditions to face the ever-present risk of discrimination and social exclusion, since users frequently encounter social and structural barriers, resulting in stigma and difficulties in accessing work and any other activity. Service user involvement is articulated in various forms and at various levels based on specific experiences and local as well as national and international policies. Starting from the situation in which people attend services as passive recipients, it's possible to reach co-production services with the help of different tools, such, you can see, information, person-centered approach, informed decision-making, user views and feedback enhancement, participation of association. Is a progressive activity that can help us to move from the passive situation to co-production. In such a way, one could realize a shift of power from professionals and politicians to the public, while promoting the growth of democratic participation and the capacity of people to intervene in the management of health care. The power can move from professional and politicians to public. But despite these political and social dynamics have emerged in all their importance, has been a neglected topic in global mental health. And most states, regardless of income level, are falling behind in promoting regulatory frameworks and practices that end discrimination in the field of mental health. In this perspective, the involvement of users and family members is put at the very center of the human rights issues, since mental health is a fundamental right in itself as an essential component of health. People should have the right to access quality mental health services, to express their will, to decide and make choices about their lives without encountering obstacles and social barriers. Ultimately, user protagonism aims to promote the transformation of power relations between individuals, communities, services, and government. WAPR, the WAPR, has always collaborated with service, user, and family association. Besides the awareness of the complexity and importance of these issues, urges our association to make an even stronger commitment. As an international association, we must make more systematic use of lived experience and experience-based knowledge in developing our organization. For this reason, it's essential to strengthen service user and career participation within the board. We need to make sure that their vision influences the debate and the organizational choices. For this purpose, I would like to present 4 levels of proposal. First level, board of director. At the level of the board, we can increase the number of representatives of service user and family member within the board of directors. And then we can establish a committee with specific tools. You can find and try these proposals in the bulletin of our organization. But the committee can suggest initiative that foresee the participation of users and the family members, programmatic and policy documents, a document to share with the media on how to deal with issues of mental health, and relationships with WHO and the United Nations to keep a regular dialogue on the issues of the development of community mental health services and human rights. At the level of regional activities, it's very important that in each regional section, we can organize meetings with media representatives to define how to deal with the issues of mental health, facilitate the representation of user and family members in the institutions, promote and support associations of users and family members with initiatives at a social mental health service level. Third level, training, different programs. You can, for family members, for users, and careers, interaction between users and health professionals, local service management opportunities, service planning. The main goal is to support professionals in changing the values and attitudes that can be both a barrier to an enabler and engagement. Before, during a symposium with the chair was Max Lachman, frequently the speakers said that very important for the patients, for the recovery, for the empowerment, the change. But the change is very important also for our professionals. Both we have to change, patients and professionals. And then we can provide a specific section in the bulletin. I think that the editorial group can accept this proposal because in the direction that they are since, I think, 2 or 3 years. Well, conclusions. In the area of human rights, we still have a long way to go. However, we can become aware that some changes, some new aims can no longer be postponed. This is the commitment that WAPR can and must make. Many thanks. Many thanks to all.
very close to it. Okay. Okay. Are we ready? Hello, everybody. My name is Audun Pedersen. I am the Senior Advisor for Mental Health in the city of Bergen in Norway. And I am very happy to be able to share with you two of the projects I have been involved in my city. And it is about art, culture, and recovery. On this Congress, we have talked a lot about citizenship and social inclusion. And in this symposium, I like to share with you how it can be done in practice. Many of our users, they tell us that to be able to be creative, to get the support needed to be creative themselves, or also the support to have access to experiences, art and cultural experiences, is for them very, very important tools for their own development and recovery. So the first presentation will be from our Department of Culture in the city. The speakers will be Livelin Remme and Fanny Holmin. And they have called their presentation Art, Culture and Mental Health, Social Inclusion and Citizenship.
Sing, play, draw, paint, write, create, live, see, breathe, feel, listen, perceive, laugh. Curious, seeking. Alone, with text, image or tune in your mind. Together, at courses, events and workshops. Share experiences, interaction with others. On the way to something out there. Unbalanced, or perhaps healthier than you thought. In any case, fanciful, playful, creative, sensitive, life affirming. Hi, my name is Livelin Remme. I work as an advisor in art, culture and mental health in the city of Bergen. I have a degree from the University of Bergen in the subjects of art history, cultural dissemination and visual communication. I have been working with the art, culture and mental health since 2004 and also developed new programs like Room for Thoughts, the Cultural Happy Pill, different courses and exhibitions. The art, culture and mental health work in Bergen focuses on people's resources, interests and potential. An essential aim of the project is to involve creative and performing artists in work for and with individuals with mental health disorders. The target group includes persons with severe or minor mental disorders. Reducing the prevalence and prejudice about mental disorders in general is also a central task. One of the primary aims is to stimulate increased participation in arts and the arts by former and current mental patients. At the same time, we seek to make available to the participants experiences, opportunities for involvement, and exhibitions of their creative work in various art forms. Our work takes place in the area between mental health and art. We receive feedback that primary focus on the artistic viewpoint gives participants the feelings that their identity as patients takes a backseat, and this in itself is inclined to give people with mental disorders greater dignity. This applies both to the way they regard themselves and the way the world around encounters them, the view of society at large. The focus on resources, interests and opportunities is well received, and we find that it is vital that the participants are taken seriously as regards their interests, in exactly the same way as with anyone who chooses to participate in a course or an activity. Art, culture and mental health in the city of Bergen started as a project in Bergen in 2002 and has since then been financed 2/3 from the Department of Work, Social Service and Housing and 1/3 from the Department of Culture, Diversity and Equality. And it all started with the parliamentary report, A Plan to Strengthen Mental Health from 1998. It says, a person with mental health problem must not just be seen as a patient, but as a complete person with body, soul and spirit. Necessary consideration must be taken to a person's spiritual and cultural need, not just to the biological and the social. Mental illness touches basic existential questions. A further aim of the art, culture and mental health at the outset in 2002 was to acquire commissions for professional artists. Jon Onstad, a ceramic artist who worked in this field for years, says that the work is important because it heightens awareness and includes people who find it almost impossible to make their mark in the public sphere, and consequently are on the outside. Art, culture and mental health makes it possible to enter the public sphere and makes them once more active participant in society. Christine Hoem, a visual artist who also worked in this field, describes the work in art, culture and mental health has contributed to strengthening the self-image of people with mental health issues in relation to creativity and involvement in creative processes. Feedback from participants indicates that adaptation according to their interest in art and cultural activity provides an experience of enhanced dignity. You are exposed according to what you express through your art, not as a patient. It results in you seeing, thinking about and defining yourself in a different way. Furthermore, the outer view of society seems to change so that you are seen according to your resources. Those of us who are involved in this work also experience that the work to a great extent is about the value and dignity of people, about having respect for people's standpoint, about adapting so that participants can find the force within. A socially inclusive society which seeks to avoid social exclusion adapts for participation and equality irrespective of origins. Opportunities to take part in activities and experiences within, for instance, art and culture must be experienced as possible and available to those who want it and on the premises of the participant. Universal design is in fact not only about demolishing physical barriers, but also about breaking down mental barriers and prejudice about mental health. It is the responsibility of our collective ego, society, to create a society that receives, that accepts mental illness, and that meets openness with respect and humility. Everyone, irrespective of origins, shall have the right to participate actively in society. Which leads me to introduce to you Fanny Holmin, the editor of our journal Kraftwerk. Welcome, Fanny.
Thank you very much, Llewellyn. Hello, my name is Fanny Holmin. I have worked as an editor of the journal Kraftwerk since 2007. In 2015, I studied connection between creative writing and quality of life among writers in Kraftwerk. That was a part of a master's degree in health and social science. I also have a background as a poet and stage artist. So let me tell a bit about my work with the journal. Every year, we present a collection of poems and short prose. We have 2 annual editions. One is online, as I will show you later, and the other is a paper edition, like this one's. By the way, the word Kraftwerk, it means a power station. I work together with an editorial team that has professional background as writers and authors. Together we do the selection of texts and we give the writers feedback and strategies to develop their writing. We work with a lot of texts every year from our partners. And many of our participants write for us for several years. And in that case, we become like a red thread in their creative process and in their lives. Over the years, I guess hundreds of people have taken part in our offer, the journal, and also a lot of writing courses. We celebrate each edition of Kraftwerk with a launch, an event with music and readings that is open and free to everyone. The texts cover a wide range: poetry, prose, and short stories. Every second issue is a digital. You can have a look at this. Our aim is to facilitate for participating in activities. We are not an area for art therapy or for writing therapy. Instead, we arrange collaborations where our participants could develop artistic skills. So why do you work like that? Creative writing is an active and conscious action using resources and skills. The act of writing is a way of being in relation to oneself, a way of meeting and understanding oneself. To contribute something that has a value and to see that what one has created may also be a value for others, for the reader, gives people self-respect. Literature seeks outwards from normality into originality. The poet looks for something unusual in combinations of words. The unusual gives us new ways to look at the world. To further illustrate the value in our way of working, I can highlight some feedback by our participants. This makes a place for experience based on my interests. It gives structure and focus. I can see that I am not alone. I can concentrate at artistic activity. I am seen as a creative human, not as a patient. The joy of creating. Self-confidence, development, security, social network, and information about possibilities, activity contra passivity. The political guidelines of today say that the health sector must develop a broader perspective on health, with a focus on quality of life, coping, and resources. It makes sense to look at creative writing from a value issue, also in context between culture and health. Writing is a way for people to speak up. It is always a right, an entitlement. Writing can have a healing effect, but creative writing is founded on other objectives than the wish to get well. Creative writing is having a purpose in itself. The connection between culture and health does not appear streamlined. The right to be a part of a living culture and to express yourself should also be open to groups who struggle with illness.
Thank you, Fanny. We do not disagree on this. Sometimes a picture hits you right in the gut, painfully, or as something delicate and beautiful. Words may describe something we have experienced ourselves or teach us something new about life itself. Music can make us want to sing, dance, or weep. The oldest known cave painting is about 40,000 years old, and there is reason to believe that music as a form of expression is more than 50,000 years old. Throughout the ages, people have had a need to express themselves through words, music, and images, which in turn move us and enrich us, leaving their mark in different ways. The intrinsic value of art, the impressions and realization left by an encounter with the arts, the cohesive force and joy arising from participation. If we are lucky, these things may cause us to experience a greater quality of life. They may also give us the courage and enthusiasm to take new steps in our life. Einar Sagen, one of the writers in Kraftwerk, says, Kraftwerk has exerted an insane influence on my development in writing and art. Not only that, but also on my self-esteem and my health. In the program Room for Thoughts, Art, Culture and Mental Health offer opportunities to meet professional artists in creative activity, in various techniques and expressions, while simultaneously meeting other participants with shared interests. The idea behind Room for Thoughts is that people in the target group will be offered to work with their own work under the guidance of professionals in various arts. The teaching takes place either in the workshop or studio or other suitable premises that provide good practical arrangements. One acquires skills in various creative forms of expression through action, activity, involvement and participation, through trial and error. Participants meet artists, authors and musicians and also have the opportunity to experience creative processes over time in the company of others. Like, for example, this little animated film, Nikolai, made just for the fun of it. The UN Convention on the Rights of Persons with Disabilities was adopted in 2006 and came into force in 2008. Article 30 on participation in cultural life, recreation, leisure and sport requires signatory states to take appropriate measures to enable persons with disabilities to have their opportunity to develop and utilize their creative, artistic and intellectual potential, not only for their own benefit, but also for the enrichment of society. Special Advisor Audun Pedersen at the Department of Work, Social Service and Housing referred in an essay in Kraftwerk number 40 from 2011 to a film by Patricia Deegan, where she referred to the concept of turning point. For most of the participants in the film, people with mental health issues, the turning point was an encounter with another person who saw in them something they had not seen themselves. The encounter could be random and very mundane, sometimes with a health professional, but often with others. The common feature of these encounters was that they involved something genuinely human, not therapeutic techniques, just a meeting person to person, not studied and planned, but spontaneous and natural. Audun Pedersen also writes that helpers must to a much greater extent have a conscious attitude to society at large. We, as helpers, must additionally find the human side of ourselves and not be afraid to use it. None of our therapeutic techniques can replace us as living beings who meet others with equality, interest and openness. The best we can do in our interaction with others is to see one another as people, to meet one another with respect in all our differences. Human diversity is exciting, and I sincerely believe that when we make it possible for everyone, irrespective of their background, to develop and utilize their creative, artistic, and intellectual potential, it will not only enrich the individuals concerned, but it will enrich us all. Like this exhibition, which can be seen at our web gallery, the exhibition Air Balloons, made by old wooden industrial spools, inherited from the artist's grandparents who worked in textile industry. Art, culture and mental health are also the organizer of the Cultural Happy Pill. We offer a diverse cultural program at activity houses for people with mental health issues. We regularly arrange courses, concerts and performances. The offer within the Cultural Happy Pill is especially aimed at those who, for various reasons, have problems seeking out cultural offers outside of the activity houses. We live in a society with great differences, far greater than many of us are aware of. The arts are not perceived as something available to all. We therefore permit ourselves to be proud of our program in the art, culture and mental health in the city of Bergen, which makes just such experience and participation available for more people. Arne Løving, a Norwegian author and psychologist, previously diagnosed with schizophrenia, now working as a senior advisor and a researcher at the National Center for Experiential Competence, says, "We are all more than our problems, and we all have the opportunity to be something other than what we are just now. For the world is not, it becomes, and we are the ones who create it." Thank you.
Thank you, Libelin and Fanny. I know you are looking at this back home in Norway, and I am really proud to present this project for my colleagues all over the world. We will move on to the next presentation, and it's in a way it's more of the same. In 1999, a user with a bipolar disorder in the city, he wrote a lot of letters to the politicians in Bergen to have a user-managed creative house. He was not very satisfied with the municipality's offers, and he asked for an opportunity, financial support, to make something they could decide for themselves. And the answer from the city board was some money, and that we should cooperate with this initiative. Today, the leader of this house is named Åse Toskedal, and the house is named after a famous Norwegian author, Amalie Skram. So this is Amalie Skram's house. She was hospitalized several times in psychiatric hospitals in Denmark when she lived, even if she was born in Bergen. So the presentation from Åse Toskedal and the members of Amalie Skram's house is titled Recovery, Creative Activity and Personal Development. The screen is yours.
Hello, Abu Dhabi. My name is Åse Toskedal, and I work as a manager at Amalie Skram's hus in Bergen, Norway. Our mission is to provide an environment for life unfoldment and creative development. Our target audience are people who have or have had mental challenges. At Amalie, we relate to people the way they are right here and right now. People are not referred to as clients or patients, and diagnosis and previous history is not our focus. At Amalie, they are our members and only our members. User participation and control is at the core of our activity. Amalia is governed by members on all levels. The majority of the board members are elected from and by the members. So, members actually has the final word when they hired me as their manager. Through our weekly house meetings, the members may also influence the activities that are in focus at any given time. And finally, members are actively participating in the day-to-day operation of our community. Our philosophy is based on recovery-oriented principles. Our focus is on each individual's own personal and creative development. Our goal is to be an arena where the members can develop through their own choice of activities, supported by our staff of accomplished artists. It is our belief that our members' recovery processes are greatly enhanced by allowing them to develop and show their individual creative skills, breaking boundaries and reaching new levels of confidence. Belonging to and being a part of an engaging community that supports and encourages them further strengthens these recovery processes in our belief. By intention, the staff at Amalia's does not contain therapists or health workers, apart from the manager herself, but I don't speak loud about that, actually. It is our belief that the recovery processes for the members are best facilitated by supervisors that are accomplished artists within their field. Our staff consists of a graphic artist, a visual artist, a hairdresser actually, a musician, a ceramicist, a studio technician, as well as a pair worker. The pair worker's own experience from mental challenges allows them to be a unique link between the staff and the members. So, Amalia is not only a community for the members, it is also a community by the members. Activities, duties, operations and maintenance of the house, including common areas and the various workshops, are shared by the members and the staff. This allows Amalia to offer a wide range of activities and host events that would be impossible with such a limited staff alone. So, as I said, it is our belief that the participation and responsibility in the community also provides a positive contribution to each individual's personal recovery process. Allow me to introduce John, one of our long-time members at Amalia's. You've been a member since we opened in 2001. Isn't that correct, John?
Yes, it is.
I know you as a very committed member. And I want to ask you, who is a typical member of Amalia?
Well, then I have to think. I don't think there is a typical member of Amalia. There's a great variety among the members. You can meet people at Amalia at work, in everyday life, for everybody, I think. There's not a typical member. Of course, a lot of people have struggled a lot with their mental health.
Yeah.
And yes, but it's a great variety. And that's one of the main points of about Amalia at all. It's like, as Kurt Cobain says, come as you are. And that's, yes. People shall feel at home at Amalia, they shall feel free, they shall be able to be themselves, not to pretend to be anybody but themselves. So, it's not easy to describe a typical member of Amalia.
I think you did it very well. But what does it actually mean that Amalia is governed by the members?
What? You mentioned recovery. You can also remember, you can talk about empowerment, for instance.
Yeah, that's interesting.
Yes, it was one of the most important things about Amalia when I started up. Those who wear these, you know, the old Indian sayings about wearing moccasins. What's moccasins in English?
Well, I don't know. Typical pair of shoes, yeah.
Yes. Well, just people who have experienced a lot of things, and those that's who they are and what their needs are. So.
In your opinion, what do you think it means for the members to have a place like Amalia?
I think it's incredibly important.
Why? Why so?
Because a lot of people, when they come to Amalia, they feel like coming home. They feel like they don't have to pretend to be anybody but themselves. They have things to do. If they are, it's about music, about drawings or paintings, chemistry. Not chemistry, but
ceramics, maybe.
Ceramics,
Yeah,
yes.
yeah.
Pottery.
Yeah, pottery.
Yes.
Yeah, yeah.
Sewing and so on. Yes, there's a lot of things to do.
Yeah.
It kind of gives meaning to their everyday life.
Yeah.
People need a house during Sundays, during holidays, during Christmas time and Easter and so on. And the problems people are facing doesn't stop at 5 o'clock or 4 o'clock in the evening. So luckily enough, we had a possibility to keep the house open, and so we have done with something called Members Open for many years. And then two of the members are together, and they kind of heads or bosses at that day when they keep the house open.
The activities offered at Amalia's are constantly evolving and changing over time. This is an ongoing developing process where everyone are involved, as John says, members and staff alike. Our aim is to provide an environment where all the members can take ownership and participate in stimulating activities to create their own unique recovery process.
Jeg sitter stille på en stein I et mørkt og stormfullt rom, og rundt meg hyler vinden hult og venter på et svar. Men jeg nå våken, fri fra fred og ro. Sanser hvert et grep rettet mot meg. Den lure ravnen vil ha sitt, og den ser snart sitt snitt til å narre meg om kulden når natten på hell. Men jeg nå våken, fri fra fred og ro. Sanser hvert et grep rettet mot meg. Hva skal jeg gjøre? Hva skal jeg gjøre når dagen gryr og vi her? Ta opp din kam, din gamle trav. Når dagen lir, ta med 2 steg. Månen lyser klart og blått, uten tanke på min kval. Og den går sin vante gang, tålmodig uten dom. Men jeg nå våken, fri fra fred og ro. Sanser hvert et grep rettet mot meg. litt rar. Når dagen lir, tar vi 2 steg. Det skal jeg gjøre, det skal jeg gjøre. Når dagen lir, tar vi 2 steg.
Har du kjent det sjøl noen gang? En tomhet i deg sjøl. Du kan aldri leve opp til de andre. Du må ta deg sammen, ikke vis dem hvem du er. Har du sagt noe om deg sjøl som er mer løgn enn sant, til de tror at alt er greit, så de holder opp med å granske deg og plage deg med ord. Alt er helt fint, jeg er helt fin, nå trengte bare litt tid for meg selv. Men se på meg nå, jeg er helt oppriktig, men ingen vet vel hva som kan skje. Har du sett deg selv noen gang? I speilet står et smil, men alt i deg er knust. Du er hjelpeløs, du vil bare bort. Ingen kan forstå. Har du drømt det selv noen gang, at du er et annet sted, der masken blir tatt bort, og all angst blir støv, og så for alltid er du her.
So thanks a lot, my friends from Amalie Skramshus, for showing your place in this colorful and lovely way. Who really went into my heart. I hope it could go into someone else's heart as well. And here is a lot of take-home messages when it comes to how organized the management, the user's influence, and also how to take this creativity seriously and use authors and artists to train and guide the members in a proper way. I don't know if there are some questions or comments, or if we have time for that, or can anybody help me? Is there an option for that? We have like 4 minutes left, so feel free, either online or here in the audience. Are there somebody? No? And there are no one online asking questions? No? No. Okay, then we close this symposium. Thank you all.
Can I try forward and backward? That's forward and that's backward. It's usually forward. So good evening, everybody. This is Dina Tabai. I'm a psychiatrist and a camp psychiatrist in Maudsley Health, Abu Dhabi, and a former lecturer of psychiatry in Cairo University. I'm going to talk today about executive functioning as a window on prefrontal functioning in children. So executive functioning refers to brain-based processes we use to control our thoughts, actions, and feelings. They include holding information in mind, controlling impulses, and thinking flexibly. They help us to persevere towards our goals, but also adapt to changing circumstances. So if I were to ask you to think of a person you know who's really patient, persistent, emotionally balanced, flexible, takes the long view when it comes to pursuing their goals, I'm guessing you will not be thinking of a 4 to 5 year old. It will come as no surprise that young people aren't very good at these skills, known as executive functioning skills. It's not that they don't have them, because actually our genes inform them, but it's the fact that it's still developing. So where do we come across executive dysfunction in our daily lives, in our daily clinical practice? Children who do not have a visible disability are expected to function according to a set of norms and rules in today's society. And if they don't, they are referred to as being lazy, unmotivated, forgetful, as well as that this behavior is viewed as being deliberate. They also show inability to start or complete a task, oppositional defined behaviors, excessive anxiety, a lot of emotional dysregulation, which manifests in meltdowns, aggressive behaviors, and impulsive acts. This leads them to become assessed and treated by a number of mental health professionals. When their symptoms do not fit the DSM criteria, they're then referred between several clinicians, several mental health professionals for treatment. And then what happens is that they're not having a label that belongs to the DSM, and in that sense, they're not properly assessed. They often go from one professional to the other over a period of time without proper adaptation and management of their deficits. So this is Garth. He has an empty brain now. So what do you think he's suffering from? Probably, from an executive perspective, he's suffering from maybe he does not know where to start from. He's having a problem with task initiation. He didn't hold anything in mind that would inform the coming steps, or maybe he's struggling with sustaining his attention. So actually it ends up that we see children spaced out and not knowing what to do. So what do executive function weaknesses look like? Children act without thinking, they interrupt others, they overreact to small problems, and a cascade of events happens. What happens is that a lot of demand is placed on their executive abilities, and executive overload takes place. They become anxious, they don't comply. It ends in a behavioral outburst, and instead of helping those children, what happened is that they become punished. If we have a child who is intact in executive skills, they will have positive social interactions, good academic achievement, and good adaptive functioning. So what is needed to promote executive development in early years? Our genes provide the blueprint, but the early environments in which children live leave a lasting signature on those genes. Early motor, sensory, and communication skills are very important to the development of executive functions. During preschool children, the interactions become more complex due to the development of language abilities as well as social behaviors. However, interactions with caregivers and the environment are the primary influences on the development of executive functions. These are the developmental trajectories of executive functions. It starts early on in life in infants, and it peaks by the age of 30 years. There are lots of strategies out there that help promote the development of executive skills in children. Research-based early childhood programs usually promote self-regulated learning, which is merely the concept of producing a self-regulated learner rather than just transmitting facts. So self-regulated learners are motivated to learn, they take ownership of their learning, they plan their strategies, and reflect on the process of the learning itself. According to Vygotsky, learning is a cognitive development through social interaction, and he referred to the zone of proximal development, which is the area between what the child can do alone and what the child can do with help. So to promote executive skills in children and to promote scaffoldings, we need to not to exert a lot of pressure on them where they get blocked, nor to give them so very easy tasks that they can easily do, and in that sense they will not be stimulated enough. As Vygotsky has mentioned, then that whenever there is imaginary situation, there are rules, and whenever there are rules, self-regulation will be promoted. Self-regulation is very important. It's one of the most important executive skill that helps and promotes success. So self-regulation has two aspects. It's to control one's impulse as well as to stop doing something if needed. Self-regulation has been correlated to success even more than IQ as well as math and reading abilities. Self-regulation means that we have a student who is staying on task, he ignores distraction, He holds thoughts in mind and is self-disciplined. Play serves the development of self-regulation. Not all play serves the function. The play that we see nowadays is on video games, on screens, is a stereotyped ones. However, mature play is the creative play where children create their own rules, self-regulation, and problem-solving skills. In the immature play, the children are perceived as slaves to their environment. They're totally dependent on it. However, in the mature play, they are masters of their own behavior. This moves us to the overstimulation hypothesis. Children nowadays are faced with a lot of screen change, a lot of stimulation that makes them engage in the screen. But actually, they're not performing a coherent narrative of what they're seeing, which is the process of learning. We need to have a coherent narrative of what we see, we internalize it, and from that we get our problem-solving skills, our internal representations of experiences. So, prolonged exposure to rapid images during critical periods of brain development causes our brain to be conditioned to expected high levels of stimulation, and this leads to inattention later in life. So, in terms of the overstimulation hypothesis, the children go to school, they find it very boring, too slow, nothing is popping up quickly or coming back and forth quickly, because their minds are conditioned to very rapid movements. And this is a very common statement that we see. Most of the children are always bored. They depend on the environment. They want something that is stimulating. And here's the concept of plugged-in children. There has been a study that has looked into children when the electricity went off or when they don't have their electronics around. Only 10% of 6-year-olds were able to play creatively, and the rest were bored. They couldn't enjoy themselves. They couldn't make use of their time. Now I'm going to move to different psychiatric disorders from an executive functioning perspective. In interest of time, I'm going to focus on ADHD. But just to highlight the fact that executive functions are nowadays being studied as biological markers in different psychiatric disorders, biological markers in diagnosis, to inform treatment, and also to see outcomes after treatment. But most of the consistent findings in research has noted that executive functions are actually markers for ADHD, ASD, and fetal alcohol syndrome. So we do have a lot of executive functioning findings in different psychiatric disorders, but I'm going to focus on ADHD. So to understand ADHD from an executive perspective, we need to know how do we self-inhibit. So first of all, we go through 3 steps of executive functioning. The first of all is inhibition, self-regulation, and then other executive functioning takes place. So for inhibition to take place, we need first of all to stop ourselves, to stop an action, to shift to a behavior or to another step that fulfills our goal, and to protect our executive functions from distractions. Self-regulation is an action aimed to the self, to inform the future. So you need to stop an action, you need to stop playing with your video game, you need to pursue your homework for the future plan, which is to study and to have a later consequence. So these are the executive skills involved in self-control. The first is the ability to inhibit behavior. Then we go to the nonverbal working memory, verbal working memory, controlling of emotion, planning, and problem solving. So the ability to inhibit behavior allow other executive functions to be able to take over and guide your behavior towards the future. For the nonverbal working memory, This is the ability that you use your visual imagery or imagination, and humans have the ability to hold images in mind about what they are proposing to do. What we call mental maps, we call it a GPS. Our brain displays a DVD of what we have in mind as a representation of this experience, which will inform our subsequent step. Nonverbal working memory, in other words, is referred to as the sense of hindsight, which is being informed of our previous experiences so as to inform our foresight and to have a long-term view of the coming steps. Overall, our subjective sense of time is affected by our foresight. In children with ADHD, their hindsight is affected because their nonverbal working memory is not in place, is offline, and in terms of their foresight, they're time blind or they have the time myopia. And in ADHD, the pathology lies in one of the main executive function, which is the time management. And this is what makes them always late, not on time, because they will act to an action when it enters their time zone or time frame, which is a very immediate one. In terms of verbal working memory, this is the ability to talk to yourself in your mind as a form of self-guidance. So there's a voice in our head that informs our behaviors, planning, learning from previous experiences. So we always question ourselves when we're faced with novel situation, and it also informs our problem-solving skills. After that, we go into the ability to control our emotions. One of the major important executive functioning is to control our emotions, and with it comes our motivation. So the ability to inhibit strong emotion and to moderate them serves to keep us on track in terms of our long-term goals, welfare, and plans. This also transfers us to the planning and problem solving. The ability to plan and problem solve is actually a mental play. And it starts early on in childhood when play starts symbolic, it then becomes internalized, and this is it's not only for leisure, it's the basis of problem solving skills in adult life. So it helps us manipulate information, discover novel combinations of solutions to problems, and in order to accomplish our tasks. So ADHD, from an executive perspective, has got a deficiency in most of the executive functioning, and a lot of psychiatrists and psychologists propose renaming the disorder as an executive function disorder or an EFDD. I'll skip this part and then I'll go into the management. So what we need to understand about executive functions in ADHD is that we need to shift our framework. It's not an attention, it's not merely an attention problem, it's an executive function problem. If we shift our understanding from inattention to executive function, will inform the treatment. So first of all, we need to know that, we need to inform parents that it's not only about attention, which entails the fact that you can just have a good sleep, drink some coffee, and you'll do well. No, it's not this. It's time management, it's organizational skills, it's the dichotomy between what the child knows and what the child needs to do. So what happens in ADHD is that children know what they need to know. It's the fact of putting it in the performance part of our brains. We also need to make sure that we put what we call accommodations, what we call prostheses or scaffoldings in a natural environment of the child. So we need parents, teachers, and significant others to be on board as well. So we instruct parents about definitely structure and routine, rewards and consequences, but in rewards and consequences, we also need to tell parents that it needs to be immediate, it needs to be proximal in the time zone of children so that it will help them feel the sense of time. It's also important to instruct parents about exercise, mind-body connection, meditation, yoga, and all these activities help children with ADHD. So these are my references, and thank you very much. So our next speaker is Dr. Wala Amin. She is a child and adolescent psychiatrist. She is an associate professor in Cairo University. Dr. Wala Amin has 16 years of experience in both public and private sectors, and she's going to speak about childhood psychosis. Thank you very much.
Good afternoon, everyone. I'd like first to thank the organization of the conference for inviting me, and thank you all for attending. Thank you, Dr. Dina, for introducing me. This presentation is aiming to identify the differences and peculiarities of childhood schizophrenia, challenges in the diagnosis, and discussing challenges in management. Psychosis or psychotic symptoms is a word used to describe situations when perceptions, thoughts, or emotions are disordered so severely that contact is lost with external reality. The appearance of psychotic symptoms in childhood, albeit rare, is an important clinical entity. This importance extends beyond their clinical prevalence and has begun to influence our understanding of the principal psychotic condition. The term psychosis is generally categorical and includes subgroups within it. The two most common mental illnesses where psychotic symptoms are a predominant feature are schizophrenia and bipolar disorder. This presentation will focus on childhood schizophrenia. Childhood onset schizophrenia has some differences compared to adult onset schizophrenia. Regarding the age of onset, it's clear that the peak onset of most common psychotic disorder, schizophrenia and bipolar, is in adolescence. Early onset schizophrenia begins before the age of 17 to 18 years, whereas very early onset schizophrenia occurs before the age of 13 years. It's rare in childhood, but becomes more expressive at around the age of 11. Although there are some reports of schizophrenia before the age of 5 years, these cases are extremely rare. Schizophrenia affects approximately 1% of the population with the age of onset 15 to 30 years. Approximately 0.1 to 1% of cases of schizophrenia occurs before the age of 10, and approximately 4% before the age of 15 years. Another difference is the gender difference. As we can see, while the proportion of men and women is virtually the same in the adult population, boys are affected twice as much as girls in the pediatric population. When its onset occurs before the age of 12 years, it's strongly associated with behavioral problems. Children have been described as socially maladapted, weird, or withdrawn, in addition to having behavioral disorders and delayed psychomotor development. As mental health professionals, we face a lot of challenges in diagnosing childhood schizophrenia, as starting from history taking. As children typically do not share their disordered perceptual experiences or delusional beliefs. For children, psychotic features belong to the realm of private or secret experiences. that are seldom divulged to significant others. Older children and adolescents who develop a psychotic illness often have some recognition that something is wrong with their thinking, perception, or behavior. They feel frightened due to a feeling of confusion in their sense of reality. Frequently, parents only become aware of the presence of psychotic symptoms when the child starts displaying abnormal behavior, which is relatively late. Some parents normalize psychotic experiences to expect that children will grow out of them. The idea may be reinforced by professionals. Sometimes pediatricians and even mental health professionals, unfortunately, support these naive expectations and give parents false reassurance. Parents are often told that these unusual experiences are trivial and temporary. Even psychiatrists may miss the symptoms underlying psychosis as they focus on presenting behavioral manifestations such as aggression or suicide. Some clinicians are reluctant to consider this diagnosis and hesitate to explore perceptual abnormalities or delusional thinking in childhood. There is a lack of familiarity with clinical presentations of psychosis in childhood. It's also true that many cases are difficult to characterize until enough time has passed for the disturbing process to provide a clear pattern of the unfolding illness. Sadly, this contributes to delays in identification and treatment of early presentation of psychotic symptoms. It's not uncommon to hear from disturbed children that they have suffered from psychotic experiences for a long time, even years, or that the psychotic experiences began in early childhood. It's when the child no longer feels able to control the psychotic influence, which is too late, that the psychosis becomes manifested in unmistakably abnormal or bizarre behavior. Difficulties in diagnosing childhood schizophrenia have been compounded by the relative rarity of the disorder, as we mentioned, the developmental limitations, the need to differentiate psychopathologic phenomena from normal experiences of childhood. For example, vivid fantasies versus delusions. The first question we face while diagnosing childhood schizophrenia is the child psychotic or he's imagining things? The age when children are able to discriminate reality from make-believe, when normal children are able to differentiate reality from fantasy, is relevant for the assessment of psychosis. According to Piaget, children aged less than 7 may have difficulty distinguishing between events occurring while dreaming and awake. However, more recent research shows that children are not globally poor at making this distinction, and that a normal child of average intelligence is fully able to distinguish between fantasy and reality by the age of 3 years. The continuum of hallucinatory experiences in children and adolescents can be interpreted as resembling the distribution found in adults, with healthy children and adolescents at one end and those experiencing more clinically significant psychopathological syndrome at the other. Although hallucinations frequently are considered synonymous with psychotic disorders, hallucinations in children and adolescents are now known to occur on a continuum, from healthy to psychopathology-related phenomena. Some neurobiological studies of adults show activation of Broca's area seconds before patients perceive auditory verbal hallucinations, which suggests that auditory hallucinations may be misidentified self-talk. The first thing we have to distinguish between hallucination and other abnormal phenomena is the imaginary friends or companions, which are common among all children. Children who have imaginary friends are more likely to report hearing voices. But imaginary friends appear, function, and disappear at the wish of the child, pose no threat, and often are a source of comfort, often can be described in detail, are not ego-dystonic. Also, children with imaginary friends will not show evidence of a thought disorder. In order to ascertain if the child's productions are the result of a vivid imagination or psychosis, the psychiatrist needs to challenge the child's account. If the child persists in his distorted perceptions or beliefs, a gentle confrontation adds a sense of conviction to the attribution of psychosis. Thus, after the child says, for instance, that he is hearing voices, the examiner may challenge her or his assertion by asking him, "Could it be that your imagination is playing a trick on you? Are you imagining this? Is this real? Are you putting me on? Psychotic children stick to their claims and persevere in the factuality of their complaints. The psychotic child feels frightened and unsafe and seeks continuous protection and reassurance. Thus, if the child holds his or her head or shakes it, expressing despair and a feeling of helplessness against his distressing experience, it's more likely that the phenomenology described by the child is real and beyond the child's control. Thought disorder, another criterion for diagnosing childhood schizophrenia. It's important to distinguish between developmental thought disorder slippage and clinically significant thought disorder. It's also important to recognize that young children may have difficulties describing their symptoms and experiences. It's doubtful that a thought disorder could be reliably diagnosed before the age of 7. The psychotic child may show other signs of adaptive impairment, that is regressive behavior. When the child avoids going to the room at night, needs company to go to the bathroom, expresses persistent preoccupation for the safety of the family, takes active steps to deal with perceived persecutors, attempt to cope with feelings of danger and persecution by procuring weapons or other means to deal with the anticipated danger. All these are signs. Also, another difference is the focus of delusional beliefs in pre-adolescents and children. It's usually in his room, in the bathroom, closets, windows, under the bed, ceilings and vents, and darkness. Former thought disorder includes impaired comprehensibility, loosening of associations, pressure of speech, and illogical thinking. However, alternative interaction are often required for younger patients. The storytelling technique or story completion as a mechanism to observe thought disorder for 7 to 13 years old children is used. Children as young as 3 years old are capable of completing stories and once given some practice. Cognition and language are areas affected in childhood psychosis. Approximately 10 to 20% of schizophrenic children have a decrease in their intelligence quotient. In addition to cognitive deficit, attention deficit, learning disabilities, and abstraction are also observed. Communication problems are frequent. The functional impairment. A child who simply reports experiences that sound psychotic and for which there is no functional significance or corroborating evidence in the mental health examination or in the adaptive level of function is likely not to be truly psychotic. Conversely, a child who denies hallucinations or delusions but who has a marked deterioration in functioning and associated bizarre behavior and thinking is likely to have a psychotic condition. The psychiatrists need to be deliberate and systematic in the exploration of psychotic symptoms in children and adolescents. Developmental history, family history, comprehensive exploration of the presenting problem, keen observations during the examination, coupled with the systematic examination of multisensory perceptual disturbances and paranoid perceptions, provide the examiner with solid leads in the diagnostic process. Difficulty in diagnosing psychosis in children and adolescents does not mean that the intervention should be postponed until a precise categorical diagnosis is achieved. Dimensions of behavior that are maladaptive need to be addressed as soon as they are detected. During interviewing a child, remember that children are highly suggestible, may answer questions in the affirmative to get attention or to please the interviewer, may not fully or partially understand what is being asked, may blame their misbehavior on voices to escape punishment, may not distinguish between night terrors and illusions. Diagnosis in children and adolescents is a dynamic process. Many heterogeneous disturbances begin with common manifestations in early childhood. As the child grows and develops, features that differentiate one disorder from another begin to emerge. To achieve categorical diagnoses in children and adolescents, longitudinal observations are necessary. It's advisable to keep an open mind in the diagnostic process. Parents should not be discouraged with hopelessness, nor should they be falsely reassured in the face of serious maladaptive symptoms. The differential diagnosis list is long, starting from autistic spectrum disorder, substance abuse, and a long list of organic and medical disorders. Risk factors of psychotic disorders include homicidal behavior, suicidal behavior, impulsive self-defeating behaviors, alcohol and drug abuse, gang participation, antisocial behaviors, unwanted pregnancies and STDs in adolescent patients, poor compliance and relapse risk, school difficulties, social and vocational problems, self-neglect, and victimization. As we face challenges in diagnosis, we also face challenges in management of childhood schizophrenia. The treatment of psychosis consists of pharmacotherapy and other psychosocial approaches. For many reasons, studies on neuroleptics are initially made with adult patients, and only after some years, these drugs are released for use in children. A large number of atypical antipsychotics have been released in the last few years with proven efficacy and fewer adverse effects, but their use in the treatment of childhood psychosis is still restricted. As you can see, not all the antipsychotics are approved for children. Children and adolescents seem to present a higher sensitivity to several side effects too, such as neurologic disturbances, hyperprolactinemia, cardiovascular-related side effects, weight gain, and related metabolic features in comparison to adult patients. These are consequences of the physiological variations typical of the developmental age, which could interfere with both the pharmacodynamic and pharmacokinetic profiles of the antipsychotics. Treatment with antipsychotics in pediatric patients is often long-term. Chronic exposure to antipsychotic during this critical developmental age could potentially lead to dysfunctional modification of both metabolic and neurological process, such as the delay in pubertal maturation, menstrual disturbance, and other things. Indeed, to date, the safety of these medications for long-term treatments in pediatric patients remains a subject of debate, and several important safety concerns previously highlighted in literature are still not yet resolved. Another challenge is dealing with the families of children with psychosis. With few expectations, parents are prone to blame themselves for child's dysfunction. Parents may take responsibility for whatever goes wrong with their children. Psychoeducation should emphasize the severity of the illness in long-term course and the need for uninterrupted treatment. Parents need to be encouraged to keep a long view of the treatment process. They need to be given hope and support and encouragement for adhering to psychopharmacological treatment and complementary psychosocial treatments. Efforts should be made at reducing expressed emotions, particularly criticism and hostility. Neutralization of the parents' negative emotion, mostly guilt, for causing the child illness, and to disconnect the family from feeling responsible for the child's problems. The families will be made aware of suicide risk, as well as the risk for violence and the risk for unfolding comorbidities like anxiety disorders, drug abuse, or others. Thank you. Do we have time for any questions? Okay, thank you.
Hello, everyone. It's wonderful to see you all here. It's a pleasure to be here. This presentation is titled Using ACT, which stands for Acceptance and Commitment Therapy, and ABA, which stands for Applied Behavior Analysis, to support families of individuals with autism. So a little bit about me. My name is Melody. I am a board certified behavior analyst. And I just wanted to talk a little bit about why I'm presenting on this topic and why it's important to me. My background is in the field of applied behavior analysis. I have 11 years of experience working with neurodiverse individuals and families, specifically those that are on the autism spectrum. And I'm really passionate about bridging the gap between behavior analysis and wellness practices. So this, of course, is a mental health conference. And in the field of ABA, we focus a lot on behavior specifically, of course. And so what's the connection between behavior, focusing on the things that we do in relation to our well-being? And so that's a little bit of what I'm going to talk about today as it relates to families of individuals with autism. My organizational values are compassion, cultural humility, being sensitive to the diverse needs of all of us from different parts of the world, and community, coming together for a common goal. And one of the things I'll be talking about in this presentation specifically, right, is the union between clinicians and caregivers, families, right? So those of you that work with caregivers or families in particular, perhaps you know that that's really important, creating a community, a union between the two in order to achieve a common goal. I live in the UAE in Abu Dhabi. I've been here for 5 years. Doing the work that I do with the population here in the Middle East. And like I said, I'm really passionate about using behavioral science, which is what this presentation is really going to be all about. It's rooted in behavioral science, and at the core is to help others to bring change to their lives that's really meaningful to them. So that's just a little bit about me. I would love to keep this interactive, understand who is in the room with me. If you could please share in the chat a little bit about yourself, who you are, what you do, why you're in this presentation perhaps, whether you work with neurodiverse individuals and families like I do, or perhaps you're a parent. So yes, I would greatly appreciate if that's possible, if you guys have access to the chat, to just kind of share, 1 or 2 sentences about who's here. I miss I'm obviously not in person, right? I'm virtual, but trying to, the only people here are the speakers for the track session. Okay, wonderful. Well, thank you for those of you that are here. So we'll just skip through this part, but I hope that this is useful for whatever work it is that you do. And yeah, we'll move on with the presentation. Thank you for letting me know that. So those of you that are clinicians, I just have a few questions that I'd like us to think about as we're moving through this presentation, which are really important and are going to guide the rest of how we do this work in working with clients, individuals, families. And, that's to think about what shows up for you. What shows up for you as a clinician when working with families who are struggling or having a difficult time. So just think about what comes up for you as I ask that first question. What frustrations or triggers do you have as a professional when you find yourself having a difficult time getting through to parents, right? And if you don't work with parents, anyone you work with, it still applies. And how do you respond to your own internal experience as a professional in your work? And I ask these questions to remind everyone, right, that we're all human beings at the end of the day. You might be on the profession side in one particular context, but at the core of that, there's still frustration, things like that that we deal with in our work that are part of being human, and just orienting your thought process to kind of what are my patterns in my workspace when I'm in a space like this. So what is this going to be all about for clinicians specifically, or educators even that are here and work with families or caregivers? It's about, one, practicing what we preach, right? We're here to help. We're here to help other people in the area of mental health in one way or another. How can we be more effective at practicing what we're preaching, right? Actually doing what we're telling our clients to do. Practicing compassion, empathy, and flexibility. Those three things we'll talk about a lot throughout the rest of this presentation. Acknowledging our own experiences when working with families, right? That's important because, as we'll talk about, it's not always enough to be in problem-solving mode, right? If you are completely ignoring your experience and the role that you play in that interaction. Learning healthy ways to problem solve. We want to validate the experience of our clients. We want to connect with our values, right? I stated mine at the beginning of this presentation. So thinking about what all of your values are. We want to increase our awareness, right? So going to work every day, some of the things we do, it can be easy to lose track, to kind of go with the flow of things, right? And when we go with the flow, we're less aware. And we want to invite our awareness to stay with us. And by doing all of that, guess what? We can better guide our clients, our families, our caregivers to do all of those things as well. I have two main objectives for this workshop. The first one, I will discuss the purpose, the principles, and benefits of acceptance and commitment therapy, as well as applied behavior analysis. And my second main objective is to provide a brief introduction for clinicians to guide parents specifically, because we're really focusing on families in this workshop, towards behavior change, which is guided by their values, determined by values. So those are my two main objectives for the rest of this presentation. Really important things for me to mention. This is not intended to be used as specific clinical advice. I will give examples in here. I will say things, right? But those of you that work in the field of mental health, as you know, right, this is general information. So of course, use your best clinical judgment in your individual cases. Learning to use ACT and ABA strategies effectively takes a lot of time and committed practice. And that goes along with my second point here, that attending one or a few workshops is not sufficient, right? So just because you attend a training or a workshop, right, that doesn't mean that there's a certification now and that now I'm qualified to do everything that I mentioned in this presentation with your clients. Of course, continue to use your best clinical judgment and use this as a guide to seek further information, hopefully is my intention. And then lastly, if you are interested in ACT and ABA, of course, this is a brief introduction. I'll post my information at the end of this presentation. please contact me. I will happily share any resources about ACT, about ABA. Of course, there are ways to become certified in behavior analysis that I can share. In ACT, there is not, but those of you that really find yourselves interested after some of the behavioral scientific information that I share here, please reach out and I will share all the information that might be of interest to you. So what is ACT? Some of you may already know this, those of you that work in mental health, perhaps. ACT, as I mentioned, stands for Acceptance and Commitment Therapy. It's an evidence-based behavioral way to approach mental health, essentially. So it uses traditional behavior therapy techniques, which is broad, right? That includes things that have been historically behavioral, and that also includes things that have been outside of the behavior tradition. The main things that we'll talk about that some of you may be familiar, cognitive diffusion, acceptance, mindfulness, right, is a very, a lot of people are familiar with mindfulness these days. Values, which we'll spend a lot of time on today, and commitments, which is really what I will be emphasizing in the behavior piece. How do we actually commit to the things that we want to do and guide our families to do that as well. The core concept of ACT, Acceptance and Commitment Therapy, is that emotional pain is not the problem, right? Those of us that work in mental health, and even if we don't work in mental health and we just really work with people in any capacity, we want to solve their problems. We want to help them, right? And what do we want to do? We want to get rid of whatever is causing them suffering, pain, and all of that. From the ACT perspective, that's actually not the problem. That's part of being a human being, right? That's part of the human experience, to experience grief, hardship, and these things. They're not actually the problem. The problem is when we get into a battle with these things, right? So at the core, suffering is not from the actual feeling, but from our attempts to avoid them, to push them away, to get rid of them. I can't feel sad, I can't feel angry. And that can really get in the way of our goals. And for families of individuals with autism, it's that are struggling with perhaps behavioral needs, emotional needs, especially families of newly diagnosed children. They're going through this a lot, right? There's something new happening. I've never experienced this before. You know, I don't know what to do. I'm experiencing a wide range of emotions, and there's all these attempts to get rid of them. So how can we teach families and guide them through this in an effective way? And there are really powerful ways to do that, as mentioned here, which we'll use. We can think of it as a little toolbox that we have accessible to us, using mindfulness strategies, acceptance, diffusion, and then using all of that to guide our actions in a very specific way. So the mind has a job, and it takes it very seriously, right? To plan, evaluate, contribute, contemplate, reminisce, to remember things, to analyze things over and over. That's what our mind is doing constantly, right? And why does our mind do that? To protect us from harm, from real harm or perceived harm. Sometimes the mind often does not know the difference between the two. So as long as someone really believes that they're in danger, or there's something that is a threat to an individual or the family, I need to do everything I can to protect myself from whatever that is, regardless of if there's real danger or not. And this is very important because you can imagine a family of a child with autism. They might perceive a lot of of things to be harmful, right? And there may be some real harm happening there. There may be things that are not really harmful. So just think about kind of what the context of this could be for a family specifically. Another core concept of ACT is psychological flexibility. That's really what we're trying to do. We want to increase psychological flexibility so that the people that we're working with can be in the present moment more fully. And then when they're in the present moment more fully, they are better able to act on the future, right? If we are so focused on our mind's job and you know, everything that we're trying to get rid of, the battle with our pain and all of these things, we cannot act on the future. It would be very difficult. If you're not familiar with the ACT hexaflex, this is essentially how we develop psychological flexibility. These are the tools that we use to help individuals develop psychological flexibility. One, being in the present moment, as I've just mentioned, right? Practicing really being aware to the experience right now, not the past, not the anxiety about the future. Our values, the things that we care about, the things that are really important to us. Our actions, the things that we're actually doing, because we can think and have feelings and have aspirations, but are we acting in a way that is aligned with the things that we say we care about and that we want out of our lives? The self as context, that refers to how we see ourselves, right? So for a lot of the families that I work with, there's a lot of views of the self, such as, right, I'm a bad parent, I have no idea what I'm doing, I'm not capable. So that's really important. What are the views that you hold about yourself and about your family and about your children as well? Diffusion, that of course refers to our ability to create distance between ourselves and our thoughts, right? How tightly are we holding on to the thoughts that we have about ourselves and about our problems and about our suffering? So we want to diffuse from that. And then acceptance, really important. Practicing things like compassion, practicing things like showing yourself grace, right, through difficult times, as we've just kind of mentioned, the human experience as a whole. So these are essentially all of the 6 different skills. They're all skills. We can think of them as skills that we want to, 1, practice ourselves as clinicians, and 2, teach our family units and our caregivers to practice these as well. And so this is what we kind of refer to as mindfulness, right? Mindfulness, all of these 4 skills that we have on the right side of this hexaflex are mindfulness skills, ability to be in the present moment, compassion, and things like that. And then the 2, values and committed action, are what we use to target behavior change. And that's very important because the orange side of this diagram is going to be what we do when we have our internal experience, feelings and thoughts that show up. When families experience feelings and thoughts that show up that are unwanted, we have all of those 4 skills to kind of help us. And then how are we going to act on those things? Using our values and committing through committed action. That's how we actually see behavior change. So as we know, parenting is not an easy task. And those of you that work with parents, right? Maybe you don't work with parents, but you are a parent. So reflect on that for just a moment, those of you that are parents here, right? I'm sure you would agree It's probably not the easiest thing you've ever done. It's difficult. It's a big responsibility. And with that comes our human experience showing up. Unwanted thoughts, emotions, and all of that. So this is a model that I love. If you can think about kind of what's in our DNA or what makes up our DNA. And if you're interested in knowing more about the DNAV model, this is called, please contact me after the session. I'll send you more information about this. But one of the ways we can think about this is we have three parts of ourselves. And I'm going to start from the bottom. We have our advisor, which is the mind that I spoke about earlier. The mind is always telling us what to do, planning, judging, evaluate, giving us advice. As I prepared this presentation, of course, that was my advisor working to organize things, organize PowerPoints. Those of you that are speakers here, you also used your advisor to prepare the information that you want to share today. And then we also have the noticer, our ability to be present, to be aware. And that is one of our main mindfulness skills that we will use and that will guide parents to use so that they're not caught up in their thoughts and in their feelings. And then our discoverer is kind of another way of talking about our behavior change. So the part within us that is able to try new things, test things out, and see how things actually work in the world, especially when we're dealing with something unfamiliar, being able to learn information, apply new information, and then see how it works. And that's kind of what we'll be talking about through the rest of this. So you, as your best parenting self, what is it like and what are you doing? So just take a moment to reflect on that. Those of you that are parents, we don't have the chat feature here, but that's okay. Just reflect on this question. Those of you that are parents, what does it look like when you are your best parent? What are you doing? What kinds of tasks? And if you're not a parent, think about what a client of yours would say when reflecting on this question. And that's really getting to the values, our core values, the things that are important to us, that matter to us. So what types of words would we use as we just thought about that question, or would our clients use to describe the ideal parenting journey? And just notice what words stand out to you. Supportive. What kind of parent do you want to be? Supportive, fun, energetic, sensitive, joyful, caring, thoughtful, compassionate, courageous, friendly, dependable, responsible, truthful, kind, fair, or generous. Just noticing if you could pick 3 to 5, right? 3 to 5 that really stand out the most, and the reasons why those words stand out. So ACT is about developing skills. So what skills do families need to develop? 1, working together, balancing child-led and adult time, acceptance, compassion, and empathy for themselves as parents, and also towards others. Responding to uncomfortable emotions that feel really big, really huge in the moment. learning to respond flexibly in context. So that means that we want to teach families to come out of rigid responding. So when there's an uncomfortable situation that presents itself, we will notice patterns in the responding of the people that we work with. And they maybe have go-to things or patterns of behavior. How can we teach them to be more flexible and broaden their perspective, right? Perspective taking and increasing awareness. And does all of this sound familiar? Of course it does, because it's very similar to the things that I brought up at the beginning about our work as clinicians. So we want to work on this ourselves, the things that show up for us in session, and then guiding that to help our clients develop these skills. So at the core of what we're doing is we're teaching parents to notice inflexible behavior and feelings. So as I mentioned, the core of ACT is to target psychological flexibility. So if we're not being psychologically flexible, then we're being psychologically inflexible, right? We're so attached to those uncomfortable thoughts and feelings, speaking about the families and the parents, that we can't respond in a flexible and adaptable way. So how can we notice and take a step back from that? So what are the things that my advisor is saying to me right now, or often says to me, that are unhelpful, especially as a parent of an individual with autism? So take a moment to think about what are the types of things that a parent of an individual with autism might be having their advisor tell them all the time. So some of the ones that I've heard, right? Thoughts about the future, about my child, right? I'm worried about how they might be when they grow up. I'm worried about them getting a job. I'm worried about them making friends at school. Thoughts about evaluating their own capabilities as a parent. I'm concerned that I'm not doing the best for my child. So those are all things that come from that advisor evaluative space. How do I feel in my mind and my body when I notice that my advisor is working? So if we're thinking about a parent that is saying all of those things to themselves all the time, how would that show up in the body, right? Tense, breath, how might that affect their breath, right? Their nervous system. So taking a moment to notice those things. And why are we doing that? Not just to say, okay, this makes my heart rate go up, but that I can notice that in this inflexible pattern, it shows up in my body and I'm unable to be fully present. And then how do I respond? How am I responding to my children? How am I responding to my children? So there's a lot involved when we see inflexible patterns in families. It's not just the behavior, right, that we can see. It's the entire context of what that person is experiencing, including the thoughts and the feelings that they're experiencing. Bidirectionality, so you as the context to facilitate change, which is really important. So that's why I've placed so much emphasis on us being able to do this as clinicians. The more we can practice, the better we are able to guide families to do the same thing. So that can start by noticing really small things. Noticing how parents respond on a moment-to-moment basis. What are parent triggers, right? When you say things or act in certain ways, how does the parent respond to you? And what are your responses in the moment, and what are your triggers? So what we're getting at here is the relationship, the constant back and forth relationship between you and your clients, and the family and you. So thinking about what do you wish for your children? And I really want to invite those of you that are parents here to really reflect on this question. And those of you that are not parents, think about what that's like for a parent that you know. Whether it's a parent that you work with or any parent that you know, what are their ultimate wishes for their children? It's a very big question, right? There might be lots of thoughts that show up, but I'll just give a few seconds to really think about this question and think about the things that come up for you in your mind. Moving on. Now we're going to move on to ABA. So we've just spent a good amount of time talking about ACT and what it is and how it can be useful for our internal experiences for parents and families, and then also for ourselves as clinicians. How are we actually going to get to behavior change though? And that's really where the core principles of applied behavior analysis come in. So what is ABA? It's a scientific approach to understanding behavior. It has a pretty decent history, goes back to the 20th century. And the premise here is that we focus on behavior, the things that we're actually doing. And by behavior, things that we can actually observe, measure, and track. And so what are these behaviors? Behaviors are anything that a living organism does, right? So sitting, drinking tea, talking on the phone, watching a Zoom presentation, recording, right? All of those things are behaviors. We can also, we generally talk about behavior in a negative way, right? When we say behavior, we're talking about challenging things like aggression or self-injury, or crying and tantrums, right? Especially for people with autism. But behavior is really everything that we do. So that's the lens that we want to keep first. And then we have both overt and covert behavior. So overt is everything that we can see, that we can physically do. And then covert is what goes on within us, more private events, we would call them in behavior analysis. And so our covert behaviors are really the things that we're going to use our ACT mindfulness-based skills for, which we've just gone over. So now we're going to talk about how do we address overt behaviors, so the inflexible behaviors that we can actually observe and see in parents, and then also the inflexible behaviors, or really just general behavior that we'll see in children, and how we can actually guide parents to respond to their children in an effective way. So at the core of behavior analysis, we are always behaving. Any living organism is any behavior that you see is happening for one of two reasons only, and that is to try to avoid or get rid of something, or to try to get more of something. That's the only reason why we do anything, whether that's going to the refrigerator, getting a drink of water, calling a friend, leaving a room. It's always going to be one of these two things. And so to take that more specifically, so we can actually analyze what are the reasons that these things are happening, we can look at what we would call the ABCs of behavior. So we have antecedents, which are what has happened right before the behavior has even happened. Then we have the behavior itself, and then the consequence, what happened right after the behavior has happened. And we'll be focusing on parent behavior. So typically when I'm talking about the ABCs of behavior, when I do trainings like this, I am typically referring to the behavior of the children because that's typically what we're trying to alter and trying to help children with autism and teens with autism behave in a way that is more adaptive and flexible. But the only way to really, at least when you're working with families, to guide children and teens to behave in a way that is more flexible is to target the behavior of the parents, right? So they have to also change and adapt their own behaviors and their own responding in order to see that in their children. So we'll look at a few really simple examples of this from the parent perspective. So what we want to do is act on values, and values are all the things that we've said we care about at the beginning. So if we look at this example, kind of tying this all together, if we have a parent that has a core value of independence, right? That's something that they've verbalized to you. I want my child to be more independent, right? And then let's take a look at this very common scenario for families, right? Perhaps a child is unable to put on their shoes, right? Parent, they're rushing, maybe they've got somewhere to be in a little while. Parent puts on the shoes for the child. So what's the consequence of that, right? Well, one, they get to leave the house and get, to where they need to be in a quicker fashion. But really, the child never may learn to put on his shoes or may not learn in a reasonable rate and becomes reliant on the parent. Of course, can you put your child's shoes on? You can. But if it's something that's happening all the time and this is a parent that really values independence, would we say that this type of behavior, the parent's behavior of putting on shoes for the child, is leading them towards their value of independence or away from that value of independence? And this would be away. So that's why it's really important to identify those values and be able to communicate with parents regularly about how their actions may not always be in line with what they want. And when they're able to do that, it can be a little bit easier to do really hard things and teach children because you know that you're moving in the direction of your values. So looking at another example of this, let's say we have a core value of connection. And we have a teen who is attempting to communicate a frustration with a parent. So that's the antecedent. That's what's happening right before. And then we have a parent that tells the teen, it's not a big deal and you just need to move on from that, right? Now this behavior, the parent's behavior, may not seem that significant, but what is the consequence of this? The teen may essentially learn that the parent is not safe to communicate with. And then we have a parent that really valued connection. I want to connect with my teen and build a relationship, but I really just, my behavior has shown that I'm dismissive and really not there to connect. And these are things that, I'm really simplifying these examples, but they're actually very common, and parents may not readily realize how their behaviors are not aligned with the things that they really value. So this is one way to kind of break down everything using that ABC analysis guided by the values and being able to regularly have conversations with parents to show them the inflexibility in their behavior and also the impact that it's having. So what do we do when discomfort shows up? Are we escaping the yucky stuff, we could call it, the things that we don't like? Or are we trying to do things just to access more of the good things, right? Which is not necessarily good either, because that means we're not really being aware, being in the present moment. And this is what we would call experiential avoidance in ACT, and fusion as well. So unlike diffusion, like I talked about at the beginning, this is a really fused situation where we're really stuck to our thoughts. And we all do this once in a while. And as clinicians and professionals, we really want to help families get out of that habit to constantly escape and avoid things that are really uncomfortable. And then also to constantly behave in a way that is only to access more and more good things. We want to find a good, flexible middle ground. So how can we teach parents to respond to child behavior? And what are parents responding to specifically and why? So this diagram really shows the process that we're moving from and the one that we want to get to. So A, are we avoiding or minimizing unpleasant emotions or circumstances? A lot of our families and parents are doing that before we start working with them. We want to teach them how that's unhelpful and not flexible. So what would we do when that happens is use skills from our ACT toolbox to respond to those difficult internal experiences. So that's really how we would address this one. And then how are we actually teaching and shaping new behaviors in children? By practicing the committed action, by using the principles of ABA and moving toward values. So going back to the examples that I just gave earlier, for a parent that values independence, we can think what would be an appropriate way to respond in this situation that would foster and facilitate independence. And that would be, right, to teach the child to do it themselves. So that's what we want to work towards. And in the second example, we have a parent that really values connection. They want to connect with their teenager. What would be a better behavior in this situation that would guide them closer to that value of connection? And that would be listening and showing empathy, right? So that child is more likely to continue those attempts to communicate the next time. And so by addressing our internal experiences, by using the ACT toolbox, we can shape new behaviors in children. We can teach our parents to do that themselves with our guidance. And then we're also moving towards our values, which is what we want at the end. And that pretty much sums it up. This is the goal of everything that we're trying to do, is to teach parents to track behaviors that pull them away from their values. So in those examples that I've shared, those are two examples of two parents moving away from their values, and they're also not taking advantage of those opportunities to teach their children really meaningful and valuable skills. And this is how we help them to do that. So it requires us as clinicians to not spend too much time in problem-solving mode, but to really use those skills, of empathy and compassion and mindfulness, all those mindfulness skills, to help us to actually teach parents to be able to track their own behaviors, and then also be able to track the impact of their behaviors on their child's behavior. And at the end of the day, these values, connection, being supportive, being caring, and being a thoughtful, loving parent, all of those qualities and ways of being that I shared at the beginning of the presentation. To value something is to make yourself vulnerable. The more something matters to you, the more vulnerable you feel when you're trying to pursue those things. One of my favorite ways to think about this is that we hurt where we care, and we care where we hurt, right? So when we're working with families and parents that are experiencing a really difficult time, holding this at the forefront and really practicing that validation and helping them to identify the things that they care about, one, and then two, identify their behaviors and if that's in alignment with the things that they care about, we're better able to help them reach those goals. So these are my final reflections for you all. We're coming to the end, and that is to think about, what do you care about as a professional? How do you want to do your work? So what are some of those qualities that you want to bring to your own personal work as a professional? Supportive, caring, thoughtful, honest, truthful. And what was most salient to you in this workshop? So this is, again, a very brief introduction. I've gone through a lot of information, but what stuck out to you the most so far? And why was that important? Why did that matter in your work as a professional? I leave you with a final quote and kind of summing everything that I've just spoken about, and that is that psychological flexibility is the ability to adapt to a situation with awareness, with openness, and focus to take effective action that is guided by your values. That's a quote by Russ Harris, who is a wonderful ACT practitioner. I can send plenty of information, those of you that are interested. These are some additional resources that I highly recommend. Of course, feel free to contact me. I can send all of these to you all. This is a list of ACT practitioners and behavior analysts that present on this topic regularly, that you can find a lot more in-depth information about. There's some great self-help resources, and then the final list here are some really good resources that I recommend for those of you that are clinicians, especially the DNAB, which I mentioned at the beginning. And that is the end. If you are interested in any additional information, feel free to email me at behavioralwellnessmap@gmail.com. My organization is called Behavioral Wellness Map, where I spend my time mostly working with families and applying this work all the time. So feel free to reach out to me, and I'll be happy to share any more information. If there are any questions, I think we have maybe 5 to 10 minutes. I don't know if that's possible. You can let me know, Jan, I think. Yes. I can't hear. I can see you talking, but I can't hear.
May I ask a question?
Sure. I think if we have, it looks like we still have 6 minutes, so sure.
Yeah. At some stage, I wanted to check the success rate of ABA as applied to children in the USA. Is there improvement in the success rate? Is there a difference between what you saw in the USA compared to what you're seeing in the Emirates? I'm asking this question. I'm a child psychiatrist. I've worked a little bit with kids with autism.
Yes, thank you. Yeah, it's very effective. It's one of the few evidence-based treatments for children with autism in the U.S. And I've seen, yeah, in the 5 years that I've lived here, it's been very, very effective. From teaching communication, fostering independence, as well as assisting children in schools, preparing children for the mainstream setting.
Thank you. I don't know if anyone else wants to ask a question, but let me follow up by checking what motivated you to learning ABA, ACT, and working with children so intensively, because my takeaway from your presentation is the patience in doing what you're doing. Thank you.
Mm-hmm. Thank you. Yeah, it's, I think as really just human beings understanding behavior and understanding the science of human behavior, definitely for children with autism and families, but even with just working with people, is powerful and can really inform what you're doing when you understand the effect that it's going to have on the people's behavior that you're working with. So that's one of the main reasons why I'm so passionate about behavior and behavior science specifically.
Thank you very much. We hope that you'll come to South Africa to teach us a little bit in some of our mental health workshops.
Yeah, I would love to. Please feel free to email me and yeah, we can stay in touch.
Yes, I will email you. I've copied the email. So we'll stay in touch. We will have a big meeting next year, but travel is still an issue, but the years after, there'll be a possibility of inviting you to one of the meetings. Thank you.
Wonderful. V, I think you're trying to ask a question. For some reason, I can't hear you very well. Yeah, I don't know. I'm not sure why. If you could write down my email and email me the question that you have, then I hope I can answer it that way. Sorry. Any more questions? I think we have 3 minutes.
If I may ask a question, then, in absence of other questions, throughout the stages of ABA, is a focus on the parent or on the child? At what stage do you use the responses from both the child and the parent?
It should definitely be both. And my recommendation is the more that you can focus on the parents, the better it is. Because the goal, at the end of the day, we don't want children to be seeking, to be having intensive ABA services away from their natural setting for the rest of their lives. That's not the goal. So there should always be programming in there that specifically addresses the individuals that are in the natural environment. So that would include parents, nannies, caregivers, teachers, all of those people, because the more that they are equipped to understand behavior and understand how to respond, the more that child is going to be able to learn, because they're spending the majority of their time with those individuals. So things like parent training and training school systems and educators and things like that are by far, for me, one of the most important ways that you can actually make a difference, than to just remove the child from their natural environment and attempt to do all the teaching there, because there's a high possibility that they may not generalize those skills in their home and etc.
Thank you.
I don't know why I can't hear you at all. You're not muted, but I can't hear your question. So please write down my email and I'll answer your question by email. Bye. Thank you all.
Thank you.
Hi, thank you very much. I think I'm the odd one out today because this is the last presentation of the day and the conference. And I'm sure all of you would be tired and wanting to go home. So I'm not sure how many of you are listening to this presentation, apart from those I can see in this room. The reason it's odd, because I'm talking slightly a different topic, medical or clinical leadership. In fact, what we have talked in the last 3 days about rehabilitation and psychosocial rehabilitation, research, and the work that we provide, in fact, none of this can be provided effectively without effective leadership. Initial talk was about medical leadership, but being aware of this conference and theme of the conference, it's a multidisciplinary conference. So it's not only about doctors, it's about the clinicians who are involved in care of treating patients. They are the key and driving forces to provide leadership in order to get effective services for their patients. And if we are not the right voice of our patients, then we'll be struggling, as mental health or psychiatry is always, or it still is, lagging behind many medical disciplines that we are aware. I mean, I have no disclosures to submit to this conference. Well, I'll be talking about leadership, what it is and types, and how we contribute in changing the lead. Contribute in changing, bringing a change. And I'll talk about a few things, what is appreciative leadership, lean thinking, and why medical leadership. But as I have already said that I have slightly changed the title, it's not only a medical leadership, it is why we need a medical or clinical leadership. And then of course, I being a doctor, how to manage difficult trainees or difficult colleagues in order to make sure that we provide the right service. What is leadership and how we define it? Obviously, it is a talk and topic slightly out of our remit as doctors, nurses. But in fact, all of us are leaders, regardless of our role, whether we are doctors, nurses, psychologists, psychotherapists, occupational therapists, social workers, or even in hospital setup, those who clean the hospitals, sweepers, they have a leadership role as well. And if they did not provide the effective leadership, we will be having the hospitals full of infections. So we'll be contributing to the illness rather than helping to treat people who are not well. There are 7 principles of a leadership. And it is not about oneself. People who are in that role, they have to provide service without selflessness, without any agenda of gaining personal financial gains. They have to be honest because they are obliged to respond to the public because they spend their money. Particularly the country that I come from and many other countries in the world, health services provided by the public health sector. So it means that we are accountable. The people's money who support the system through their taxes. And we have to be objective, that we do not give unnecessary favors that people will like, but we will be helping people without any discrimination. Because again, repeating myself, we have to be accountable. If we did not feel that I'm accountable where I work, perhaps I will not be able to provide the right service. We have to be open and honest, transparent, telling people what we do and how we do with honesty and dignity. Leadership as a set of personal qualities. There can be many theories, and I don't want to go into those. Leadership as a social process, working with others and communicating and influencing and motivating other people. Leadership as a position, if you are a prime minister or a medical director in your hospital, or a clinical director, or a head of nursing team. And leadership and management, that is very important as well, which we'll talk in a minute. And clinical leadership, the people like me, who sees patients and treat them. We have to be leading services from where we are, means that at the point we see patients. Leadership is personal. It's not about organization, community, or a country. It's about us, that how we interact and behave and communicate with people. If they did not trust us, what we're telling them, then of course we will be in trouble. Communication is a very important skill for any leader. Our ability to convey the message, whether it's a business, a company that we run, or we're running organization for commercial benefits. Whatever we do, we have to be able to communicate effectively. Now we have to identify the difference between managers and leaders. Managers usually plan, where leaders give directions. Managers are concerned about budgeting, and leaders have vision. Managers look at the timetables. Leaders look at the strategy. Managers look at resource allocations, and leaders look at how they communicate. Managers look at the structures, and leaders will be looking at the individuals, how built teams. They will be looking at the staffing level, whereas leaders will be inspiring and motivating the existing staff members. Management is about controlling, and leadership is about changing, because the reality is that we are changing all the time, whether we like it or not like it. We are changing all the time. Even within ourselves, there is constant change taking place biologically. Managers check things, and leaders involve people. There are several types, but this is much more practical, and I think I like this one as well. This looks at the individual needs and task needs and try to maintain the needs. is a John Adler section model theory. This approach is practical and aims to show how to lead. Adler also highlights some core functional leadership, and these are know yourself, know your situation, choose an appropriate leadership style, and remember task, team, and individual. So it is very important that you need to know what you are, why you are there, and what is that you aim to achieve, and see what is the situation and what is the task that you have to answer. There are other models as well. Directing leaders usually have a low competence, but they are highly committed people. Coaching leaders, they have some competence, but low motivation or low commitment. Supporting leaders, they usually have a very high competence, but their commitment might be variable. Whereas delegating leaders who involve people, they are highly committed, highly competent people. I think I've already covered this. Learning organizations described by Peter. It's a personal mastery that we get mastery in what we try to do. We create mental models, and then leadership theories that I've mentioned, you share vision by involving different people and talking to them and listening to them and learning the teams that what their aims and objectives are, and try to think systematically, like you see a patient, you see what symptoms they have come from, how these symptoms have developed, and how you're going to manage. Exactly the same way, you systematically think about management or providing leadership as well. Emotional intelligence is one of the most important things, and it has 4 components. Capacity to recognize your own feelings and of those around you. So it's not only that I'm looking at my feelings, but I'm also looking at what I say, how it is going to impact other people. And it is about motivating ourselves. Ourselves include you and others, and managing emotions well within ourselves, because sometimes we hear things that we may not like, but rather than reacting in an angry manner, we listen why that person has responded into that situation now, and why now. Self-awareness, I've already covered it, knowing about your own emotions, being aware of yourself, and self-assessment. You need to critically assess yourself. Social awareness, we have to be empathic towards other people. We need to be aware of organizational demands as well. And we have to be looking at what service demands are. Self-management, we need to manage our emotions. Like I said, that somebody react badly to us rather than reacting same way, an angry response is not going to be a good response. Relationship management, it's important that develop relationships with people and working with them, inspiring other people, motivating them. Leading change, it's not about showing a syringe that, look, I'm going to give it to you. Don't worry, it's not going to hurt you. Yes, it's a reassurance, but at the same time, it's a threat as well. We know that change goes through different emotions. Initially, people get anxious. Whenever there is a new change, it brings an emotion, and that's the anxiety. Then it might bring happiness that, I'm going to go to achieve this task that I have thought. But at the same time, I might be frightened and fearful that if I did not achieve, how this is going to impact my life. And that fear will bring on threat that I might lose my job. It might bring a guilt in myself that I have not only taken this responsibility on my own, but what I am going to do is going to affect a lot of other people around me. And people may go through depression and despair. But when they start moving and things are going smoothly, people will start accepting the change and then smoothly move forward. Leadership role in change is defining your role in the process. What is your role? What is that you are going to achieve? If you tell people that you're working with clearly and honestly, what is that you want to achieve, more than likely they are going to work with you. If they work with you, it's a success. But if you tell them wrong stories, like Prime Minister of England, Boris Johnson, gave this notion to the public that by going through Brexit, we're going to save so many hundreds of millions of pounds that we spend on the NHS. And identifying the knowledge and skills. When we are talking about people, we need to know. If I'm going to involve different people, we need to put right people into the right roles. If we did not put the right people in the right role, it means it's setting to fail. Recognizing the impact of your inner voice, that what is that you think, what is your gut feeling? Leaders' role in change is they listen to other people, they are realistic, they have a very friendly attitude. Like, I was surprised to see that King of Abu Dhabi ended up visiting a car mechanic lady. This shows that they are empathic, listening and reaching out. Coaching, being motivators, and visionary, have a long vision rather than thinking at here and now. They try to mentor, and they are good communicators as well. The patterns of change that we see in healthcare, change is demographic and disease profile. That certain areas have certain conditions, like schizophrenia, for the sake of an argument. We know that it is worldwide 1%, but at the same time, we know that in bigger cities, inner cities, rates are much higher than people who are living in countryside. Change is in pattern of illness and pressures on budgets. Depression is going on rise. You already know the WHO has recognized depression as the second largest cause of morbidity. Patient and community expectations, what public expects. In England, NHS is free. If you go and make that service, paying service, people are going to respond. People are going to react to that. It might not be that kind of a reaction that you would expect in America, but at the same time, you heard yesterday, American colleague, he was talking about the pressures that doctors go through, the record keeping. They want to write so much. And again, service there is dependent on how much insurance that you pay. So it depends on an individual's pocket rather than a public money. New techniques and technologies keep on evolving. So we have to make good use of these services rather than indiscriminately prescribing certain investigations that are not needed. New approach to self-sustaining and continuous improvement. Increasing emphasis on a step change innovation rather than bringing big change. Bring the change in stepwise manner. Smaller steps, you see the success and move to the next step. The organization of healthcare is changing. Again, there's no doubt, like I said, that things are changing all the time. I mean, this conference started with a lot of enthusiasm, a lot of people attended, and now these halls are empty. And I'm sure that people who are online, they will have dwindled down as well. Innovation and values. What is innovation? Innovation is about relationship. It's about taking risks. It's about finding the right resources. It's knowing what is that we know and what are the gaps in our knowledge. What is that we want to achieve? What are our goals? At the same time, rewarding people that continue to work with you. And we need to have the right tools. Now, I have learned that people will forget what you said. People might forget what you did, but people might not forget what you said to them and how did you make them feel. If you make somebody feel anxious, depressed, angry, they are not going to forget that, because emotion is a so powerful, tool that is going to stay with you most of your life. Is there anything? Can I carry on? Thank you. Appreciative leadership is again a tool in which people discover that what they want to achieve. Have a dream about it, that how they are going to achieve it. And then in order to achieve that dream, they design how they will reach to that point, and then try to look at the destiny. And again, if they did not reach to the destiny, they'll go through the same cycle again. They will discover the faults that they may have experienced during that initial cycle. Then they will have another dream, and then design new things. Lean. I mean, this is, lean comes from Toyota. Toyota car, we all know. I mean, Toyota car saw that their business model was how to reduce the waste. A lot of things were wasted, and they believe passionately that there's always simple and better way of doing things rather than making things complicated. A continuous drive to identify and eliminate the waste. The things that we should not do, rather than keep on doing the same thing without getting the right results. We shall be aiming to get rid of that repetitiveness that is not going to give us anything. We shall be looking at something better, which is simpler, and easier to achieve. And then apply rigorously the lean tools and techniques in the whole organization. And look at, when you go into the, I'm sure it's not only Toyota, you walk into any car showroom, you'll see they are going to present you with a tea, coffee. They'll welcome you and ask you what kind of a car that you need. Why medical leadership? Or I shall say, why clinical leadership? Because doctors and clinicians here have a role in healthcare, because we lead the healthcare. We are the commander, and we are the considerable user of the resources of the service. Whether we prescribe medication, we write investigation, it is something that we do that has an impact on the pockets of healthcare system. Professor Took in 2008, he was a British professor, he looked at how we improve medical leadership. He's aspiring to excellence, finding and recommendations of an independent inquiry into modernizing the medical career. Previously, we used to work differently. We used to have different terms for the trainee doctors, but now we have changed. And it's not enough for a clinician to act as a practitioner in their own discipline only. They must act as a partners to their colleagues, accepting shared accountability for their service provided to their patients. When we talk about colleagues, we're talking about a wider range of colleagues: nurses, social workers, occupational therapists, psychologists, even people who clean the hospitals. They are also expected to offer leadership and work with others to change system when it is necessary for the benefits of patients. It's tomorrow's doctors. We need to look at how we produce tomorrow's modern doctors. And there should be a greater freedom, enhanced accountability, and empowering staff. It is necessary for efficient and successful healthcare system as well. Leadership is a key part of the doctor's professional work, regardless of specialty and setting. So it's not that only managers or medical directors or clinical directors, they are the leaders. Every healthcare worker, regardless of their role and position, they are leaders. A legal duty broadens that other professionals as well, because we are legally accountable towards what we do. Doctors practice within system and organizations and have a responsibility to contribute with the organization. So we don't work in isolation. We do not work alone. We work for the organization, and we work with a lot of different people. So we have to take all those people together with us. A direct and far-reaching impact on the patient experience and outcomes. That is very important. What we do should produce a positive outcome in the patients that we see. The importance of a shared leadership is not dictated by the position, but by the influence. And that influencer can be anybody. I'm not sure how many of you are aware there was an incident in United Kingdom. A pilot's wife died during what you call surgical theater. So nobody was taking responsibility. When they went through, then there was a learning that there were 2 consultants at that group, and nobody was taking responsibility. There was a nurse who was trying to influence them, but nobody was listening. Since then, they have created this medical leadership competency framework. So in theater, somebody has to take a responsibility. If something goes wrong, who is going to lead? Who is going to tell even a surgeon to do what? Who is going to ask another nurse to do what? And it is about personal qualities. Medical competency framework about leadership is about demonstrating personal qualities. And working with others means a team working, managing the service together and improving the services, and setting the directions for achieving the right goal. I mean, this medical leadership curriculum and competency framework may not be relevant to, I'm talking about curriculum-wise, but it is very much relevant to every doctor. If you Google this, I'm sure you'll find this free resource as a booklet as well on Google. Now, what we do, I put here training, but it can be any colleague who is working in the team. If they start disappearing during the working time, and they're not producing what is expected from them, and they usually get angry and show disrespect and hostility towards the other staff members. They're very rigid in their working style. They don't want to deviate from what they are used to do. And bypass syndrome, nurses and others avoid seeking doctor's help. Sometimes you have, because doctor is a nasty person for their eyes. If I did ask Dr. Qureshi something, he might get angry. He might get upset. So people avoid that kind of a doctor. So if there is a career problems that people are not progressing well and showing these symptoms, it means that there is some problem in that person. It means that they have no insight into what they do. Now, like I must comment here, a lady called Zendi, she has been so responsible and so responsive during this organization that constantly communicating effectively with all speakers, communicating with all those people who have come here. And if she did not show that effective leadership under the leadership of Khaled Afifi, then obviously you will not have this successful conference. You would not have that successful conference. It's very important to have a leader. So it is not about a particular role. It's particular about who is going to take responsibility for that kind of a work. And it is, that they are failing in all these spheres. Personal life might go in shatters. Professionally, they are not progressing. Educationally, they are not progressing. Exams, they have failed. We have a responsibility to minimize these risks because these people are involved in healthcare. When one person who is involved in healthcare fails, it means that they are going to fail the system. If they are going to fail the system, it means that we are going to provide a poor quality of service. We talked about psychosocial rehabilitation. None of this will be possible if there was not a right leadership. Ensure safe return of the doctor or a colleague to the work. We systematically see and assess them without judging them, without being, penalizing them and, punishing them. We need to understand why they behave the way they have behaved. They need help because at the end of the day, we all human beings. Avoid more formal punishment. If we punish these people, it means that they will go off sick. If they go off sick, then you are going to be, earlier today I was talking about career opportunities. Why I was talking about that? We already know there's a shortage of doctors all over the world, but particularly in England and Europe, there's a shortage of doctors. So I was trying to share information with you that if any of you is interested to spare a couple of years to leave your country and go and work in another country to gain different experience, and that experience you can take back. So it's by you coming back to England, not only that you are going to contribute in the system, but you are going to learn as well. At the same time, we'll be learning something from you as well. And improve working between doctors and human resources. That's very important. Identify the problem early. Earlier you identify, it will be easy to eradicate, obtain information from other people. But it is important, one thing I should have said earlier, when you identify the problem, do not publicize it. Maintain a confidentiality that, if there is a problem and Dr. Qureshi and Gabriel Roca is a medical director, Gabriel shall not talk to Medhat about the same thing because we work together. So he shall keep it confidential because my privacy is very important. Obtain information from others, but in a confidential manner. Explore and work out and what is the underlying problem. We need to diagnose what is the problem with Dr. Qureshi, that he is not coming to work. He's always sulking. He gets angry. Nurses and junior doctors are frightened of him. Why? So rather than thinking that Dr. Qureshi is a bad person, you need to identify what is wrong with him, why he is behaving, whereas he has not behaved like this for many years previously. Work out appropriate help or interventions. Treatment if that is necessary. Treatment if that is necessary. Every organization have their occupational health departments. You refer them to occupational health. WPBAs, I mean, this might be a new term for me. It means workplace-based assessments. I mean, in England, since Professor Toole, the example that I gave, the modernization medical careers, now the progression depends on junior doctors or training doctors, workplace-based assessments as well, that, they are assessed by different professionals, they are seniors. Exactly the same way, you might remember, those of you who were there earlier this morning on my other talk, that I talked about appraisals. Even the senior doctors, they go through appraisals. So they have also, not WPBAs, but they do case-based discussions with their other colleagues and review and monitor the documentation. It's important that these people are able to maintain the portfolios. If they don't maintain the portfolios, it means that there is something wrong. And get help from the others. In that case, tutors, TPDs. If it is a nurse, then nurse director. And document. Important thing is that whatever conversation that you have, you must document. If you did not document, means that nothing had happened. Like patient. If you have what you call treated patient, and if you have not documented and something goes wrong with that patient, despite your best intention, best efforts, you will not be able to prove that in court of law that what you did was with the right intention, unless you have written it down and documented somewhere. Email trainees and copy relevant others means that something goes wrong, something is not happening, you try to reach out to that person, whatever means that you have. Another thing is important that we need to, I like this cycle. I like Gibbs cycle than many people use other cycle, COP cycle, but I personally like this. This is why I put, we need to understand what has happened and what were we thinking and feeling at that time when something was happening. What was good or bad about that experience? What sense can we make out of it? And where else we can go? And if it happens again, how we are going to manage that? It's important that we reflect. Reflection is again a systematic way of looking at things. Description is a change in local educational program through School of Psychiatry or its impact. Feelings are unhappiness amongst the trainees. Evaluation is implemented the new system, but lack of attendance because of the unhappiness. Analysis is expensive, time consuming, leaving some sites without trainees. Conclusions, alternative models such as teleconference. Action plan is review and reflect. This presentation, I made it much earlier than COVID, and telepsychiatry has become a norm these days. And those days, telepsychiatry was not something that we were routinely thinking. Our feelings are very important because these affect our progress. Challenging somebody is not easy either. Challenging somebody is difficult as well. The way you tackle things, you need to think about the strategies. What is your strategy, how you deal with that person? Things that you find about yourself. Thought about how you learn the best. Ideas arising from your learning or studies. How different areas of your studies link up. How your studies relate to the real life. I've come to this conference. My employers would like to know what is that I am going to learn from this that I'll go back and produce there. Now, because I'm involved in a psychosocial rehabilitation as one of the officers, besides this, I am also a rehabilitation psychiatrist. So it is an important event for me. So I have come here, so I have to demonstrate what I have done. It's not because I am office holder, but because I'm working at well. So what I'm going to give back to my own organization. I mentioned our COPE cycle. Again, it is something, it's very popular, but for some reasons I like the other Gibbs cycle. The concrete experience that you feel, you reflect about the observations, and then conceptualize it, and then active experimentation. Reflective practice is a habitual and judicial use, communication. And again, if you look at the biblical, I am here in the land of Arabs. Israel is not very far from here, the land of three major religions. So if you look at the biblical texts, whether it is Judaism, Christianity, or Islam, all of these talk about think. It asks the human beings to think what you do. So it is important for us as well, regardless of our religion, regardless of our faith, because of our practice, we need to think about what we do, how it affects and impacts on people that we treat. And I was speaking with a colleague from Israel. I think she's sitting here, and with her permission, I'm saying this because I did ask her and other colleagues from Israel. I mean, Israel is in a constant state of a conflict. It is a responsibility of healthcare professionals like her and others to ensure that healthcare is provided regardless of ethnicity and regardless of alliances. And I was really pleased to see that they did not only come with them as Hebrew speaking, but they had an Arab speaking colleague as well. And I went especially for their presentation, and one of their presenter was Arab. And although I had difficulty understanding Arabic, because I don't understand the language, the main of the conversation was in English, Arabic. So it is important that we need to provide leadership at all levels to ensure safe healthcare for our patients. I'll stop it here, and if you have any questions, I'll be happy to answer. Not that I'm expert on leadership, but it's important that we all have a role as a leadership. I've given you some what you call references as well. My presentation will be available here if anybody is interested. Not that it's a rocket science, but if anybody's interested in any references, they can always have it. I'm happy to take any questions if anybody has any questions. Thank you very much. And I guess, pardon me? Yeah. Hello, it's Murali. Welcome, Murali. Mr. President, thank you very much. You are the leader. You are the real leader in terms of not only as a doctor, but in your role as a current president of World Association of Psychosocial Rehabilitation.
I was quite impressed with the way you have been talking, because currently in India, majority of the corporate hospitals are on, as well as the private medical college institutions are going for what is called the National Accreditation Board for Hospitals, called NABH. Now, where what happens is that everything is being duplicated, lot of record keeping, and what happens is that, as you rightly point out, if you don't keep records, it is not being done. That's the way it is being talked about.
Yeah.
Now, the issue comes is that in places like low and middle income countries, I can understand in the NHS how you can do these issues, but in low and middle income countries, there are a lot of difficulties which comes in maintaining an extensive record and issues like that, because sheer number of patients who come to the hospital every day. That is one. The other point which I want to raise is that we have the administrative, hospital administrative, MD in hospital administration in India, which is being done by people who are doctors basically. But what we find is that after they complete the course and comes out of it, they are more an administrator than a doctor. Now, what I suggest is that the doctors who have had sufficient field experience over a period of time with the patients and like prescription pattern and how much time you have to spend with the patients and how much time for record maintenance, but they know all these things, and they are the people who should be the leaders rather than some manager coming and or an administrator coming and dictating terms with the doctors. This is happening across the world because, as we rightly point out, it is an insurance system which is dictating the whole healthcare system everywhere now, planning towards that. But in India, we are having both the government service as well as the private thing. Majority of the, like large population is being catered by the free healthcare services from the Ministry of Health. And it's not at a center level. Every state government has got its own rules. So one of the things is that they get the free medication, and in all these places, in the government side, the medical superintendent or the administrator of the respective places will be a doctor. It is not given to an administrator now. But in private side, what you find is that all the corporate facilities are managed by the administrators, and they dictate terms with the specialists. They can also terminate you. They will get information from, as you rightly point out, the privileged information from non-medical people who are there as nurses or staff at the class 4 level, various people, they collect information. And then they say that one fine morning they call the doctor and say that, doctor, your work is not satisfactory. Tomorrow onwards you may not come. What I'm saying is that there is a lot of clash between the so-called administrators and the thing. They are not actually leaders. Leadership, as you rightly point out, it should be with a vision and what is to be done and what is feasible at the ground level, which is not being looked at in various places. This is what I want to make a comment. So, excellent presentation.
Thank you very much
good
for your comments, Mr. President. I'm glad that you did not ask me a question because I was having some difficulty, comprehending the whole thing because of the voice quality.
Okay, okay.
Yeah. Any other
I have
questions?
a question to ask.
Yes.
Yes.
Another leader that we have,
may I ask?
Solomon Rotmane, he is our Secretary General. Yes, sir.
Thank you. I'm calling from South Africa, Pretoria. Kuresh, thank you very much for this presentation. Extremely informative. You touched a very important point on confidentiality. The question I have is, does it help to ask staff members to sign a confidentiality clause, before they start? Or you just say it and hope that the staff understand that as employees or part of the system, they have to keep secrets. They shouldn't just talk anyhow. Does it help to sign or not to sign?
Right. Now, thank you very much, Professor Solomon Rotmane, another leader of World Association of Psychosocial Rehabilitation as a Secretary General. It's a very good question. Now, I think it very much depends on the country and organizations that we're working in. In England and the NHS, when NHS employs a doctor or a nurse, it is already embedded in the contract that, we are not going to talk about patients, or we're not going to talk about colleagues, unless there is a real concern about patient safety. If there is a patient safety, then you have to, speak out. If it is not affecting patient care and it's only a behavior of that individual, then there is a appraisal system that has come into system in year 2000. And I'm sure you might know, from year 2009, all the doctors in England are licensed rather than having, just registration with the medical council. They have a license to practice. And the license to practice requires us to go through revalidation. And each year when we go through appraisal process has 6 things. One is your knowledge. Second thing is your involvement in quality. Third thing is that learning from incidences risk, learning from what you call learning from complaints, if people have made complaints against you. Fifth thing is your 360-degree appraisal. The last thing is probity and health, that your health has to be in a condition that it should not impact patient care. And other thing is probity. Probity means that, I'm sure you know that we have to be honest. And so in England, I think it is necessary, and if it is not embedded already in your contracts, I would suggest that that protects those staff as well who are going through difficulties, and those staff as well who are managing them are going to investigate them as well. it's very important that that system is embedded. So, I mean, I would say that will be a breach of confidentiality if you did not. Of course, if it is not already there, then it depends to the local laws, codes, that how they deal with that.
Thank you very much, Krish.
I'm not sure whether I answered your question or not, but this is what my understanding would be.
No, Shad, I think that, yes, you've answered my question. It's important to have it somewhere, maybe at the beginning of the contract,
yeah.
But it should be verbally repeated, at regular intervals, just to assure staff that...
You need to look at South Africa's, I'm sorry for interrupting, you may need to look at South Africa's employment law, that what is the employment law is suggesting.
Okay. No, thank you very much.
Any other questions? Yes, VK, how are you, my friend? I have sent you condolences of our very senior Indian colleague, doctor, who passed away at 98. I'm really sorry for your loss. Yes, what is your question, sir?
Can't hear.
I can't hear anything.
Unmute.
Yeah.
Unmute. Can't hear.
VK, you're muted. Unmute, please.
Unmute. Can't
VK,
hear.
unmute. You're muted.
Okay. Sorry, I'm sorry. VK can always drop me a question by email, and I'll be more than happy to answer if I can. Because we are together on WAPR's WhatsApp as well. Any other questions from outside? Thank you very much. I would like to thank you all for giving me this opportunity to do second presentation in the day. Thank you.
So, as we are, okay. As we are approaching the end of the third day, and after discussions of the executive board member and lengthy discussion, because we have lots of very important posters. So we decided to have 4 poster prizes. First one, and then second, and 2 shared third prizes. And there was a sort of agreement. All of the executive board members, most of them agreed on these selections. So the first prize, according to the voting, which will give to the winner $200. It's about psychosocial and vocational rehabilitation and the members of Franco Basaglia Day Center. And the speakers are, or the presenters are, Kuro Costa Angelici, valuable Los Fortis and colleagues. So congratulations for your first prize, and they are from Greece. Colleagues are from Greece. The second prize, which is $150, goes to the poster using task analysis and video modeling to teach a child a cultural dressing skill to children with autism in United Arab Emirates. And the speakers are, or the researchers are, Amira Salim, Moza Marzouki, and Farah El Zain. Congratulations. The third prize, each one will get $100, and its first one is barriers to vocational rehabilitation in adults with autism spectrum disorder, a case series from a tertiary mental health services in India. And the speakers are, excuse me if I am wrongly pronouncing any, so the names are Arkishan Mamtani, Kartik Singhai, and colleagues. So congratulations for the third prize. And the second, actually the deal was that we are going to have only 3 prizes, but we found that these 4 winners deserve to be in the best boosters. So the second, third one is take care of those who care, psychosocial rehabilitation for oncology nurses. And the researchers are Dr. Sahar Dawood, Dr. Noha Ali, Dr. Manal Alewa, and they are from Egypt. Congratulations, and we are honored to have that great participation from colleagues from different countries, and luckily the posters were really distributed between many countries, which is giving a meaningful for our global perspective of WAPR. And we are honored to have your presentations. Also, the MENA conference, generously, Mr. Khalid and colleagues, they agreed to expand the prizes to contain the 4 winners. And definitely we have the contact of colleagues there. So we are going to forward to them the certificates of appreciation and the deserved monetary assigned to those prizes. So thank you very much, and we're going to have the next speaker, which I mentioned to him. We kept the best for the last, to be the best ending before the closing ceremony of the conference. So I'd like to ask the President-elect, Dr. Gabriel Roca, to introduce Professor Roberto Messina.
Roberto Messina is a psychiatrist and currently the director of the International School Franca and Franco Basaglia, the Practice of Freedom. He was director of the Department of Mental Health in Trieste from 2012 to 2019. He contributed from 1978 to the experience in Trieste, which inspired the Italian mental health reform law of 1978, with the closure of the psychiatric hospital and the creation of a network of totally alternative community-based network of services. From 2009, he was the head of the WHO Collaborating Center for Research and Training in Trieste, which aimed to support community-based services and reform policy worldwide. Among others, UK, Denmark, Australia, Czech Republic, New Zealand, Serbia, France, Poland. He is chair of the International Mental Health Collaborating Network. He has been invited as teacher, keynote speaker, and expert in hundreds of conferences and courses held by scientific institutes, universities, mental health services in Italy, Europe, and overseas. Prized by Zero Project at UN in Vienna 2014, and as European Personality of the Year award by Gamian Europe in 2017. Recently, he has been nominated as Vice President of the World Federation for Mental Health for Europe. He is also a friend close to me. Please, Roberto.
Important realities worldwide, representing so many countries, so many type of stakeholders within the field of mental health, and moreover, I think the WAPR represented the innovation across the world, gathering best experiences in services. So that's why I'm thinking of the subject that was asked to talk today, which is about the key principles of community mental health care. I will start from my experience in Italy and in Trieste, but I hope that some of these ideas will be shared on a wider, more global scene. So we can think this can be the mature age of a community approach, but is really now the time for community mental health? Can be the new horizon. We are wondering if it's appropriate now to sanction the transition from psychiatry to community mental health. And we can define community mental health as an approach that is concerned with the health of a population, not just that of individuals, which is rooted in communities, offering treatments, but specifically in the context of real life and social life, using the resources of the communities and other resources available in the area, in other institutions, and also orientating the action toward health promotion, prevention, and community development. So it's something much more beyond the idea of a social or community psychiatry. The focus in community mental health care particularly can be thus not just on the content, but on the delivery of care. That means the overall impact of a service system on a whole community, not just on individuals in care, and thinking not just of applying techniques to be inserted in different contexts or settings, but the construction of processes of care and pathways of care in integration with welfare systems and services which can provide what is called integration. So integration between social and health care, which can address going beyond the medical and psychological model, can address also the social determinants of health, and particularly mental health, can be our horizon. Integration between public and so we can call third voluntary sector, NGOs, so statutory and not statutory services, co-production with stakeholders and the other community representatives is also very important. Another tension we can find in this field is the relationship between structures of care, services, as facilities, as buildings, as teams, and components and functions. So I think that each structure don't exhaust the various functions to which it must respond, and functions overlap across different structures. So we should be seeing all these functions integrated in a continuum to respond to healthcare needs. This is a very common, let's say, mistake in planning services, which are just focused on one or few functions while they should connect themselves in a wider continuum. Another important tension today, as we all know, is the one between comprehensive services and specialized services, particularly in high-income countries. But it's now a problem emerging also in developing countries or medium and even low-income countries. We can find, for instance, an emphasis today on early intervention, which is correct, particularly for young people, but we must ensure that the basics of care are guaranteed for everyone. So if we start to specialize without having covered early intervention and open access for all users, that means what Alan Rosen and Peter Byrne called early intervention of nearly everything. We cannot just specialize in one field like that. So rather to specialize function in separate services, which can create risk of fragmentation or a sum of intervention, which is linear and horizontal, we should think in a vertical synergies where contemporary multidimensional stratification of services can be dealt, and a balanced system of territorial responses. Let's speak a little bit about organization. I think this is valid for our experience in Europe and in Italy, but I think these are principles that maybe we can share on a wider scenery. For the three levels that Carl Wake, which is a very important expert of organizations, wrote in 1998, is the connection between principles, procedures, and interactions between the actors. These three levels must be satisfied together, linked to each other, because the principles must be translated into processes and interactions between institutional subjects in the different care contexts. The WHO has set up the very important action plan in 2013. Now it has been extended until 2030. And some of the 3 points and the principles that I would like to underline here is the right-based approach, empowerment, and multi-sectoral approach. This put an emphasis on the connection between the 3E that Thornycroft and Transella described, between ethics, evidence, and experiences. So we don't need just to have evidence-based services. We need ethical base, and we need real experiences of people using services, which is the experience of care and the experience of contributing to mental health on part of the different stakeholders. The issue of rights emerged at this stage. In Italy, we have a tradition where the issue of rights, in particular human rights, is intended within the overall issue of citizenship. Ensuring citizenship of people with mental disorder means fighting against discrimination and social exclusion. And today this is updated by the important affirmation of the Convention on the Rights of Persons with Disabilities that we all know of the United Nations, which in Italy has been ratified in 2009 and in many other countries. There are some examples of areas sensitive to the issues of rights in community mental health today. The use of restraint, not just the physical, mechanical restraint, but the chemical restraint. Alternative to use drugs then, and the reduction of coercion in general is an important aim of the evolution of services. We need to emphasize the importance of having community-based services which tend to operate 24 hours a day. Of course, in developing countries or in countries with low income, this is very difficult to achieve, but they should go in connection with the other community resources to offer a wider coverage which can compete with the existing hospitals. 7 days a week, to be mainstreamed in healthcare organizations, that's the importance of primary care, integrating them with welfare services, promoting prevention of disability through early intervention, contrasting institutionalization, and responding to whole life needs, from housing to work to a wider social inclusion. And such services must be planned, delivered, and evaluated in co-production with stakeholders, particularly people with lived experiences. 24-hour services, in our experience, particularly in Italy and in Trieste, are intended as full alternative to hospitals when they have to guarantee a 24-hour response. This very important affirmation started in 2005 at the European Action Plan in Helsinki, 2005, where particularly the action plan connected to the declaration identified the hospital as a last resort. So we must ensure that community-based services and systems provide a full alternative. That means having a rapid and mobile response to crisis, but also ensuring the continuity of care subsequently. So we need to use what evidence-based model of care, like the assertive community treatment, like crisis teams, but these are usually intended as alternative to hospitalization. There are new forms like crisis homes, sanctuary houses, foster families, and we underline our experience of community mental health centers, which are open 24 hours a day with a few beds, which is the Trieste model called. Rehabilitation must be developed, must be community-based, must be developed in the community dimension, which means that this is linked to a process of social inclusion. I think it's important that we can start to take seriously the issue of benchmarking community service models, unless there is the risk to fix or standardize the models of services. We should try to find which are the most important outcomes and evidences coming from several models. For instance, the OECD in 2018 made a proposal referred to principles and related indicators, a very interesting set of indicators. And recently, in terms of services, it has issued a mental health performance network with 6 principles, which are similar to those we are listing today. That means focusing on individual, having accessible, high-quality mental health services, taking an integrated approach, multi-sectorial, preventing mental illness and promoting well-being, also having a positive mental health approach, providing strong leadership and good governance, and focused on the future and being innovative. These are, I think, things that we can be sound in our experience. But there are other things outside the horizon of services, which is the complexity of ecosystems, has been defined by Rosen and Karula recently. And so we need to define which are the indicators to catch the complexity, to evaluate the complexity. Or on the other hand, on the ethical side, Gianni Tognoni in Italy has issued the concept of epidemiology of citizenship, focused on rights and related indicators of the implementation of human rights. For instance, an example, for instance, to measure the outcomes of community-based 24-hour system in terms of number of involuntary treatment, because we can not give the fault as a failure of the patient, but this is the failure sometimes of prevention on part of a service, providing a low hospitalization rate, the short duration of acute stay, because nobody likes to stay in a hospital, having a reduced number of long stay residential facilities and moving toward supported accommodation, a low rate of forensic cases and security measures, and providing appropriate use of medications, less polypharmacy, no lifetime prescription if possible, alternative to drugs through a psychosocial intervention, and overall cost effectiveness and sustainability. This is a framework. I don't want to go, of course, in details, but if we can see the progression from the person to the group, to social network, local community, and institutions and society, we can also see that at different levels we have the level of service, we have the level of life stories, identifying group and family as the social network, etc. Multidisciplinary approach, progression from monoprofessional toward co-production, healthcare, and welfare integration, orientation from recovery-oriented, peer support, etc. So we have to deal with all this complex system that there is no time to go in depth, of course. Human rights is very important today. There is a lot of emphasis also in this conference that started also with the presentation by Michel Funk from WHO, which, with which I collaborated in the last guidance for the part on Trieste and other more general parts. But it's important not just to declare human rights, but try to realize human rights. There is now a momentum for addressing the transformation of mental health care by embracing human rights, especially personal freedom, in our opinion, is a precondition of care. There are other important aspects related to legal capacity, open door, no restraint policy, abandoning confinement and seclusion, but also right to work, housing, and social inclusion. So ensuring human rights is a preliminary step also to address social justice and to reduce stigma and discrimination for people with mental health problems. Usually freedom is seen as a result of a positive, good recovery pathway. The person has recovered, anyway, is deserving to be free. But we think it is a preliminary choice on the sound part of a mental health system of care to ensure liberty and freedom, possibility of choice to the person in order to use the person as the main resource in the process of care, not just an object of care, but a subject of care. The WHO has ensured all these principles, particularly not just the human rights, but also the fundamental freedoms. Many international stakeholders are working on this side, like the WAPR, the World Federation for Mental Health, also the World Psychiatric Association, and have set up relevant working groups or documents, charters, etc. And some affirmations are particularly striking, like the one said by Special Rapporteur on the right to health, Daniel Spouras, there is no health without human rights, even. So this is particularly timely because the COVID pandemic has signaled the high increase of human rights violations toward people with disabilities, not just in institutions, but also at the margin of our societies, the homeless people, the migrants, which have proved to be some of the most vulnerable population during the pandemic. So there is urgent to call now for universal attention to this crucial issue, because no real care will be possible and no increase of quality of life without human rights. Alternatives to coercion is important. This must be not just alternatives, in our opinion, but try to be mainstream, generalized, becoming systemic forms of approaching care, reducing coercive intervention in routine clinical practices, changing the organizations, but also providing innovative type of services. It has been mentioned during this conference, the recent WHO guidance and technical packages on right-based community mental health services, which are focused on particular areas like mental health crisis services, hospital-based mental health services, where it's demonstrated that even in a hospital you can have an open door system, community mental health centers, peer support, community outreach, mental health services covering social aspects of care, supported living for mental health, and finally, comprehensive mental health service networks. And the three examples are listed are Lille in France, Trieste in Italy, as I mentioned, and Campinas in Brazil. So not just in Europe, it's something beyond. Another aspect is working toward a whole life approach. A whole life is a right. The whole life approach has been experimented in various countries, particularly through the organization which I chair, which is the International Mental Health Collaborating Network, which promotes by applying a whole system methodology in design, planning, and implementation. That means creating a system to support all the life domains that the person needs to be fulfilled. So implementing the CRPD in the real world is now the problem. That means not just fighting today for decentralization, like many years ago, and this is a very important legacy of the Italian experience that WHO has captured for more than 20 years ago under the presidency of Benedetto Saraceno, Angelo Barbato, and today Gabriele Rocca, but also fighting against dehumanization today, seclusion of different forms, confinement, for instance, in forensic services, etc. On one end, this is still a very important point, but on the other hand, we need to converge with all the strategy for the advocacy of substantive individual rights, converging both strategy. So I think this is a very crucial point, in my opinion, that must be fulfilled. Some of the examples to provide alternatives to coercion is to establish a no-restraint general framework in a service view. The three E's that I mentioned before, ethics, evidence, and experience, but also changing the relationship of power no internment, providing citizenship rights, an open door approach in service, so people can come inside the services, can use the services, having a democratization of the access. Marginal use of involuntary treatment based on the principle of negotiation, which is crucial, that recognizing to the other person as being a contractual subject in a power relationship, sometimes where you have to give up, you have to recognize the power of the other. That's a very important lesson that comes from the Italian experience, particularly Franco Basaglia. Let me speak a little bit about Trieste. I think Trieste is an example of human rights application in practice. This is the quotation from Nicholas Rowe's last book called Our Psychiatric Future, where he recognizes that there was some success in trying to combine an approach that can go beyond the tension between care and control that was denounced by Basaglia, that was typical of psychiatric hospitals. Care on one hand, the promise of care at least, and social control. It's possible to make a mediation, working out this contradiction, and demonstrating that freedom is therapeutic, like in this famous drawing by Ugo Guarino, a great artist that contributed to Trieste. The system of care in Trieste, which is now unfortunately under threat because of changes in local politics, and after the pandemic also, so it's not supported by the center-right government of the region, unfortunately. So we are fighting to support it also using the international support that I please you also to provide this support. Can be intended as a system of opportunities on the 24 hours, where also not just the treatment of illness, but the recognition of the importance of health in the daily life is an important aspect. A free open access with an immediate response in the community mental health centers. It's a holistic, ecological, person-centered and recovery-oriented, using social networks, connections within the network, inclusion and social capital. So looking at extra-clinical aspects, not just the clinical care, and social determinants, addressing the social determinant of health by using, for instance, personal budgets, where you can respond not just to the care needs, but also to the social needs of the person, using work grants, etc. And try to involve the city, building bridges to community toward what is called the caring city. This is the utopia. Criteria are well known, so based on the principle territorial responsibility on your community. So the service is the point of reference, the single point of entry. This service must be mobile, actively present, proactive and assertive, providing the therapeutic continuity, no transitions in care, not passing the patient to a service to another, from a service to another, for instance, from acute to ongoing care, responding to crisis in the community, providing comprehensive care, mediating social and clinical responses. The teamwork is important. The team must be becoming an organic entity which can use creativity, not just multidisciplinarity in the whole team approach, and addressing the whole life approach as the final aim. This has been described by important research by the Trimbos Institute in the Netherlands that underlined three aspects: the holistic approach, the ecological approach using the resources of the community, and the legal approach, which is based on respect, and not just respect, but implementation of rights. This is an example of our little things done in the community. This is the ship sponsored by the social cooperative, local entities, etc., with the Marco Cavallo, the blue horse, as a symbol. And the ship is run by our young guys, people with psychosis, but becoming skippers, and very powerful demonstration of the inclusion in our society. Looking at what happened during the pandemic, I was part of the European group, technical advisory group that WHO has established. This group has issued 3 levels of recommendation: general population and community, the second is about vulnerable groups, and the third is about public mental health services. Starting from the consideration of the paradoxical situation that COVID has created, particularly for community mental health, because the therapeutic relationships and any kind of social links has been anyway put at stake. The social connection and reconnection are diminished by lockdown and other measures. The social distance, the community-based services has been reduced, and psychiatric institutions became more locked than ever. So they also proved to be sources of infection on the other hand. So human rights has been compromised, as demonstrated by researchers by the World Health Organization in Europe. So the decrease of the respect for human rights in a locked environment. Small scale has been demonstrated that it is safer, for instance, small supported accommodation where there is a shared management on part of the service users which are hosted there became safer. There is also an important opportunity, great opportunity to challenge stigma by developing the better understanding of the issue of mental health that is everyone's problem and business. And vulnerable people have been impacted more by social isolation and disappearance of the society as a resource. So we need to have to address a more active participation of people with mental health problems, solidarity at the community level, whole of society responses, as many international bodies, starting from the UN, the United Nations, have underlined. But what is more dangerous now is the long-lasting consequences and effect of mental health of all people, not just people which are suffering for psychiatric conditions, but everyone, including us. This is occurring today, and particularly in a situation where the shortage of services, the impoverishment of services is a matter of fact. The socioeconomic inequalities are also worsened, and we know that there are health inequalities and systematic differences in health between groups of people which are avoidable and are very really unfair. Much of these are created by structural and political processes, and they represent a very serious social injustice today. Economic vulnerability is not exhausting the issue because this is strongly connected to social vulnerability, which is the potential impact on events on people who are poor, single-parent household, pregnant or lactating women, people with disabilities, children, and elderly. There are very serious risk factors which are worsening during this period. We know poverty, unemployment, disparities in access to education, and minority ethnic communities, and gender inequality. So all these factors, which are social factors, are impacting differently according to several individuals, but particularly the vulnerable groups are suffering the most. These are spatial groups, which range is very long and cannot be defined by strict criteria. Even there was some attempt to define who are the vulnerable population today. But this is mainly also another social and political issue to define what does it mean vulnerable. The impact on long term can be heavier for those suffering from a negative impact of social determinants of mental health, which can have a cumulative effect. These are treated especially about equality to receive care for the pandemic, access to services, social exclusion, and stigma. The people with pre-existing mental health problems may lack proper information and medical care. As we said, they are suffering within institution and in the community. And we also learned that diagnosis by itself is a poor predictor of vulnerability. In identifying people who are at higher risk, we need to consider a range of social factors and determinants which adds on diagnosis. Sometimes people with severe mental health problems are, in a way, reacting better than others, surprisingly, as has been demonstrated by many first-person accounts in the field of recovery research. The social gradient of mental health care, so thus, is reinforced by the current crisis, particularly poorest people, homeless people. Services should increase in reaction to that. More outreach care. And this means not just having more mobile services, but mobilizing resources of community, volunteers, neighborhoods, associations, churches or religious bodies, etc. I think it's also important to remind that there are wider targets in general population, older adults, women, which are affected, which are particularly taking care of their relatives affected by COVID or severe mental illness, but also by a worsening of domestic violence, which is a terrible situation being created by COVID, and this has an impact on mental health. We must take into account all these issues, including what happened with children and adolescents, which are suffering from the distraction from school, being locked down in family, disruption of social life, etc. So going to a conclusion, I think we must recognize that it's important to respond to this very severe social gradient of mental health and social justice, and fill the void that the pandemic has created around the person which are the most vulnerable. So this is a whole society task, a service imperative, and a political priority. Thus we need no more just individual responses, but a whole of society approach as a collective effort to tackle all these problems. In terms of developing services, it means avoid fragmentation. We need to join the alliances between public mental health care, social services, and third sectors, responding to whole life needs and protecting the human rights. COVID by itself so has been demonstrated, as Hans Kluge, the director of the World Health Organization in Europe, has denounced, an illness of inequality by itself, with concurring violations of human rights and related discrimination. And this is linked to power and participation of stakeholders. So the political issue and question is how to ensure participation in a situation that COVID has created of social distancing, of more marginalization. So thus we need a more effective societal approach. The World Mental Health Day this year was called Mental Health in an Unequal World. This reminds us that not just access to care is the problem. Of course, we know that there is a gap treatment, but all social and civil rights are now at stake. They are lacking for people with mental health issues around the globe. Inequalities exist in health as well as in economic and the social field, and these domains continuously interact and are worsened by stigma and discrimination. So there is, it's needed a huge effort to address these social determinants. This must be an effort of all international organizations, and of course, moving, as the United Nations Secretary General Gutierrez has declared, move from institution to community care is hurt by pandemic. That means also involvement and responsibility of all the subjects, not just a paternalistic top-down authoritarian approach. The new episteme that we have seen in Italy through the reform many years ago, and Franco Basaglia has anticipated, which is a person-centered paradigm, valuing the experience of a person as a social entity, of an individual as citizen, is the core of this new paradigm shift. It's not a paradigm of disease, but the person in the social context is very central. There are some principles in the services that can ensure that. Mainstreaming, co-production, we mentioned some of those. Let me summarize at the end. Equalities and participation, no coercion, work towards reducing the use of secure beds and units, so reducing coercion in general and in specific aspects, no long-term psychiatric hospital, and services must be fully community-based, proximity, community-based services, holistic approach, evidence-based and ethics. There is a coalition developed by the International Network, Collaborating Network, together with the WAPR and other international organizations, which is trying to respond to the big issues and actions for change related to these questions that I listed during the COVID. So we need to develop not just emergency action plans, but building up a new community mental health service, which provide the bridge toward a new normal, rights-based and person-centered, but also whole community approach. Investing in mental health and also having joining community mental health and the institutionalization is one of the things that can ensure the paradigm shift. So let me finish with this final slide. We need a shift particularly from a power on, a person subjected to power, that is typical of the relationship within the old and traditional psychiatry, through the pedagogy of power that Basaglia has invoked, toward empowerment and bottom-up power recognition. That means power with, sharing power, the power of the subjects, and a shift from individual to collective and community dimension. All of this can be called human rights today. Thank you very much.
Some questions about the very interesting presentation of Roberto Mezzina. If someone can ask.
Can you ask questions?
Hi, Solly. Hi, Roberto. Please, Solly. He's online. Solly, you can speak.
Thank you very much, Professor Mezzina. This is a very informative talk. I'm in South Africa, and the ideas you disseminated today are very applicable to the South African situation. But my understanding from your talk is that freedom is liberating and it's therapeutic. But the question that arises from that is the border between freedom and coercion in our active practice. Because sometimes we act in the best interests, as we think, of the patient and the family, but that is seen as coercive. How do we teach this approach of being free to allow people to make choices for themselves without coercing them to make these choices? Thank you.
Please, Roberto.
Yes, okay. Thank you. Rispondo adesso. Can I reply now, or it's okay?
Yes, please.
Okay, thank you. Thank you, Professor Ratamane. Well, I completely agree. It's a difficult task. Nonetheless, it's a very important one. So in our practice, we try to set up the principle, as I mentioned, of negotiation. That means recognizing the other as an entity in a relationship. Today, there is a lot of emphasis on an approach. It is called the open dialogue approach, based in Finland, and also spread across the world, which is based on the possibility of creating a circular discourse among all the actors engaged in a crisis or in a psychosocial crisis. And this is very important, but we cannot deny that we also have a social mandate as psychiatry, and this is very hard sometimes to bring people which are on the deviant side somehow in a relationship to the normal, which doesn't exist, but within to include them in the society through processes of care. In order to do that, I think the service is a good service can develop what I call a dialectic relationship rather than just open dialoguing relationship. That means offering something. Sometimes this offer is not just on the therapeutic side. This can be related to opportunities of social relationships, self-help, engaging in meaningful activities, if possible, occupation, if possible, social inclusion of different forms. So I think it's important to widen our view from the strict treatment options to a wider view that encompasses all the aspects of what I call whole life responses. I don't know if I gave some.
No, thank you very much. Thank you. That's me.
As well, Solly? Okay. Well, another question.
Thank you very much for a very interesting talk. Can I ask, I don't want to misunderstand you, but I think in a few places you mentioned no restraint, no coercion, etc. Do you really mean no restraint, never? Or are you saying that in patients who are really, really unwell and a danger to themselves and a danger to other people, they can be restrained or put in a locked ward, such as an intensive psychiatric care unit? So are you saying none of that should happen, or are you saying it should be kept for the most dangerous patients?
Well, I speak from my experience. Of course, I've been lucky because I had the whole career done in a place like Trieste, even if I had contacts with several services across the world. Well, our experience is it is possible to have this open door general framework. That means that people can easily access services, they can easily get care, they can enter in relationships very quickly. You can de-escalate crisis, you can have an earlier approach and engagement in care of the people. This is a very important point of start. On the other hand, therapeutic relationship must be based on trust and engage the social network. The approach made in this way proved that it's possible to abolish, let's say, 70–80% of forms of coercion. I would like to mention in our practice the limit of the use of drugs. Sometimes medication is a limit, sometimes used not just for therapeutic purpose per se, but to control a behavior. We have to admit that sometimes it's a limit. But the important issue is to start to talk again. The process of negotiation is a relentless process, must be done at any single time, not just entering into black holes. That means, okay, now we are in a coercion situation and we go on with coercion. We to try to regain the consent to care at any single moment that is possible. This is one of the things that has been prescribed by the Italian legislation, for instance. One of the revolution of the 1978 law, the Basaglia law, was not just to close psychiatric hospital, but to say that when you apply an involuntary treatment, you must go on continuing to try to achieve the consent to care on part of person which is submitted to coercion. So while our institutions are rigid boxes, the people are put there, you deprive the person because it's considered to be dangerous. But what is dangerousness? It's an attribute of the person, or is in a way an attribute of the situation, an attribute of the social conditions and the context in which the process of care has been displayed.
I think that's important. I think what you talk about is ideal, but I think there are situations, and I have members of my family who've suffered severe illness, and I think you have to balance the risks against society and against the individual, suicide, attacking other people, and sometimes killing several people. I think you have to balance the patient's rights against your duty as a doctor or as someone who works in mental health care to protect society. And I'm not talking about, I'm not a coercive psychiatrist, but you have to balance all these things. And I think you can never say no restraint, no coercion, no locked wards. And I think if you've worked in an intensive psychiatric care unit, or you've worked in a forensic ward, and you've seen the damage that can be done by mental health when it's not well controlled, whatever the reasons, whether it's the service has failed, whether psychiatrist has failed, whether the community or the government have failed, whatever the reasons for that are, you cannot say no restraint, no coercion, if that then leads to the person killing himself or killing other people or just seriously injuring other people. So it has to be balanced. And I think you have to think about risk and danger and controlling that as a pyramid. And yes, the patient's rights are important, but those who are at the top of the pyramid of danger, you may need coercion, and you will need coercion. That's inevitable.
I don't think it's inevitable. This is the difference between me and you, probably.
Have you worked in an intensive psychiatric care unit?
Yes. Well, I have experienced in any context, including forensic. We adopted a forensic open door service that proved to have the best results in overall the Italian new forensic services, for instance. It's possible to adopt a mindset that provides the recognition of the other in a relationship, sometimes conflictual relationship too. But our power is to intermediate all this tension and try to find solutions, not losing the alliance with the client. When the client is reduced to an object of care, you have lost the battle. That's the problem.
I disagree that by saving a patient from harming themselves or killing other people or injuring other people, you're not losing an alliance of care.
Okay.
You can do both. You can still be pardon?
No, you can save the person through relationships, not through lockdowns.
Well, right? You can have a good relationship with a patient and still protect them and protect other people with restraint, coercion, medication. But as soon as possible, take them out of that level of care, down to a lower level of care, and maintain a good relationship. I'm sorry, I have to disagree with what you're saying.
Many thanks. There is a question. Shahid Qureshi, Manchester.
My name is Shahid Qureshi. I'm a psychiatrist working in low secure unit, and I don't have a question, but a comment. I think I would totally agree with the colleague who was commenting. Whilst I do agree with you that there are times where we have to be careful not to be too restrictive, but keeping Human Rights Act into mind. But at the same time, there are people who needs to be treated and managed in a very controlled environment, without which, because as I mentioned, I work currently in a low secure unit. And if these people were not in a low secure unit setting, then they will be quite a risk to the society. And majority of them are not subjected to mental health act that we use as a civil mental health act, but they are subjected to Ministry of Justice conditions. So there's no, two-way views about that. I totally agree with you.
Can I also just say that I worked in a forensic community mental health service. I don't know how many of them there are in the world. Forensic community mental health service. And we and the consultants in charge did their best to keep those patients in the community, but they also had a locked ward, and they needed that locked ward. So that just shows you that patients and psychiatrists and mental health services can allow a flow up and down the level of coercion and restraint with the best will in the world to try and keep them informal. But thank you for allowing me to give those comments.
I disagree completely, but it's okay. We're in democracy.
Okay.
That's
okay.
Right. Yeah.
But we can conclude only one sentence about the experience of Trieste and Italy. I would like to suggest, that probably we are the situation where it's impossible to avoid the coercion procedures. But the question, the heart of the problem, I think, is to have an organization of the mental health services and a style of work that avoid to arrive to that situation. This is at the heart. Because sometimes it's impossible to avoid the coercion, but the possibility of reduction of coercion, open door, is to adopt an organization that the patients have immediately answers, and they are treated in a way that the dramatic situation, dramatic crisis, the aggression are avoided. This is the heart of the problem. Well, we can close the session. Many thanks, Roberto. He disappeared.
Thanks, Gabriele and everyone.
Many thanks, Roberto. Thanks to Dr. Mezzina. And we can move to the closing ceremony. Well.
Go ahead. Come up. So we start with the now remind you with Abu Dhabi. 3 years ago, I stood here, not here, in the podium in Madrid. I promised everyone that we are going to show you the Arabian hospitality when you're coming to Abu Dhabi. I wish that all of you were here, but unfortunately, Omicron prevented us from seeing you physically, but we are honored with your participation all over this very comprehensive Congress. There are some difficulties and challenges that we had, but we succeeded. We succeeded to have the most comprehensive Congress in the history of WAPR. This is the first Congress to be in the Middle East, the first Congress to be hybrid. We have 5,000 delegates online. We have 780 delegates physically. We have 200 speakers. We have 140 CME hours running concurrently. We have accreditation from European Commission of Education for 24 hours, which is more than the ECNB itself. They are, we have all these things, and better than this, we have a wonderful audience. We have great presidents, President-elect Gabriel Roca, President Morali, and past immediate President Ricardo. We have our Secretary General, Solomon. We have one of the most important presidents in Angelo Barabato, and I met him in 2012 in Milan, and they had one of the most important congresses there. Ricardo faced a very critical situation when he made the World Congress in Madrid, and I have the similar feeling for you. Of course, VK is always supporting to us. Pedro, Antonio, Maun, Michaela, Amring, thank you very much for all what you did. Barbara Davanzo, thank you very much. I would like to thank Rita Roncon because she did lots. She's not attending with us, but she did lots of support to all of us. Marit Borg and Michaelis, both of them, they supported me a lot in preparation of the presentations and in calling for support. I'm afraid I'm going to forget some of colleagues, but having Matthew Verghese as well as a treasurer with us, these are great moments. We have colleagues who came all the way to here one of the past presidents as well, Zebulon Tentur, he came with us here, Monique Moshero, Max Lashman, and all other colleagues who were supporting to us and coming physically to here. And right now, the last presenter, Dr. Ahmed Hanafi, is there. He shared with us in this. And imagine or not, till the last moment in this Congress, we have people interacting and are attending. And this is a real success. Our main message is to expand the WAPR concepts and to have this multi-disciplinary interaction and collaboration together. I'd like to thank all the audience who supported us, and many of them are here. They are really active in participation, and some of them are my colleagues in the hospital, my previous hospital. Now I'm working in private sector for the last 3 weeks, and can name them Adil Rawajda and Ratib Al-Abadi and Mahmoud Shaqla. And we have also one of our colleagues, Fatma. She's really active with us. So really, I appreciate all your support. And now I feel your feeling, Ricardo, that I have to take rest. Maybe I'll think again about organizing conferences, but definitely I'll be always there to serve WAPR and see me activities in WAPR and in the region. Thank you very much for all your support. And I think we'll give a chance to Gabriel Roca to say some word before we bought the video for Abu Dhabi Tourism, and then we hand over the flag, and I'll say goodbye to that conference. So please, Gabriel, if you would like to say something.
Can I just intervene, maybe, before we...
Of course.
There's a president, current president as well.
Sure, sure.
If we want to say something, because, sorry, a few words before we invite formally Gabriel Roca.
Yeah. So, Professor Morali, if you'd like to give some input. And
can you hear me, all friends, Secretary General, President-elect, immediate past President, and all our board members? I think I should formally congratulate Methat and his team for a wonderful conference, which is the first time as a hybrid in the history of WAPR. And I feel that the scientific programs which were organized had a real good mix of keynote as well as plenaries and guest lectures, posters, free papers, and workshops. And this is a very, very well organized scientific piece. That is one. The most important thing is that the number of participation across the world online has been extremely encouraging, and probably one of the really best participated WAPR congresses. And thanks to Methat and his team, and Khalid and his team, and Sandy has been doing an excellent work, and we all felt that it was really good. Now, I personally feel that I have missed coming there in person, but at the same time, the travel restrictions and issues like that, and this new variant. But we do not know when it is going to happen. The other two announcements which I would like to say is that usually along with the World Congress, we used to have the elections, which have not happened, and it will happen in February, and the dates and the last dates for the dues, all this will be immediately communicated to all of you, and please see that our next Congress bid has been opened, and we are yet to hear from people, and hopefully that's the reason that I requested Methat to hand over the flag to the President-elect Dr. Gabriela Roca. Thank you all for such a wonderful program, and I enjoyed, and we shall say 3 cheers to Medat.
I would like to thank Medat for his great effort. I understood his work when I arrived here in Abu Dhabi. It's an incredible congress, an incredible work and effort. And I hope that it is the first initiative with which we can restart as WAPR. We need to recover also as an association that during the last 2 years we suffered a lot. And then we need to restart and to try to promote our usual initiative and also the new initiatives. And then I would like to thank all the members of the board that are here, and this is a sign of participation, of support, and enthusiasm. Many thanks. We hope to start again.
So is this how the things are going? It's we have a very democratic organization. We have a pride to have so many presidents at the same time. So this is an example of how we are working together, and this is an example for the one of the best organizations I ever worked with. So I'm honored to be with you, and it's my pleasure to be a servant for WAPR at any moment the president asks me for. Now, remind you with Abu Dhabi. thanks for all the colleagues who supported me, and I'm asking them, all of them, to join us on the stage to take a group photo for MENA conference who supported us, for our colleagues who are attending for the last moment, and for the board members who are here and they did all the best to make
I would also urge the board members who are present virtually to join me in thanking Medhat for organizing such a wonderful conference. I can understand that it must have been difficult for you all to come and join here today, but it was extremely well. I mean, there are no words that I can express. So thank you, Medhat.
Thank you very much. Please come to the stage to take a group photo for MENA conference and colleagues. No, the flag is yours. Thank God I did my mission, and as a soldier in this organization under the presidency of Professor Morali, I am thanking all of you and all the best of luck, and God bless you all for all your support. You did a marvelous job. Thank you. And I can sleep tonight after this lengthy 3 years. Thank you very much, and see you soon, inshallah, physically.